Vakratun Mahakaya Su Om Ganganapataye Namo Namaha Shri Siddhi Vinayak Namo Namaha Ashtavinayak Namo Namaha Ganapati Bappa Moria Om Ganganapataye Namo Namaha Shri Siddhi Vinayak Namo Namaha Ashtavinayak Namo Namaha Ganapati Bappa Moria
गणपतये नमो नमः श्री सिद्धि विनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया
ॐ गणपतये नमो नमः श्रीसिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया।
अष्टविनायक नमो नमः गणपति बाप्पा।
ॐ गणपतये नमो नमः श्रीसिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया।
नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया।
ॐ गणपतये नमो नमः श्रीसिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया।
अष्टविनायक नमो नमः गणपति बाप्पा मोरया।
This this hello hello check this hello hello check this hello hello check this hello 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 check this hello 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 check this this hello 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 ha- hello hello check hello 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 mic check hello अभी आया। हेलो 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 माइक चेक। हेलो 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 माइक चेक माइक चेक माइक चेक।
ॐ गणपतये नमो नमः। श्रीसिद्धिविनायक
A very good morning to all of you present here. So I am Angana Chakrabarti from the marketing team of Epure, and it gives me an immense pleasure to welcome the esteemed faculty to this first of its kind initiative taken by Epure in partnership with Indian Stroke Association. The same will run across almost 6+ geographical locations all over India. The aim of this initiative is to create a learning platform aimed to skill healthcare professionals working at the peripheries in stroke identification and immediate management, which includes basic care, thrombolysis to reduce the incidences of stroke related complications, including death in the country. So, with no further ado, I would like to invite to the stage Indian Stroke Association members Dr. Nirmal Surya, President, Indian Stroke Association, Dr. Arvind Sharma, Secretary, ISA, Indian Stroke Association, Dr. M.V. Padma Srivastava, Past President, ISA, Indian Stroke Association, Dr. Amit Kulkarni, EC Member, Indian Stroke Association, Dr. Pramod Ojha, EC Member, Indian Stroke Association, Dr. Shipal Shah, EC Member of Indian Stroke Association, and the ABI dignitaries, Dr. Sanjay Patne, President of ABI, Dr. Anand, and also sorry to miss Dr. Anand Kulkarni, Secretary ABI, and Dr. Vatrambar for the lighting of the lamp. So, welcome all of you to the stage. I would also like to invite Dr. Makan to the stage.
वक्रतुण्ड महा ॐ गङ्गणपतये नमो नमः श्रीसिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया
नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया
ॐ गङ्गणपतये नमो नमः श्रीसिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया
अष्टविनायक नमो नमः गणपति बाप्पा मोरया
So now, with the blessings of the God, we would like to start the program. I would like to invite esteemed faculty Dr. Arvind Sharma to the stage for the further proceedings of the session. Thank you.
Thank you very much. And we are really honored to be here at Aurangabad. Beautiful weather. You have a jewelry here. We visited. Thank you very much. So, on behalf of ISA, we thank API for giving us this opportunity to be here on behalf of ISA. And I got just informed that there are 1,500 across who are on live at present online seeing this program, and we have near about 80 here who are attending it. So I would like to welcome our president of Indian Stroke Association, Dr. Nirmal Surya, to welcome you all.
Thank you, Arvind. Good morning, friends. Dr. Padma, Dr. Patni, Dr. Nagarkar, my members of the Stroke Association, and all the physicians and intensivists who are here as physically as well as online. As the president of Indian Stroke Association, it is a great pleasure for me to welcome you all in this city, which is a historical city now known as Sambhajinagar. And as Arvind mentioned, that one of the Jyotirling is here, so they have been blessed. Definitely. The CME today on the stroke care, I'm sure you all will like it. This is something which Indian Stroke Association want to impart to the future. As you all are aware that stroke is the third most leading cause of death and fourth most common cause of disability. And in India, the stroke is happening 10 years younger as compared to the other parts of the world. And compared to what we are getting the number of stroke, we are not being able, we are give the thrombolysis and that largely because of lack of awareness, lack of confidence. And we would like you to be more confident in dealing with patients. We need to create an awareness among the public because everybody knows that if I have a chest pain, I go to the IC and I get medically done. But when they get the weakness, they are not bothered. And therefore, I have labeled this as a brain attack so that they know that it is not just the brain impact. And we really need message this like time is brain. They need to go rightly to the right people. Right. I'm sure this one day for CME is also accredited by Maharashtra Medical. Thanks to the local doctors for the definitely help both physical as well as online. And those who are online, they can always send their questions and try and answer as many as possible. And I think this end of the day, you will get a not only the knowledge but also the confidence to impart the newer therapy to your patient who will be the that note, I once again welcome your
I would like to thank you very much for those words, Mr. President. I would like to call upon the President for API, Dr. Sanjay Patni, to take the
Good morning, friends. In the capacity as President of the Association, I would like to really thank this noble initiative taken by Stroke Academy. And because, friends, I'll tell you, I've been practicing for past 33 years, and my cardiologist friends have been successful in hammering in our patient mind that time is essential. The moment the patient has an attack or anything, you take him immediately to your guard. But what is true for heart is equally also true for the brain. In fact, more true for the brain because the investigative abilities of the brain are limited. And, there are limited knowledge also. So time is essence is what should be hammered to our patient. And I really, it's your humility, sir, that you praised us. But in fact, we are indebted to you for giving us this opportunity to learn, gain more insight on this important factor. One more gray area in this stroke management again is about rehabilitation. That's what I personally feel. Rehabilitation is something falls and injuries, post-stroke rehabilitation is something really very lots of surgeons from our place who had got stroke and fell down and had injury. Friends, apart from this small deviation, I like we are having elections for the positions of unfortunately, our association does not have any directory of our members who are members of API. I would take this opportunity to kindly call upon you to just let us know who all are members so that we know our exact number. Thank you so much, and I thank you.
Dr. Nirmal Surya, the president of Indian Stroke Association, to make that understand how brain attack make that possible.
As rightly we mentioned that I also I thought that the verdict of stroke doesn't give any value to the. Therefore, as an Indian Stroke Association president, I thought how I am a reach the- and I thought that let us give this mission a brain when we can talk about heart attack and back to the people. I thought brain attack might also give a they will think that it is something like heart attack linked with that. Therefore, with that thought, I started the mission brain attack and we launched our first program at Holy City again, one of the biggest facilities at Varanasi, and 13th May. We also have the place of our Prime Minister belongs from that place, the Chamber of Parliament, and it exactly we did one day before on 12th May. He filed his nomination of 14th May there. So we were escaped on that day. So what we are talking about, what is it? You can see that there is a beautiful logo. I tried to create. Mission brain attack. What we are trying to give what is the end-to-end care? It starts from the primary prevention. And all you know that primary prevention is important. Stress control of blood pressure, diabetes, basically regular exercise, walk, smoking, alcohol. So we give equal importance to that. Now, if you get a stroke, then the awareness about the past, how to recognize that this is a stroke, and once you recognize that this is a stroke, you should go to the nearest hospital to get and where there is a scan is available, once the CT scan be done, normal what required within 4.5 hours, can give the thrombolysis as all the cardiologists regularly, and I'm sure many of you are also heart attack without any fear. So if you have no fear by using the same medicine for the heart attack, why you have a fear of using the brain? I can understand that you may be scared that there are stroke, but at the moment the guideline is that if a patient has normal CT scan come with the symptoms of omnipresence, weakness. However, it is also important that if you have given the patient not you've done the MRI after you find that there is a large vessel of blood or there is a clot in the middle cerebral artery. You need to know that place go because within 6 to 12 hours, clot can be moved from the brain and patient can release that. And I'm sure in Aurangabad, you have a couple of people. Everyone is very much here. There's the we have people from Nashik. So you have people who are there. It's only you have to plan the right but in the right time. These people save the life. And it can completely change the life. I had patient with quadriplegia due to the visual artery thrombosis, and within 12 hours we remove the clot. They completely all right. Walk back, quadriplegia, walk home. So this is something can happen. However, you have done primary prevention, you have done the acute management, tried to some of the patients or large number of patients, what came came to you in 24 hours, after 24 hours, still have. So we give an equal importance as changing the concept of life. There is a lot of changes, and you will hear during the course of the day how rehabilitation life of people. I would talk about that. We want government also to understand that Mr. President, not just for acute or now, what is the impact of this? We had so far three programs. The first, as I launched uh, Varanasi. Then we had a second program at Jaipur in the first block, and there we focused the IMA people. They were very motivated, more active there. And then third program was in Bangalore during our pediatric stroke congress, where we promoted the brain attack. The fourth such session started by the. Now you will ask me, you have done, what is the impact? The impact in Varanasi, where it was led by 100 plus, that 3 physicians, and there are 6 patients that already. I want to see in next couple of months this to reach to the 1,000, 2,000, 5,000. Then really our all this success depends on you people. Take it seriously, as you all are aware of using this drug very much in the heart attack. I'm sure you can use it in the brain attack. And for any extent at any time, we are available. Dr. Padma has started telestroke 5 years ago in Haryana and Himachal. He has done hundreds and hundreds of policies just on the telestroke with the help of. So I'm sure this program will keen to do this, provide you support on the telestroke, help you out, save the life of patient so that we can use the receptor. I think with that note, I hope that Mr. Brain Attack take a priority. Government also take it seriously at some point of time, make it effective all across the country so that we can save many more lives. Thank you very much for being.
Hello, everybody. Good morning. And thank you, Nirmal Surya sir, for that effort on improving stroke care. We were to share this session. I would like to call upon Dr. Rahul Chaudhary. Please come on to the dais. Dr. Amol Kulkarni, come on to the dais. And Dr. Vilesh Vai. I would now request the chairperson to introduce the first speaker of the day, Dr. Arvind Sharma, who needs no introduction. I would like to the speakers take up.
Dr. Arvind Sharma, the MDDM neurology. Yes, he's head department of neurology. He has many public. He is president of Association of Gujarat, founder member and legislator of neurology. He is executive member of ANA, and he has many achievements and awards. Of which uh, Mancini Award, Mancini Award, American Society of Neurology 2007,
Very much there. And I think we are very late because one of the teacher is not there. And I'd like to thank the lady and as we have done in the Varanasi, Jaipur, as we said, we start first of all to look at what we are, what Indian burden is and what world burden is. It's not. So what the world burden is and what India is at present at this scenario, what amount of the treatment we are doing across India in the form of thrombolysis. I will not talk about thrombectomy because there are a lot of different we talk about. So we start the weekend, right? And we don't know. We are doctors. And this is what we do as a stroke neurologist every day. We come in the night, we go to the fire, and I tell you, it is enjoyable when we see people walk. And till date, those who have not gone to this fire, those who have not treated those patients, Dr. Basma correct me, nobody has been sued for the complication. But those who have not treated, they have been asked why they have not done it. The treatment is available, they have not. So this whole program is to empower the people. We are 30 to 35 years late, agree, in comparison to the cardiologist. But our person, Dr. Basma is here, Dr. Basma is there. We always set a precedent that we can take power, take thrombolysis, and we you at their place there. And it will be great that we are able to do it with this whole program. So, not to let all the players know about it, 35% are hemorrhagic, and we are here to talk about more about it. Because hemorrhagic gamut is another concept for living. And this is what the anatomical on the table, how the stroke look like, and everyone is worried about hypoxic gap, which are corrected for water intake. And you can see how the speed happens with the high blood pressure and the pressure. So, globally, there are 12.2 million new stroke reported, and 101 million people currently living experience stroke. And incident rate in India is average 138, 100,000. And India is the fourth leading cause of death and fifth cause of death. We know truth, but the more agonizing is the people living with it. Heart attack, you can have pain, you have a walking difficulty. I agree. You can have the shortness, but you are not able to do your activity dependent on others. It's more disheartening than what more than 50% of the stroke survivors have moderate to severe disease. So if you the stroke incidence in the rural and the area from India, that rural and the urban area, the rural registered were higher than the urban. And to be cumulative, that is 70% died in birth. And availability of the imaging and MRI was between 72 and it is, I think, after the COVID, that more and more scans are available at the level. But it is the wish and willingness of the treatment and knowing about how to treat, when to treat, when not to treat, which is time is a dilemma for us. And I think today that will be very much we make. This is what 1.8 million cases of stroke and stroke every as we already discussed about it. The last I want to spread, I want to get you more attention. That is less than 1% of our body. I'll give you the data. What are the numbers we are looking at? How the new drug has made an impact. Big problem, very small. So this is what the myth and reality is. People, Dr. has talked about the rehabilitation, the way because people still think that they have a stroke, the recovery stops up. And it is not. Neuronal plasticity, you all know. We have to engage the patient and their relatives. As we have a joint, uh, family living, not everyone go to the rehabilitation they can do the exercise. Many of they come to us and they do exercise at their home, but you can train them and they can not stop it within 6 months about the recovery. 2020, journalist asked me about on the World Stroke Day. I've given him the and what picture doesn't put the picture of put the picture of heart on World Stroke. This is what the awareness of the difference should have. And that is why press conference press right? So and this is what the awareness we did. 5,000 random people who entered our hospital and asked them about which stage happened, which organ pain happened. So you can see the person there are people who have wrong. Some said lung, some said kidney, some said heart. Heart is okay, but saying lung and kidney is for a layman is very wrong. If we are wrong at that part, that we are not creating that much of public awareness. So others are very much high. They are good. 9% they are not good. So it is a number the public where they don't know about where the stroke happens or not and what to do when it happens. There are a lot of things that are not available when it happens. So if you see the gap as we are talking about the for the severity of the stroke gap challenges stroke for the parent. Where are the challenges for the paper primary neurologists are now as a neurologist they are going to the healthcare and there are the various challenge levels at the level of lot of awareness about the they have a consent for the law and at the health to have a lack of education. Even the gadgets are available they are not staff and at the stroke professional level at the level they don't want to come in night. The stroke members they are competent but they are not motivated or so this is what I is having in my room also. So fireman job is risky, but your high blood pressure this is about the prevention. This is about the prevention of stroke. About the smoke. That are also a very risky job, but blood pressure, smoking, they are all same as the cardiac. They are not smoke. They are your blood pressure, your diabetes, and you have they all. But we know what our there are few like cancer. Coming to the stroke symptoms, it is always sudden. You all know about it, but I'll give you one example out of all. You know about trouble walk, you know about the balance, you know about the sudden headache, where the clap is there. But I'll talk to you about the sudden confusion and not able to hear about you. He went to a psychiatrist because he was not employed. That you married, right? So the CEO a lot of stress, married a lot of stress, right? So went to the psychiatrist, time was one day past, went to another psychiatrist. Came to our hospital, he has psychiatrist that he's not able to live. So we asked it that neurologist there you can so we asked him what is your so he started saying I live in Aurangabad, I do this. That was the jargon. So that was not been identified by the then we did an amount to have a right now I've been identified that have this have to identify the cause. Now the law has to identify the mechanism. We call it as which is very important. Not every that we have to identify that what we had. And he cannot go back to his own company to deliver his job because he's not able to. There comes the role of therapist and identify a cause. Did found out a cardiac cause for it. We treated it. 3 months was done a therapy. Vaishnu Devi and came back and he's still continuing as a CEO, and he has 2 children. So marriage was happy, right? It was not a stress. It was a stroke. Not everything is stress. That's what I want to mention. So we'll go further because I have only 20 minutes and time is not there. So time is always up there. So can you start timer there, please? Yeah. So so recognize the stroke symptoms. This is what the mnemonic is, which you can keep in your physician chamber, so people will know about the balance: eye, face, arm, speech, and time. Stroke type. This is another slide. When I went for a stroke fellowship, one of our stroke neurologist mentor, Ken Butcher, always show these 2 slides to the residents. These are the stroke types, and he says those 30% of the cryptogenic stroke, you have to identify a cause as a stroke neurologist, otherwise you stop practicing. Because we all know atherosclerotic cardioembolic, but if you don't run after why the patient had a stroke, he will some other disease, and we all know that after the stroke, next is MI. And after the MI, after a few years, all the studies have shown you have stroke. So you have to identify the risk factors, you identify which type of anticoagulant, antiplatelet patient has to given. So this is what he presents. 60-year-old gentleman. It's the same slide I'm presenting. Hypertension 180, 110. Residents sitting in the neurology and the MD resident also were in the class. Few of them raised their hand. It's a bleed. And then he showed this CT. And he told never guess type of the stroke. Because if it's a high blood pressure, vomiting, headache, it can be a ischemic stroke. Second, he showed a decompensated 140/80. There was a bleed. The second thing he said to us, never predict type of a stroke. Don't give heparin or don't give aspirin before CT scan. Because as a physician, you can say in your forum also, CT scan is equal to ECG for MI. For a stroke, it is CT scan. CT scan should be done before giving any treatment. Because when I came to Ahmedabad also, there were general physicians who asked, chances तो 15% ही है ना, एस्पिरिन देके भेजेंगे आपके पास, क्लोपिडोग्रेल देके भेजेंगे. So those are not the recommendations, because as we take an oath, we cannot harm the patient for this. If you see time is brain, this is what the age accelerated for stroke patient, average stroke 36 years. For 1 minute it is 3.1 week, and for 1 hour you age about 3.6 years. So time matters. And if you see, number also matters. It is not like that 4.5 hours. Recently, Dr. Padma, down in the breakfast, we were talking about a new trial has come with the tenecteplase from 4.5 to 24 hours. So nobody know that what number, how that number has come. But this number says if you treat less than equal to 90 minutes, you need number needed to treat only 4 to 5. But if you go higher up, your number needed to treat become more. So patient coming to you within 30 minutes, don't wait for 4.5 hours. You treat them immediately. What we use the evaluation scale at our place. This is what we use. We use the NIHSS score. We use the emergency physician chart for a checklist where the basic all the vitals are there. We have code white at our place, and these are the all the measures which we use as MRS. That's a disability scale. We want from 0 to 2, where there is a very minimal disability. We don't want our patient to be between 4 or 5, where they are lying in the bed. And NIHS is for the severity. There are limitations on tube, but it is a good score for identifying, and you don't need stethoscope and a hammer to do NIHSS. So this is, I will not go in detail. You can read in the book from 0 to 42. Severe one come between 5 to 20. And this is what the modified ranking scale I was talking about. Slight disability till 2, and 3 to 5 are the most disabled one, and nobody want their patient should die. Time is the biggest challenge. We all know that. We cannot recycle time. And this is what it's a famous graph for us, where you see how it narrows down for 4.5 hours. And it is not because of the hemorrhage. Remember, it is the Poon analysis has showed it is not as the time increases, the hemorrhage is more, but you loses that penumbra, the benign oligemia, where you can save that part of the brain. That is most important. The reason which you may have faced this, they don't recognize symptoms. There is a denial. They think nothing can be done, and they are very positive. हाथ दब गया नीचे, इसलिए झंझनाटी हो रही थी और हाथ पैर में कमजोरी थी. इवन जनरल फिजिशियन भी कह देते हैं कि थोड़ी देर वेट करो, ठीक हो जाएगा. बट वो थोड़ी देर वेट में वो स्ट्रोक कंप्लीट हो जाता है, जिसे इवोल्यूशन ऑफ स्ट्रोक कहते हैं. व्हाट आई मीन टू से दैट, एंड वी शुड नॉट वेक इफ इट इज going up and down also, because it will complete in stroke. Think symptoms will disappear in fever of the hospital, even the cost of the hospital, and we all know the cost is less than a PAMI. if you see, and if you see what they are doing as a plasty here in the brain is worth doing it because the cost is much higher. A word mention about the TIA because it is very important, and I call it as a take immediate action because it is just like unstable angina. Because 70% within 90 days, within first week, develop a great risk as a stroke. And it is very important to identify the mechanism of the stroke. And you are lucky, you are very good, 5 minutes में stroke ठीक हो गया, we'll put you on aspirin. Not like this. You have to think about the neck. Everything goes below the neck. You have to do the carotid vertebral Doppler. We have carotid vertebral Doppler in our health checkup, and we tell our cardiothoracic surgeon to do, when they are doing angio, they should do the carotids also when they are treating the patient, because this is also vascular, 20 to 25% of the, and it's a stroke management is not a single man job, it's a team job. We need so many people to treat that if you are having a tertiary care, and if you are at a secondary care, you can have only a CT scan, there you can do the thrombolysis. So it team effort with measure, and it is that the protocol, the pathway, which is very important. I will let you know what Indian Stroke Association is doing about it, and this all gamut what you need to treat the patient. And this is what the hemorrhagic and the protocol is. There are thrombolysis will be talked about, thrombectomy will be talked about. I will not go into detail, but these are the protocols which are very important. This is what protocol we are following at our place. These are the people, directly phone call goes to them, and they are on call. They have to reach and they have to tell about. And creatinine is not a value which we see. We say neurons are major than nephrons, and nephrologists agree they will do the dialysis after that if needed. So it is a stroke unit to turn chaos into the order. If you have a system in place, everything can be done. And these are all the drugs. Among them, Altiplase and the tenecteplase are the two drugs which has come in picture, which will be discussed. I will tell you how the pre-notification help you for a patient to be treated in within time, how fast you can be. He's the orthopedic surgeon. At 2 a.m., everything is sluggish in the West or India. You don't tell that India has that. Even I worked in West, I know that how 2 a.m. is there. So if somebody notify you, CT brain doesn't show any early changes, aspect score 10 means brain is absolutely fine. And there was a plaque in the neck. Came at 2, reached emergency 2:30. Altiplase was started 2:55. We have done before this also. I'm showing because how pre-notification helped us 25 minutes, door to onset to needle was 55 minutes. Because he informed us, the radiologist was also ready and everyone was ready, and patient improved and had only my pronator drift. And I think I'm talking about 2010-11, and he went with 1,60,000 of the bill on his treatment. I think that is worthy, and he still is there in US and doing his work. And this is what the time window you are looking. And if you have a proper system in place, you can tell the pathologist, you can tell everyone, and no need of asking them to get the report. It will automatically be stamped and come. So this is what the analogy is. Time is brain, time lost is the brain lost. So rush to the nearest hospital with the CT scan facility, 4.5 hours, and a spot a brain stroke. And you have to create more than 100 people about that awareness, spot a stroke and save a life. And this is what the journey of the thrombolysis is from 1995 when it was approved, and it was licensed in India in 2005. Then subsequently, there were more than 1,000 centers in 2022 for stroke ready. And this is what the thrombolysis rate with the Altiplase in 2023, 12,000 in a year. It should be 20 lakhs in a year. If you see the numbers, what we are doing is very low. This is the state-wise thrombolysis numbers. You can see how less numbers in certain areas like Orissa, Bihar, and Uttarakhand. And after the tenecteplase is also approved, the 50,000 has increased to 27,000 in the thrombolysis rate across that year. And that is what it is, but it's still very less. And if you see the mismatch among the neurointerventionists, you have, I think, 2 or 3 in Aurangabad, but if you go across India, they are very less, and you can see the few spots there, how many stroke interventionists are there, and we promote more and more stroke neurologists to become the interventionists. I'll just give you a word about the accreditation program which we are running on the Stroke Association with Quality Accreditation India. Quality Accreditation Institute of India. And what they are doing, the advanced center are applying for the those who have the cath lab for the advanced stroke center. But we are more, and we are very delighted to say that recently we got the first primary stroke center approved at Thrur in Chennai, in Tamil Nadu. So it's a round of applause for the first primary center got accredited, and will push the physician to apply for primary stroke center if they are doing the thrombolysis. They need only CT scan and they need only a neurophysician on call to help them to do the thrombolysis. And they are well enough to do the thrombolysis. And more centers who have CT scan can become a primary stroke center. And it's a very good accreditation program. You can, like NABH, you can get your hospital accredited QI that, and they know that the stroke is treated here. And this is what the whole form is, the self-assessment. And if you need any help, Indian Stroke Association can help you in doing it. And this is the first center last year in March. We have, after that, more than 80 centers are already advanced stroke centers. This was first Dr. Vijay Center at Guntur got the advanced stroke certification. And here there are many others who are in the application. Telestroke, I will not go much. That is another thing which physician can take a help of a neurologist if they don't have it. That can be like a rural comprehensive and the physician program. The future of stroke is in your hands, the family physicians and the physician, right? And it is a work spouse wife. It is written there. It is a work spouse balance. Don't get everywhere wife. So it is very important. The 4R of stroke care is right time, right place, right imaging, right drug. People are treating with the off-label drugs in periphery. People come with different boxes like retiplays and other plays, and they are treating and doing the thrombolysis, but they should know which are approved across India. Still, time is brain. That is the most important thing which is there, and it is the biggest obstacle which you know. But more and more areas where the treatment is done, I think more and more benefit of the patient. World, Canada, US, they are doing 20% of the patient. They are also not doing 80% of the stroke which are coming to them. They are doing 20%. We are doing less than 1%. If we start doing 2 to 3%, 5% initial target of that, we will be a much better country and stroke-free country if we see. Thank you very much for the patient listening.
Thank you, sir, for your nice presentation. And it's all depend upon the treating physician whether he has prepared himself for identify these kind of stroke symptoms and uh, whether he's having facility of doing CT scan. So as you rightly said that for cardiologist it is a ECG is a basic investigation, and for neurologist or treating patient of stroke, it's a CT brain is a basic investigation. And to identify, usually the relative and patient is are in denial mode that they might tell you that different kind of symptoms he's under stress and he's having some sort of neuropathy, but it's treating physician's duty to identify stroke symptoms. He has to have a positive threshold to identify this, and one should investigate in that manner. Thank you.
Very rightly, sir. Sir, very nice presentation, and you are excellently explained the epidemiology and how is the load of the stroke in the society. So as we are working in medical college, beyond this, what we are doing here is we generated a stroke helpline number. And second thing is in hospital, suppose someone come in ED with acute stroke, we are generating code, stroke code like code blue. So it's like something emergency happening in the hospital, and all part team members and the department like CT scan or MRI, ED people or IC people, lift even also, they get alert that we at any time will get the patient. So this will help definitely to decrease the drug to needle time, and that will help in hospital management about the stroke patient.
Very rightly said. I will really appreciate that comment. In medical college, we'll give them a round of applause. They have a stroke helpline, and it is a big thing, stroke helpline and having a code stroke at your place. And that is what matters, stroke pathway. If you have a stroke pathway in place, even you go with your closed eyes, you can do everything. Nobody is asked, CT scan kholo, ye pathology ka la do, ye report la do. If you have everything in place, as you said, that is what is important in stroke, because it is the process. Because patient comes, you do the vitals, you do the sugar also, then you send the patient to the CT, then you thrombolize or do a thrombectomy. Cath lab, I tell you, the cath lab, our neurointerventionist is there, but the cath lab technician is not there. So that's the will if you develop the pathway.
Yeah, very correct, sir. Let me share my own experience in our hospital. Since when we started this code stroke, I can tell you the last patient we thrombolized in 20 minutes.
Wow.
When patient reached the hospital, in 20 minutes we thrombolize the patient. And really it's a wonder to see the patient who came with symptoms and walking away completely normal. So this code stroke is a very important thing. And as you said, code stroke pathway is to be displayed. So this really helps. I can tell you from my own experience.
Very
Thank
good.
you, sir.
You should get your hospital accredited. Yeah.
I have two more questions. Just I'll take one of that. As a chairperson, it's my duty to take these questions. I think this will be covered in next few talks. The one question is, why can't we angio catheters through the main vessel and try to suck out the clot and seal? I don't know who asked this.
I think that will be very well
Yes.
explained by Dr.
Yes.
Pandurang and others who are doing this. Yeah.
And next question is, why can't we have minimal hole surgery with computer controlled and seal the bleed? That is for. I think that will be covered.
Yeah.
Yes. Intervention. Thank you, sir, for its
With this,
excellent presentation.
I thank Dr. Arvind Sharma, sir, for an excellent presentation, and I would like to thank all the three chairpersons. Now it's my responsibility to request the three chairpersons to hand over the memento to Dr. Arvind Sharma, to facilitate Dr. Arvind Sharma. And I would like to thank API Aurangabad chapter for these fragrant flowers that they have brought. Um, it's making the hall very fragrant. I would now like to invite Dr. Rajesh Sethia. Sir, are you there? Dr. Rajesh Sethia, to hand over the mementos to the chairpersons. Dr. Rahul Chaudhary, Dr. Amol Kulkarni, and Dr. Milind Vaishnav. I thank the three chairpersons for this session. As we move on to the next session, Dr. Salil Uppal is not available today. He could not travel to Aurangabad today. So we will skip that topic and we move over to the next topic, which is diagnostic imaging in stroke. And for this, I would like to call upon the two chairpersons, Dr. Govind Vaijwade and Dr. Rajesh Shah. Sir, please come on to the dais. So I would like to call upon to the dais the speaker of today's session, which is Dr. Shripal Shah from Nasik. And I would request the chairpersons to introduce Dr. Shripal Shah. Thank you.
Hello, hello. Yeah, I would like to introduce the speaker, Dr. Shripal Shah. He is an MD DM neurology from Bangalore, and FINR from KEM, and he is head of department since April 22 at Sahyadri Super Speciality Hospital, Nashik. He has multiple publications. He has special interest in stroke, interventional neurology, interventional neuroradiology, endovascular neurosurgery, and vascular neurology. He the first interventional neurologist in North Maharashtra and actively and independently performed both diagnostic and therapeutic procedures. Specialized in mechanical thrombectomy for acute ischemic stroke, carotid and vertebral angioplasty, stenting, intracranial stenting, cerebral aneurysm coiling, AVM embolization, preoperative embolization of the CNS tumor. Over to Dr. Shah.
Thank you, sir. Thanks for the kind introduction. Good morning, all. So, after we have discussed the stroke pathway and symptoms, how to diagnose a stroke clinically, now we have to go and radiologically try to diagnose. So, neuroimaging is a very important aspect in acute ischemic stroke. So CT and MRI over last 20 years have made a paradigm shift towards the diagnosis of stroke, management of stroke, and accordingly thrombolysis and thrombectomy has helped us to definitely be the game changer in acute ischemic stroke treatment. So why neuroimaging in stroke is important? So what are the goals? Establish a diagnosis as early as possible, guide appropriate treatment by location assessment and size of territory involved, assess possibility of reversibility of lesion. So we have to rule out stroke mimics in our casualty also. Is it a mimic, not a stroke? Rule out hemorrhage also and obtain accurate information about the intracranial vasculature and brain perfusion for guidance of appropriate therapy. So what are the imaging 4 P's which are required for us to understand? One is parenchyma, second is pipes, third is perfusion, and fourth is penumbra. So parenchyma helps us to understand which brain parenchymal area is involved and hemorrhage is ruled out. Secondly, pipe is vasculature. It is the extracranial and intracranial vasculature of the brain, which will help us to understand if there is a stenosis, thrombosis, or a stenosis with a thrombus. Third is perfusion. How much is the tissue which is viable will be seen on perfusion and the penumbra. Both will help us to understand which are the dying tissues and which are the tissues which are viable for recovery. So this is what we have to understand in our imaging. So if we see the brain parenchyma, the dead tissue, what we are seeing, the normal blood flow is 50 to 55 ml per 100 grams per minute. And the dead tissue occurs or infarcted zone when the blood volume is less than 10 ml. So what we are going to understand, which is the ischemic penumbra, which is salvageable. So every second counts. For example, a patient comes immediately to our center and there is a right MCA territory stroke and left hemiparesis. This is the dead tissue which is involved. And this is the parenchyma, which ischemic penumbra is there, which is salvageable. As the time is lost, again if we see after 6 hours, still within first 4.5 hours, early we intervene or thrombolize or do a thrombectomy, then definitely the salvageable tissue would be there. But if after 24 hours we see, there will be a large territory of infected tissue and the penumbra is still there, but the time may have been lost. So every second counts on it. So which are the imaging modalities? See, there are so many pathways which are mentioned in trials, books, everywhere. It doesn't matter. What matters to us is what is best in our scenario. We should always see that. म्हणजे मी एकदम प्रॅक्टिकल आहे की आपल्या परिस्थितीत व्हॉट इज द बेस्ट पाथवे वी कॅन यूज इज व्हेरी इम्पॉर्टंट. ओके, सो वी हॅव अ CT and we have an MRI. From the CT we have to go for a CT angio and CTP, or a MRI based pathway with a MRI with a MR angio of the neck and brain, and if required perfusion. So these are the two only pathways for acute ischemic stroke. So let's see which will help us in diagnosing for acute ischemic stroke treatment. So everyone knows the role of CT scan in assessment of stroke should be performed immediately or at least within an hour of presentation. At least it rules out a hemorrhage. So in any scenario, if we don't have an MRI nearby, please do a CT scan. CT scan rules out a hemorrhage. It reliable, cost-effective means of assessment and cornerstone for imaging. That is CT scan for us. But there are limitations to it, which I'll come to it later. So what we can see on the CT scan, multiple areas what we see for in a anterior circulation. We see for the MCA territory, subcortical areas, lentiform nucleus, capsules, thalamus, anywhere anything is there. So on a CT scan, we have to see the brain is gray, white matter is usually dark and the gray matter is usually bit light gray. So the early signs what we see is hypodense or hyperdense. So hyperdense is what we see hypodense is always because of the infarcted tissue, which may not be seen early on a CT scan, but it can be seen, or edema or necrosis. Hyperdense is always white. White is always blood, calcium, most of it which can be seen, or mucus secretions. So sinuses. So what I feel is at least we rule out a blood or a infarcted tissue if seen on a CT. Not possible. So what are the early signs of ischemic stroke on a CT sign you can pick up? One is hypoattenuation of the brain tissue, obscuration of the lentiform nucleus, dense MCA sign, and insular ribbon sign. I'll just go through it. So what is hypoattenuation of the brain tissue? If you see this brain tissue on the right hemispherical zone, it is a within 6 hours of the onset of the stroke, you are seeing a hypodensity in the right MCA territory, which is known as hypoattenuation of the brain tissue. It may be an early sign of a evolving right MCA territory infarct, which may be picked up on the CT. What is another sign if we can pick up all? See, loss of gray matter differentiation, which is seen on the left side. So this may be seen early in stage of a 2 to 3 hours of onset of a stroke. That is obscuration of the lentiform nucleus. This is the lentiform nucleus obscuration, which is compared to the opposite side. Early sign of a left MCA territory stroke, which can be picked up. What is insular ribbon sign? This is the insular cortex, what we are seeing, right insular cortex. And this is the white arrow, which is showing obscuration of the posterior part of the right lentiform nucleus. And this may be also early sign of a infarcted area, which we can see. So these are signs which we can pick on CT as an early sign for a MCA territory stroke. Again, what is dense MCA sign? We see a CT scan, and if we see a dense area involving the MCA, so this is a blood clot which is there in the MCA. Definitely it mentions or shows it is a large vessel occlusion or a thrombus which is there in the MCA territory. If we do a CT angio, we see a cutoff at this location also. Now, if we are doing a CT, every patient, do we do a CT angiography in our practice? Ideally, we are doing a MR based practice or a CT based here? CT based. But everywhere you are doing a CT angiography? Not possible. Two reasons: contrast, secondly, cost, third is time. What? So, even if we see these things on a plain CT, we can go ahead with thrombolysis. Okay. If we see a large territory involvement, then we can think of, I'll come to it later. But when you are suspecting the high NIHS and CT scan showing some changes, but you feel there may be a large vessel occlusion, then you can go for a angiography immediately, CT angiography, which can help us to pick up if there is a large vessel like a LVO involving the ICA, MCA or a basilar which can be occluded. Okay. So it helps to see the circle of Willis and guide appropriate therapy like intervention, mechanical thrombectomy or IV thrombolysis. Plus it can help us to prognosticate the patient also. Is he going to, the relatives, is he going to improve or he may worsen within few hours also. So So this is a patient with a thrombus, what I had shown. Again, the CT angiography showing total occlusion of the MCA, and there are no collaterals. So CT angio helps in our practice, but mostly our practice is MR based, what we are seeing. So I'll come to it. But CT angiography in acute setting also helps if we are taking for thrombectomies or something. And we can see the collaterals also in the CT. Good collaterals have a good prognosis. They are slow progressors. Intermediate collaterals, if there is a MCA occlusion, collaterals are less, what are seen on multiphasic CT, and a poor collaterals in a right MCA territory, where you can see their collaterals are very poor, so they are fast progressors. So if we can make out collaterals on a CT angio, then also it helps us to understand, is this patient going to worsen early or no. So one CT angiography with CT scan, are we ready to do? Yes, if it helps us for the location, the artery which is involved, do we require intervention and for the prognostication? Otherwise, no. Only CT scan is also helpful for our thrombolysis. CT perfusion, everyone mentions about CT perfusion in lots of trials, but in our clinical practice, very difficult to do. We don't have good technicians. We don't have good radiologists to report these perfusions. Secondly, cost. Third, it is only helpful. It is after beyond window period. Or if we want to see the ischemic penumbra, then we'll do perfusion and later on imaging. So after 6 hours of stroke, if we want to go ahead even with IV thrombolysis or mechanical thrombectomy up to 24 hours, these are the modalities we should think of to be done. Otherwise, initially we may avoid it. So if this is a perfusion imaging, what we are seeing, a decreased blood volume is seen, and there is a large area which may get involved later. So it helps to differentiate that there is a salvageable tissue which is there. But this may be only helpful if we are not going to do initially any treatment. After 6 hours, it will help. So most of this modalities should be used only if when required, but only a plain CT is helpful for us in initial time window, just to help immediately to take any decisions. So what is important clinical application of a CT? That is very important. We used to always been taught 1/3 of the territory of the MCA involved, that is frontal, parietal, or a temporal lobe and the basal ganglia. So 1/3 purely poorly defined area which is involved. So that says it is a large MCA territory, more than 1/3 involved. So prognostication may be not good after IV thrombolysis. So later on, there was a Alberta stroke program early CT score known as aspect score, which came into picture, and everywhere the aspect score was introduced, and it is the good quantitative score for good outcomes and bad outcomes in a patient with early thrombolysis. So we are seeing the MCA territory. This is the M1, M2, M3, caudate nucleus, internal capsule, lentiform nucleus, and insular cortex. And this is M4, M5, M6, supraganglionic and ganglionic level. If the aspects is, I'll come to the aspects. If the aspects is 10, so no territory is involved, early ischemic changes are not seen, so patient is going to do a good clinical recovery. If the aspects is getting involved more, like the infarcted size keeps on increasing in the MCA territory, the outcomes may be poor, or then rather the infarct is a bigger size infarct. So as the aspect is less than 7, so definitely it shows that it is going to be a big territory involvement on the CT. But mind you, in 15% of our acute strokes, we may get hemorrhagic strokes also. So anyway, CT scan is going to help us to find out hypertensive bleeds, non-hypertensive bleeds like AVMs, angiomas, CVTs, bleeding disorders, tumors, trauma. So even a CT is going to help us in stroke mimics, ICH, subarachnoid hemorrhage because of aneurysmal rupture, subdurals and extradural hematomas. And that definitely sites also most of us have been taught in hypertensive bleeds. So coming to conclusion of a CT, where to use? Non-contrast CT, it excludes the bleed and differentiate ischemic from hemorrhagic, identify stroke mimics also, arterial occlusions or early signs of infarctions also can be picked up, and diagnosis of SAH can be also done on a CT. CT angio, definitely vessel occlusions, so pipes can be seen over on a CT angio, and definitely if SH is there, aneurysmals can be picked up. And CTP, again to quantify and help if penumbral imaging is required or more than 6 hours, go for CTP. Coming to MRI, so MRI has been the game changer for thrombolysis and thrombectomies also. Diffusion weighted MRI made things much better because the pickup rate was as early as 10 to 15 minutes in MRI, and brainstem involvement, which cannot be seen on CT, is picked up very early on the MRI. And again, MRI negative strokes, which we see very often after 2 days, again has been picked up on MRI. So helps in detection of infarction, exclusion of hemorrhage. Again, occlusion sites can be seen and provides a differential diagnosis also. And accuracy is very high. I'll come to it. So what is a fast stroke protocol for MRI? In our center, when I joined, the MRI was done in 45 minutes. 45 minutes with a MRI angio. So I have reduced it to 14 minutes now with a MRI angio and only 6 minutes with brain screening. I don't do whole MRI. We do a diffusion, we do a flare, and we do a GRE. Nothing else. That takes 6 minutes to me. And with a angio, it takes 8 minutes. It is 14 to 16 minutes roughly. So that is the stroke protocol we use in MRI. It helps for parenchyma. It looks for vessel occlusion. Perfusion, we don't do it. Perfusion, we are not able to do it. Technicians are not good. More than 6 hours. Definitely I do a DSA or then ASL we do. I'll come to it, arterial spin labeling. So advantages of MRI. Although CT is most commonly used modality, MRI has its own superiority. Early sensitivity in pickup of definitely a diffusion restriction, absence of radiation, and also helpful in delineating a ischemic penumbra when there is a discrepancy. So DWI imaging, so Brownian movement was used, water molecules definitely within living tissue, but dead tissue, water molecules again because of the cytotoxic edema restriction is there, and there is a diffusion restriction. So this is a large diffusion restriction in right cerebellar hemisphere. This has been picked up within few seconds to 2 minutes. So these are various MRIs, left PCA territory, bilateral ACA, and the MCA territory, diffusion restriction. So DWI is a game changer. So changes in DWI within 30 minutes of onset of ischemia, but it has to be corresponding to the ADC maps. When this is white on diffusion, it should be black on ADC. So that is acute. If diffusion is white and ADC is also white, it is not acute, it is subacute, 1 to 4 weeks. And if diffusion is alone, cannot be used as white, and if patient had a black ADC and a white, black on diffusion and white, so it is showing chronicity. It is ulta, it is not white. So this is how it can pick up. 95% we see hyperintense on diffusion and hypointense on ADC. This is very important. So this is how you will find out. This is diffusion restriction on right MCA territory, superior division, and this is ADC reversal. Again, we see flare. Why flare is important? If there is a flare restriction, same patient, if we are seeing flare imaging, it is more than 6 hours. So do we thrombolize these patients? No, because flare is showing definitely already the infarcted tissue, more than 6 hours. So flare imaging is going to help us only positive in 30 to 50% in first 4 hours. Okay. So flare positivity by 7 hours following symptoms onset. So flare is also important to us. And lastly, we see flare diffusion mismatch. Negative flare, positive diffusion. So definitely it is early infarct, and these patients are best to be thrombolized because it is less than 6 hours. Quick indicator, for example, this is a MCA subcortical area and flare is not showing any black or any changes, early changes. So definitely it is a viable and less than 4.5 to 6 hours, eligible for thrombolysis. Now we see GRE also. So what we see is diffusion, ADC, corresponding, second is flare and GRE. That's all. That is what is required in acute MRI to be seen. GRE definitely is for hemoglobin deoxygenation or hemosiderin cuts. It helps us to see any blood is there, any blooming is there in acute stage. So if there is a blooming or this is a blooming sign, this is a dense MCA seen on a GRE also. So there is a thrombus which can be seen, clot burden also, and length of the clot also can be seen. Sometimes we miss small strokes on a CT scan also. पेशंट म्हणतो एका पायाच्या हातापायांच्या मुंग्या येतात, एक बाजू जड झालेली. We do a CT, it is negative. Sometimes we do a MRI, it is negative. But sometimes we repeat it, there is a small thalamic infarct which is seen. So we may miss a small perforator stroke which is in the thalamus or a capsule or a paramedian pontine area. These are all negative stroke ischemic. Last 5 minutes, 2 minutes. So MR angio also for vessel occlusion. This is a stroke protocol we should use, and accuracy is very high for diffusion, sensitivity and specificity. But false negative diffusion can be small strokes also, which may you have to repeat after 48 hours and see. Lastly, I'll not go into perfusion. And what is the pathway to finish with? Diffusion, flare, MR angio. If required, perfusion or don't do perfusion. Perfusion only after 6 hours up to 24 hours, and GRE for diagnosis of any bleed. So this is the pathway we should follow. CT if required, no CT, go for MRI, but with angiogram, and just always check the vessels also, or a Doppler carotid later. Thank you.
Thank you, Dr. Shah. You have nicely explained the sequence of diagnostic modalities which you should do.
Yes.
I always have an apprehension about TIA. Means if suppose patient has TIA, then how means just on CT will you?
No, sir. So there was a American Association guidelines for TIA, and their MRI is the gold standard to be used, because TIA, MRI negative is always a TIA, but TIA with MRI positive diffusion restriction, it is a minor stroke. It is not a TIA. So always we should do a MRI with a angiogram, MR angiogram as a protocol for a TIA patient.
Yeah, so means
CT will not pick up, sir.
so previously what we were taught that CT negative and MRI positive then
Yes, sir.
only give stroke. Is that does
Yes,
it
sir.
still hold? Good.
Yeah. Diffusion restriction makes it as a minor stroke. It is not a TIA considered, sir. With a vessel involvement, still it becomes a difficult situation because it may worsen into a full-blown stroke, sir. So that is a early sign to pick up, sir, in a TIA.
Wake up strokes.
MRI, sir.
And incidence, how much, sir? We as a
Sir, in a wake-up stroke, why MRI? I'll tell you. Because as an interventionist or a person who wants to thrombolyze, will see a flare image also there. So if flare is showing on wake-up stroke, there is already a infarcted area. So very difficult to say. So it has a more than 6 hours. Secondly, if infarcted area is not seen bright on flare, then definitely it is less than 6 hours.
You mean to say that we should go for flare first?
No, not flare. MRI images, MRI sequences, sir. I feel CT may not help, or sometimes CT may show also, sir.
So, Dr. Shah, can I say that if you have CT and MRI both available, always do MRI first?
Sir, not like that. It depends upon the time of onset also and what you are expecting also. Large area involvement, NIHS score being high, blood pressures being high, patient is drowsy, you feel it may be a hemorrhagic stroke, go for a CT. If not, then go for an MRI. If depending if both are available, we should take accordingly, sir.
Thank you.
But one protocol has to be strict to, sir. Otherwise, what happens? It doesn't get customized or systemized, sir.
So start with CT and then.
Or then MRI is also. Sometimes we shift over from MRI to CT immediately and say, "Arey, it's something different." Thank you.
Thank you, Dr. Shripal Shah, for a wonderful talk. I would now like to the chairpersons to felicitate Dr. Shripal Shah. I would request Dr. Umesh Raite. Dr. Umesh Raite, sir, is he there? Is Dr. Umesh Raite there? Okay. Uh, yeah. So I would like to request Dr. Umesh Raite to felicitate our chairpersons, Dr. Govind Vajvade and Dr. Rajesh Shah. I would like to thank Dr. Jyoti Kulkarni for participating as an NMC observer in this CME. And I would now like to request Dr. Jyoti Kulkarni to come onto the dais, please. Thank you, madam. I would like to request Dr. Sanjay Patne to come and felicitate Dr. Jyoti Kulkarni. Dr. Sanjay Patne, please. Okay. I would request her to come onto the dais and felicitate Dr. Jyoti Kulkarni. Thank you, madam. We would now like to move on to the next talk. And to chair this talk, I would like to request Dr. Vinod Gosavi and Dr. Sanjay Patne to come on to the dais. And I would request Madam Dr. Padma Srivastava to speak on this topic. Madam really needs no introduction. I would still request both the chairpersons, Dr. Vinod Gosavi and Dr. Sanjay Patne, to introduce Dr. M.V. Padma, Madam. Thank you.
Hello, good morning, everybody. We have a very esteemed guest, Dr. M.V. Padma Srivastava. I was going through a CV and it's really so impressive. She is a professor and HOD of neurosciences at AIMS, and she has done a lot of work, more than 200 publications to date. And apart from organizing various national, international conferences and symposia on cerebrovascular disorders, she is also instrumental in formulating the India Stroke Guidelines. I think this is more prestigious, India Stroke Guidelines. And she has been awarded as the Padma Shri by the President of India, recipient of the prestigious Vimla Veermani Oration, and there are a lot many awards. I won't go through all this. But what impresses me more than apart from all these credentials is her pioneering work on telestroke that I was told by Dr. Surya that she has pioneered the telestroke movement in North India. I think that's more prestigious and more valuable for us physicians here. Thank you, madam. Please go ahead.
Thank you so much. And it's really an honor and pleasure to be here. Can I have the first slide, please? Silent. Yeah, so this is my first time in Aurangabad, and I was listening to the talks earlier. I mean, there have been stalwarts who've been given this, but then I also listened to the comments, and then you already have thrombolysis going on by the physicians. So some of it is probably like carrying coal to Newcastle, but then I'll try to be just tell you the update of the intravenous thrombolysis. And so I'm not giving you the Indian data, which has already been given by Arvind and very nicely. But let me just, have no disclosures. And we already been through this. This time is brain, and every minute which is lost is zillions and trillions of neurons which are lost forever. So unless we have more Dr. Nirmals, in the world, we're not going to get this rehabilitation up and going. That's really a neglected part. So when you're looking at a patient who's come to an emergency, and then you, it's very well, Shripal has told you that when you're assessing someone with an acute stroke, you're not spending too much of time. And so maybe everything is running in vertical in parallel. You're also taking the history, you're also wheeling in the patients to imaging, and what is in your face is probably is what really strikes. The NIHS is doing that. Will take you full 30 minutes. We're not doing that. Everything is done vertical, and it's quickly. When did you notice? Did anybody see you? And get onto a plain CT. And there are only two basic tests which are done. Take the blood pressure and take the point of care, blood sugar. That's how we've actually been established this acute stroke program thrombolysis in a small little place in Himachal, Dr. Nirmal has alluded to, and that was in April 2014. If there is time, I'll tell you a story about how we actually launched that. So that's the rapid neurological assessment. NIHS is less than 10 minutes flat. And essentially, this is going to be covered probably in the next lecture. So again, I'm not getting into that. Yes, you need all of that, and the most unglamorous part of a stroke management remains a stroke unit, not talked about, because you don't really talk about how you're going to position the patient, what's the blood pressure, what's the blood sugar. All of us know about it, but very seldom done. And that's actually the game changer beyond all the glamorous tests we talk about is IV and EVT. It's essentially simple positioning and taking care of BT blood pressure, not getting the infection, taking care of the DVT part of it, and just fluid electrolyte balance. We all think that we know and that someone else will do it. They don't do that. And that's a stroke unit care. So this has already been done. Now, quickly coming to IV thrombolysis. So let's get into all the guidelines. I haven't put in the Indian stroke guidelines because they've also been updated recently in November 2022, which we released, and it's actually online and you can access those. So less than 4.5 hours, more than 4.5 hours. So within 4.5 hours, the age is now 16 years. It was 18 years. So following this later on with the essentially the stroke registry data, not huge number of meta-analysis, that they've actually reduced the age now to 16, so that's legal. And then you have the upper age limit of 80 years has been removed. And how many of you will you will agree with me that age is just a number, isn't it? You're old as you feel you are, correct? So we have 80 plus running as a president for United States. So I don't think age matters. So you need to be a good age. That's it. So this is out of the window. In fact, the meta-analysis said it is pretty safe, and we have 80 plus who rule countries, so that's fine with us. So then we also have two good lytic agents. Right? I really think that this has been the game changer, at least for Indian subcontinent. We've, Arvind has put up the kind of, it's an Amazonian advance in numbers of thrombolysis. And also this been kicked off after the COVID era. In COVID time, it made sense that you had an lytic agent which you just needed to push instead of giving as an infusion over 1 hour. You had the green corridors. So I think that's where it really kicked off. And India was the first, the country to approve tenectic place. If you know about that, and now it's actually got into the UNESCO guidelines as well, and the government of India has approved the tenectic plays up till 4.5 hours, and probably we'll also be trying 4.5 to 24 hours, thanks to some of the recent things. And alteplase dose reduction is not recommended, although there's been a lot of data which came in from the far eastern part of the world where they said 0.6, but somehow it hasn't come up to the level of evidence that you can dole it out, that yes, you can do it. But practically, when I started the thrombolysis program from AIMS, which actually had been the first public sector to start thrombolysis, and there we did not have the luxury of a 20 milligram vial. We just had 50. And I really had to have a trade-off of opening up another 50 milligrams for another 5 mg more. So a lot of it, in fact, that averaged out to 0.7, but I'm not going to go public about that. I just did. Anyhow, so that's where it is. You need to balance out, and sometimes, jugaad works for India. Actually, it happened yesterday, isn't it? Day before yesterday, when the whole of the world shut down after that IT problem. So, and then the thrombolysis, in case you have a lot of early ischemic changes, please, you have guidelines to guide, but each patient is an individual. You need to balance out the risk benefit ratio for that particular individual. Okay, so only when you have everything dead and gone, you're not obviously going to thrombolyze, and that's a no-brainer. Now, beyond 4.5 hours, which are non-selected, that means those you do not have very, all this huge advanced technology which is at your disposal. Now we have in the guidelines that when you're looking at a basilar artery occlusion, you still cannot, you even beyond 4 hours and within 24 hours, without advanced imaging, you can do IV thrombolysis. That's because basilar artery occlusion is such a devastating stroke. You have 80% mortality and morbidity, possibly because of that, and also because of, just remember, this is actually coming to the guidelines in 2024. So, and then, the aspects is scoring, which essentially roughly tells you where you are headed towards a severity of stroke. So 10 on 10 is great. But then in RCTs, where you have aspects which are less than 6, and a lot of EVT trials have that, you consider the other the other things. Like, what is a pre-stroke state? I mean, is that guy advanced cancer and he has an MRS of 5, he's bedridden, frailty, and also there the age of, say, he's a 92-year-old, he's frail. Now, look at those aspects, and then you would consider being much more aggressive. And 4.5 to 9 hours, so the wake up strokes, you do have a lot of data which has come in. And whether you're talking of European or the other guidelines, advanced brain imaging comes in here. And you had this wonderful talk. Shripal has given you both CT and MR based. And there have been always these debates whether should I do CT or MRI, just depending on, I may have MGH is entirely, they look at the MR based. And there's a Beth Israel protocol with all CT based. Now my center now is all MR based. But in AIMS, we had both CT and MR, so it was just practical. So just depending upon whatever you have, you can do that. You have guidance over both of them. And so now we know the wake up strokes, and within 9 hours from the onset or having known, you can definitely initiate if there is a mismatch. And then even the mismatches are a lot of them. It's very difficult to remember these numbers. No one does. You either have those wonderful labs, which are humongously expensive, which people use, and a lot of southern part of India does that. But then roughly it is like you can have a CT clinical mismatch. That is, the patient is drowsy, and then you have plain CT, which is normal. You either have a stroke which is very early and the guy has damn good collaterals, which is saving the brain, or it is a stroke plus something else, or it is not a stroke at all. You have a hypoglycemia, you have a postictal issues, or you have, something else happening. So that's a huge red flag. In fact, when in the telestroke, when we asked the physicians to come on board for in Himachal, and the Himachal story happened because it was a top-down approach because one of the chief secretaries had a stroke, and then even when they airlifted the chief secretary to Chandigarh PGI, the time was lost. So you actually have, ambassadors who you choose, and you also have ambassadors for things they had a stroke, and then they become sort of champions to get the wheel running. So in that, we always told the physicians that red flags, if the patient is drowsy, don't get into thrombolysis because it is much more than your checklist, right? So the mismatches could be just clinical CT, or it could be that you have the most common thing that we use is a diffusion flare mismatch, which has been told to you. But then doing a perfusion is extremely tough. You need a contrast. And a lot of times we don't do that. So common things right now are diffusion flare mismatch, but you only have a CT with you, is a plain CT, and you have all other parameters which are coming okay. That means a guy is not drowsy. Okay. But then otherwise, the theoretically or textbook wise, when you have to teach, then these are all the radiological parameters which tell you about mismatch. And this is what has been used in most of the major trials which have garnered the inclusion into the guidelines. So you have the diffusion flare mismatch, which has been used even in the wake-up stroke, and that's the reason Shripal was telling you, sir, that in a wake-up, you get the MR protocol in. And when you said the incidence of having a wake-up strokes is almost 1/5. It's just like MIs, that for some reason you have more hypercoagulability in the early hours. So, the same thing, the circadian rhythm. And there's also this guideline now which has come in that it's a large artery and you have immediately thrombolized unless the patients had a attack while on the cardiac table, and during an intervention you always bridge. You probably there's a consensus that if you have a hub and spoke, you give the IV and then thrombolize to your hub or the region where you can do the EVT, or even in a patient in a comprehensive stroke center, you're both of them available in the ER, you getting the IV and shifting to the patient into the cath lab for EVT. So that's where current guideline exists. Maybe it changes, but it's okay. But there is in the CSC as such, do we really have a consensus? May not be, but in my practice, I always start IV. I do believe IV has a role even when you are bridging, because it reaches those parts where the EVT cannot go and even beyond EVT. So I do believe that we should bridge. So the Tenictic place and Altiplace both have come on board equally, and I do think there was a clinical equipoise once, but I don't think there's an equipoise now. I do believe that this molecule has an edge over a lot of areas. So the tenecteplase in India has been approved in way back by the DCGI with a dose of 0.2, but the current guidelines says 0.25. And the international guidelines also go on to 0.25. And it is the umbrella or the spectrum where you actually being given this medication is probably expanding as we speak. Altiplase is definitely there, but then the altiplase guys are also trying to go beyond the 4.5 hours. We have some evidence up till 9 hours. It hasn't come into a guideline. But the areas where you have a very minor stroke, those are the situations wherein we still have to get some more the evidence for tenectic place, some evidence in altiplase, simply because it's been there for a long, long time, even before tenectic place. So at this point, the expert consensus also says that now this is this is just not, I do believe that it is an alternative, but also for a developing world, especially us, I think tenectic places probably definitely has an edge. And I think most of you are also using tenectic place, if I know correctly, right? So most of those are there. And this is where the stroke of one tone, I mean, this is where I've already told you about it. And then we have the contraindications. And then, when you first had the IV thrombolysis, that was a publication by the NINS trial, 1995. You had a whole lot listed up there why you should not be treating a stroke patient. And that was essentially an expert based thing, because the biggest bugbear, of which, if I have time, I'll tell you a little bit about why people still don't thrombolize. The biggest bugbear is bleed in the brain. But then the contraindications included something which is mild, don't thrombolize, very severe, don't thrombolize, and extensive, and go on and so forth. So you have all these things there, and people have thought, out of the box, and we know now that the contraindications, if they exist for IV thrombolysis, obviously you're not going to thrombolize a bleed in the brain, so you're not going into hemorrhagic stroke, quickly ruled out by just a plain CT scan, which remains, in spite of all those, advances, the workhorse would still be a plain CT scan. And yes, you have to be concerned about the blood pressure. In fact, the single most important parameter which will definitely improve your stroke outcome is maintaining an optimal blood pressure. You have your BP controlled, you will prevent a bleed, you will prevent another stroke, you will prevent a re-occlusion, you will prevent early death, in fact, a stroke recurrence, and your entire stroke outcome. One single parameter is a high blood pressure. So have your BP under control. You should have it less than 180 by 110. And please, obviously, you're not actively thrombolizing a mimic, which is hypoglycemia. Other than that, unless the patient is in your face chronic liver disease, chronic kidney disease, is on anticoagulants, there's really no other contraindication for IV thrombolysis. And that's why we got this, monkey proof checklist for the physicians when we first got the telestroke guidelines up there. Okay, so the other thing is, you have a premorbid disability, you have to obviously consider, but a lumbar puncture and a malignancy with a survival of more than 6 months, those would not remain, and or most of them are hypercoagulable conditions. And the eye disease and a sickle disease, well, you see, they say that get your ophthalmologist on board. But when you have a stroke which is hemorrhagic, had happened in the past, now there was, my very good friend Dr. Subhash Kaul always says there is a Mr. Lucky and a Mr. Unlucky. So both of them have hypertension and diabetes, and both smoke like chimneys. And then one of them had a huge hemorrhagic stroke, the other had a small lacoon stroke and survived. All right, so we don't know really, and we probably come down to genomics and proteomics as to what really predisposes someone to have a bleed versus. And moreover, all of them also predisposed to MI, and it's one body. So there's nothing which says that you had a hemorrhagic stroke because of hypertension, a small thalamic bleed. The person is not going to get an acute MI. He will be. I'm going to ignore that, please. So, okay. So therefore, I do believe that you will need a prophylaxis of antiplatelets. And if that, and the worst is when they also have an atrial fibrillation and needs an anticoagulant on board. So therefore, now when you have a hemorrhagic stroke, you wait for 6 months and then start them on antiplatelets. And that's probably not come as a level 1 evidence, but that's a consensus guideline and a practical solution. But for IV thrombolysis, if it is a small bleed more than 3 months ago, go ahead and IV thrombolize. But you're not going to get that as a guideline. But if you have a massive bleed, and more importantly is an SDH, and I'll come quickly to that. So therefore, again, we don't have patients who read textbooks and come to you. There will always be difficult situations and practically. So unknown late onset, I'm not getting to that. As I told you, there are these clinically useful mismatch. This has already been talked about. And the number needed to treat in wake-up stroke is 9. Not too bad. Can any one of, most of you physicians tell me the number needed to treat in a acute MI to give thrombolysis? Please. All of you give thrombolysis for acute MI. Tell me the number needed to treat. Anyone? It's 43. Go and Google it and look up. And here we are talking about thrombolysis and acute ischemic stroke of within 3 hours is 4 to 5, 7, 9. And even in wake-up strokes is number 9 in mismatch. Please look at the biological effect of this, okay? Minor and severe strokes, to me, a stroke is a stroke is a stroke. If there is a right hand, a little disability, or there is a little facial paralysis, little slur in speech, then I just could be one. It's disabling. So for me, there is nothing like a minor stroke. To me, a stroke is a stroke. I'm going to thrombolize. And there is my good friend who is Pooja, who's actually done the PRISM study and said, don't thrombolize. She also agrees with me, actually. Those studies, some studies are just statistics. So stroke mimics, don't go and actively thrombolize a hypoglycemia. The whole lot of parrots there. But then if it's taking a lot of time to prove it's a mimic, then don't wait and go and thrombolize. Very young, very old, we already said that. It's 16 years. And in a very old patient, depends upon the frailty and disability which exists pre-stroke. So that's where we are about that. Now the bleeding risk from cerebral pathologies, quickly. If it is a subacute clinical ischemic stroke less than 6 weeks, it's okay if it is small. And silent subacute leukoariosis, what have you, especially when you do an MR base, you'll have a whole lot of stuff happening there. Don't worry, go ahead. Subarachnoid hemorrhage, which is totally treated, you can. And hypertensive ICH still remains relative. Subdural hematoma, that's a big problem there. Okay. If it is a major trauma related, it's okay. But if it is not spontaneous SDH, be very, very careful. Cerebral microbleeds more than 10, you should not be thrombolizing. Malignancy, I've told you. Intracranial malignancy is obviously again a no-brainer. You will not thrombolize. This is where we are for asymptomatic aneurysms, which may be picked up. Less than 10 millimeters, you can. 10 to 25, get the guy on board, the interventionalist and the neuroradiology. More than 25, don't thrombolize. These are the asymptomatic guys. AVMs and cabanoma, no thrombolysis, but when you have a DVA and capillary telangiectasia, so it's picked up on an MR, you can thrombolize. Now, what the aspirin and the things, now, a lot of them are on aspirin. Don't worry, go ahead and thrombolize. Double antiplatelets, clopidogrel is still okay, but ticagrelol, which is a very common thing right now, a lot of our cardiac guys are on that. Be careful, that can be a thrombolysis issue. Roughly, when you have a lot of NOACs, now you have a lot of rivaroxaban, apixaban on board. We don't have edoxaban. So we do not have this thrombin time and factor 10A assays. That's not practical. To me, it's not sine qua non, but roughly what I do is when it's a dabigatran, I use APTT. You can get that as a point of care. And all the bands, that's rivaroxaban, apixaban, it's PTINR. Again, you have a point of care system. Now, that's not a completely scientific way of seeing things, but then we have to do jugaad. Otherwise, we have to have some practical solutions, and that's what I do. And of course, you know that the drug is taken 48 hours before, go ahead and thrombolize. This is important. It's a dengue season. Get the platelets. And especially in COVID, this was very important because platelets less than 1 lakh is a big red flag. Less than 50, do not thrombolize. Okay. And then systemic diseases and interventions, bleeding daxis, obviously aortic dissection. You're not going to thrombolize on those situations. Active bleeding, you can't control, don't thrombolize. Everywhere you can secure hemostasis, you can thrombolize. Okay. Cardiac conditions, in earlier, we always have this insert that you have an acute MI, don't thrombolize. So if you have an acute stroke, don't thrombolize for an MI. That's obsolete. Okay. And if there is an acute MI and you have an acute stroke, which can happen, and they come to you in emergency, then the dose you choose is for stroke. Remember those things. And other situations, I think I'll quickly I'm going to skip all this. And the only thing I'm going to touch about is this SICH. And the way you need to actually prevent that is, this is what people are worried about when you thrombolize, that there are all these bleeds, but you don't need to do it. And the ENDs, early neurological deterioration within the first 24 hours, is what we would be worried about. But there are a lot of risk scores. I'm not going to get into that either. Management is going to be cumbersome. So the best way to prevent those issues would be, proper selection would be there, of course. So you should know your guidelines. Risk factors, most important is get your blood pressure and don't get your glycemic, that means don't have high glucose. And then do not vanish from the scene after you start thrombolysis or you pushed it. That's the only thing. You have a regular BP control and your sugars, proper positioning, and look out for an early deterioration. You can actually prevent. And if you look at this would actually tell you what's happening earlier, the risk of the symptomatic intracranial bleed is that's what we're worried about, not little bleeds which you can pick up on the brain. In that, the earlier ones were the ones which had a 6%, that, but if you look at all the recent trials, including there is a 0%. So you do not have too much happening as you have advanced in your experience and have better gadgets of monitoring. So don't be, excessively worried about these things. I think I'll stop here. I've already taken a lot of time. Thank you.
Thank you, madam. Your clarity of ideas probably stems from the extensive work you have done, and I'm very sure my physician friends from whole of Marathwada will benefit from this. Madam, as a practicing physician, I have a small doubt, if I am permitted to ask. Madam, howsoever you may emphasize that the incidence is zero in latest studies, we as practicing physicians still have the lingering fear of hemorrhagic transformation. So I was wondering whether low dose, that is what we attempted to do, low dose altiplase would be equally effective as in your experience, I don't know. But that's the safest way we go ahead, though the 90 days mortality is almost same in this group. I was wondering whether, and that is important. And second thing is, ma'am, initiation of aspirin after thrombolysis.
Yeah, so excellent question, sir. So one is that we do have the zero 0.6 milligram per kilogram body weight of alteplase is already there in Japanese guidelines. So, but the thing is with us, we probably have a borrowed system, and the other is the kind of the jugaad that we have to do to be able to, balance out the biggest elephant in the room is finances. Because 70%, in spite of the fact that, both these agents are free, by the government of India in some of the district hospitals. I don't think it percolated down to the entire country. And we had a huge, war against. Did you know that Ayushman version 1 didn't include stroke into neurology? We didn't have neurology in Ayushman. Did you know that? So then, meanwhile, I rushed to Dr. Vinod, Dr. Paul, because he was just next door to me at that time. And they said, look, Ayushman doesn't have stroke. So then Ayushman 2 came in and still didn't figure. The stroke was enlisted under the medical emergencies and 4,500 rupees a day. Whether you thrombolize, you didn't thrombolize, you do what have you. It was ridiculous. Finally, Ayushman 3, there were a lot of extensive meetings and we got stroke include that. And with a lot of, we had private guys or public sector guys, because 70% care is private. You can't have a same yardstick and say like, look, this is the only amount that can be done under Ayushman. And then when it went to PGI, and the finances wing, that committee was looking into PGI, and then they said that it's somewhere it's got diluted again. So I think in EVTs you still have IVT still an issue. So therefore, when you're looking at a cost factor, then some of the times practically we get the dose down, not according to guideline, and not because it will cause less bleed. Now, even for tenectic place, it is zero 0.2 and not 0.25, but international is 0.25, and our latest guidelines said 0.25. Technically speaking, though, the intracranial hemorrhage part of it don't seem to be really that bad when you are within the guidelines of 4.5. The problem is beyond the 4.5. That is where I think when you're looking at a mismatch and you're going ahead with it, that you sometimes have that. And I completely understand, and I haven't touched about remote bleeds. I didn't much talk about the bleed will happen. We are only concerned about parenchymal hematomas, grade 1 and grade 2, which are symptomatic and cause early neurological deterioration. But we've had more litigations and cases coming to us that you did not thrombolize, and not because there was a bleed after thrombolysis. Please remember that part of it. And according to guidelines, you don't even need to take a consent within the given 4.5 hours to thrombolize, what we always do. Now I'm in the private sector, I'm doing it. But in names, we never did because in the guidelines, you didn't have. So understand your point. But and then to manage, the SICH, the symptomatic bleed, we do not have high-end PCCs. We don't have 3 and 4. It's difficult. They're very expensive. So what do? We still use FFPs. We still use platelets when the platelets are down in those clinical situations. And to get the neurosurgeons on board when something is bleeding is tough. So you always undercover, you try to get them. So it is a problem when there is a big bleeds, but most bleeds are not big. And most often SICH is not big. So that is where, and well, every big treatment has a flip side.
Yeah, thank you,
That's
madam,
there.
for your wonderful talk. Just a practical question: what is your experience of getting bleeding risk with tenictyplase and alteplase? Because most of the times, as we are always talking about financial issues, we are choosing tenictyplase. So, what is your practical experience of the bleeding risk of tenictyplase versus alteplase?
No, actually, with tenectic plays, I really haven't found too much happening. Didn't have too much happening with altiplace either. But the tenic place actually has, it practically it's a push and you are okay, and then you're monitoring. There are people who actually argue that look, you're pushing, so therefore you've given everything, so you can't even contain it. That there's a 1 hour slow infusion, there's something happening, you can stop that. But that practically didn't really transform to that kind of a situation. Head to head, I don't have data to tell you, nor is there a great publication. But in the stroke subtypes, though, in terms of recanalization and the hemorrhagic risk, tenetic place had an edge over altiplase
And
in
about
the studies. And the practical, during COVID and beyond COVID, is the ACT trial, which the Bijoy and all had done from the Canadian Stroke Network. The bleed risk was in percentage lesser than altiplase in with tenictic place. Angioedema is about 1%. That 0.1% is what they say. I have never seen, but there was one case which, when we were talking about it, some of the individuals in the southern part they found it's on the opposite side of the tongue. It swells up. Very rarely it is causing respiratory issues. Most often than not, it subsides with it's actually it's not anaphylactic. It's anaphylactoid reaction. So it's okay. It is treatable, but you should know about it, but very rarely encounter.
Ma'am, since you are talking about government guidelines, Ayushman and Jugaad, I want to ask you, CT is available in Maharashtra, every district hospital has a CT. But a man who is practicing in Taluka place. So what does government want to tell to this? You see a patient, you ask every one of them to go and do a CT. Instead, we don't have a contraindication of getting aspirin, we can thrombolyze. So why can't we promote give aspirin unless patient is say so much bad or GCS more than 20, 25? Because these people are going to go to quacks. I'm sure in Aurangabad, everywhere there are quacks. So since you are in guiding government and this thing, I feel it's my suggestion. Okay, fine. Cardiologists give aspirin, clopidogrel. No harm in giving at least aspirin. So what is our stand of ISA, or for that matter, what is your personal opinion on this? How can you guide government on this?
Thank you so much. That's a wonderful question. So there was an international stroke trial which actually had done. I mean, this is pretty old trial of 40,000 patients, where the one of the groups actually had given aspirin without actually doing a plain CT and documenting there was a bleed. And there was another group with aspirin and also Clexane in combination. Both the groups didn't do well. And so the international guidelines actually say that you should not be taking that risk of doing a plain CT. And then, without even doing a plain CT and giving aspirin. But then I understand what you're practically, trying to say. So in lot of the states that when we have, there are states in this country where it is almost 70% public sector. And there are, of course, states which are 90% is only private sector. So Himachal is one where it is mostly public sector. The very few private players. There are 12 districts. Two districts are Spiti and the Lahore, where you just can't enter them. The 10 districts, all the district hospitals have a plain CT. Some of them have white elephants. So the first thing was to get them functional. And what most people were doing is that they would be CT, and the CT would be analyzed by an outsourced person. And that's where also they were getting into trouble. So there we had actually given what I actually call as a monkey it. You don't take one, don't give it. So that kind of a protocol, and it was a top-down thing, getting this 10 districts, CMOs and others. And again, it was a top-down approach driven by the health ministry. It worked and it is still working. And then it went on to Haryana. All of those they have to have a plain CT.
We are
A
behind
lot
schedule,
of
ma'am.
clinical guidelines have come, but they're really not able to differentiate hemorrhagic and so I think at this point, don't give antiplatelets without a plain CT.
Thank you, madam. We are behind schedule. That's why.
Please take
Cut
this.
down.
I would now thank you, madam, for a wonderful talk. I'd like to invite the chairpersons. I would like to invite the chairpersons to felicitate Padma Shri, Dr. M.V. Padma, madam. Thank you, madam. I would like to invite Dr. Manu Pagare. Dr. Manu, is he there? Yeah. I would like him to felicitate the chairpersons, Dr. Vinod Gosavi and Dr. Sanjay Patne. Thank you, chairpersons. I would like to announce the next topic, which is mechanical thrombectomy. And for this, I would like to invite the chairpersons, Dr. Tushar Chudiwal and Dr. Satish Solanke. Dr. Tushar Chudiwal and Dr. Satish Solanke to come onto the dais, please. And the speaker for this session is Dr. Pandurang Vattamvar, also the host of today's program.
I think we all know Dr. Pandurang Vattamvar. He's a very busy practitioner, neurophysician of Aurangabad, very dynamic. I think we'll not waste time in introduction. You can go ahead.
Thank you so much. We have seen the treatment for acute ischemic stroke. That is the most important is uh, intravenous IV thrombolysis. But as we have discussed, ma'am has also told, IV thrombolysis has become a standard care for patients with acute ischemic stroke, but there are certain limitations. So limitations is narrow therapeutic window. That is up to 4.5 hours it can be given, but what about afterwards? So there are different imaging criterias are there. It is IV thrombolysis is also contraindicated in certain situations like recent major surgery or if patient has IC bleed in the past or patient is on anticoagulation and many others. And we have seen in many studies that when patient presents with acute ischemic stroke because of large vessel occlusion, the rate of recanalization with IV thrombolysis is about 20 to 30%, not more than that. So in such cases, what should be done? So I will go through different cases which we have treated and what is the current evidence for that treatment and what are the current guidelines. So coming to first case, 48-year-old male presented with acute onset weakness in left upper limb and lower limb since 7:30 a.m. He reached our hospital by 12:30 a.m. There were no past medical illness. He had left hemiplegia grade 0. NHS score was 13. So he was definitely out of window period 5 hours after the onset of the symptoms. This was diffusion weighted MRI. It showed right MCA acute infarct, and MR angio showed right MCA total occlusion. So in this situation, what should be done? Anybody would like to answer? So patient is with acute ischemic stroke out of window period. So, what should be done? IV thrombolysis is definitely out of question. Now mechanical thrombectomy. So what is the current evidence at present? So the after publications like 5 big trials which have been published in 2015, the mechanical thrombectomy has become standard care treatment patients with acute ischemic stroke because of large vessel occlusion, especially IC and M1 occlusion. And its efficacy over IV thrombolysis has been proven beyond doubt. So these are the 5 big trials which has been published around 2015. These are Mr. Clean, Swift Prime, Escape, Extend I, Revascat, and these are the 5 big trial which has proven that mechanical thrombectomy endovascular treatment is is beneficial after IV thrombolysis in patients with acute ischemic stroke with large vessel occlusion. And Hermes collaboration was the meta-analysis of the data of all these 5 big trials. So I will not go much detail into these clinical trials, but I will go briefly. The Mr. Clean trial, this trial was done to prove the clinical efficacy of intra-arterial treatment in proximal intracranial arterial occlusion, like yeah, ICA or MCA. So in this trial, 500 patients were enrolled, and out of which 233 patients were randomized to intra-arterial therapy. Of these 233, 190 patients underwent mechanical thrombectomy with stent retrieval. And the results of this study concluded that patients with acute ischemic stroke because of large vessel occlusion, yeah, intra-arterial treatment, that is mechanical thrombectomy, if performed within 6 hours, has been beneficial after IV thrombolysis as compared to the best medical treatment. So this is the next trial, Swift Prime. Uh, the result of this study also were quite similar, and the study was stopped early because of proven efficacy. This is a escape trial. Also, this study was also stopped early because of efficacy. And all this study, we are studying the effect of mechanical thrombectomy within 6 hours. Revascat trial was a trial which studied the efficacy of mechanical thrombectomy up to 8 hours after the onset of the symptoms. So that has also proven efficacious in patients with acute ischemic stroke because of large vessel occlusion. And this is extent I, and this was a meta-analysis. So in this Hermes trial, the subgroup analysis after the adjustment for age, sex, baseline stroke severity, that is NHS score, site of occlusion, whether it was IC occlusion, M1 or M2, whether the patient has received IV thrombolysis before going for endovascular treatment or not, baseline aspect score, we have seen what is aspect score, and time from the onset to the randomization. This where the subgroup analysis was done, and in these patients, total 1287 patients were included, and in this subgroup analysis also, it was found that endovascular thrombectomy was is of benefit to most of these patients with acute ischemic stroke with large vessel occlusion. So there is no doubt now. What is the evidence is there? A lot of evidence is there. So in this patient, what we did is we immediately took patient for the to the cath lab. DSA was done. DSA showed right MCA total occlusion. After discussion with the relatives, we went ahead for mechanical thrombectomy with stent retrieval. So here we can see the stent retrieval was crossed across the occluded segment of the MCA, and after 2 passes, there was complete recanalization of right MCA. So 5th day, patient was discharged with minimal deficits. There was mild left upper limb weakness. So when we can offer mechanical thrombectomy? So in these patients with large vessel occlusion, that is distal ICA or M1 occlusion, age more than 18, pre-stroke MRI score either 0 or 1, NIHSS score more than or equal to 6, aspect score more than or equal to 6, and if treatment can be initiated within 6 hours from the onset of the symptom, that means Gran puncture can be taken within 6 hours from the onset of the symptoms. So these are the class 1A guidelines for mechanical thrombectomy. So let us see another situation. 30-year-old male presented with acute onset weakness in left upper limb and lower limb. 1.5 hours prior to the presentation, NIHS score was 12, and this was diffusion weighted MRI, which shows hyperacute right MCA territory infarct, and there was right MCA total occlusion. So in this situation, what should we do? Patient is in window period. Patient is 1.5 hours after the onset of the symptom which patient has presented. Whether we should thrombolize, whether we should take the patient directly for thrombectomy, or whether we should thrombolize first and then take the patient to cath lab for thrombectomy. So what does the evidence we have at present? So there are 6 clinical trials which have assessed non-inferiority of mechanical thrombectomy over bridging therapy. Uh, that is, bridging therapy is IV thrombolysis followed by mechanical thrombectomy. So in this all 6 trial, the only 3 trials, direct empty, direct skip, and Mr. Clean no IV. These were the 3 trials which showed that direct thrombectomy was non-inferior or either not inferior or superior. So, but the still the data which is available is not that much robust, and this was just 1 minute. This is the meta-analysis of all these patients recently published 2023, and the results of this meta-analysis suggest that there was no significant difference between if the patient's final outcome, if the patient undergoes whether directly mechanical thrombectomy or bridging therapy. But the subgroup analysis have showed that the patients who were in bridging therapy, there was better successful recanalization rate. However, there was slight increase in symptomatic intracranial bleed in patients with bridging therapy, but that was not statistically significant. So what we did in this patient was 1.5 hours into illness. We did not thrombolize. We took patient directly to cath lab. There was MCA total occlusion, and with stent retrieval, patient underwent mechanical thrombectomy, and after 2 passes, there was complete recanalization of right MCA, and the next day morning, there were only mild deficit left upper limb, mild loss of dexterity was there. So what we should do in such situation, if the patient is in window period and patients with large vessel occlusion, what guidelines at present we have is if the patient is eligible for IV thrombolysis, we should thrombolize the patient. Even if the patient is eligible for, if we are planning for mechanical thrombectomy, we should not waste time. After thrombolysis, we should not wait that patient will improve and then we'll see how is the response. After thrombolysis, we should plan and take the patient for mechanical thrombectomy into the cath lab. Where the situations where we thrombolize the patient, but we do not have facility for mechanical thrombectomy. In such situations, when there is a large vessel occlusion, patient should be thrombolized and immediately shifted to a center where mechanical thrombectomy facility is there. And class 2B evidence is there, where we have the facility of mechanical thrombectomy, patient can be taken directly for MT rather than going for bridging therapy. This third case, 43-year-old male, brought in casualty with weakness in left upper limb and lower limb. He noticed this weakness when he got up from sleep at 7 a.m. He was last seen normal was at 10 p.m. The day before, and he reached our hospital by 8 a.m. So if we calculate the time of onset, the last seen from normal, it is almost 10 hours. MRI showed right MCA territory infarct, and there was right ICA occlusion. ICA occlusion. It was a large infarct, and here you can see flare images also. The flare images, there is definitely diffusion and flare mismatch. So I will come to it. So in this situation, what should be done? Patient is out of endo period, thrombolysis is out of question. Patient is large infarct, large core, whether mechanical thrombectomy also help or not. In such situation, what evidence we have is two major trials. One is Dawn trial and another is Diffuse 3 trial. The Dawn trial, thrombectomy, the effect of thrombectomy was assessed from 6 hours to 24 hours after stroke with a mismatch between deficit and the infarct. Here, the patients were included into the trial when there was a mismatch, either diffusion and clinical mismatch or CT perfusion and clinical mismatch. And window period which was included in this trial was 6 hours to 24 hours since the time of the onset of the symptoms. And these are the inclusion criteria here you can see. And this trial has concluded that endovascular therapy, that is thrombectomy, was better plus standard care plus was better than standard care alone. So, and next is the diffuse trial, the thrombectomy from 6 to 16 hours based on perfusion imaging. It is also the same, almost same selection criteria in wake up stroke or patient presenting late after the stroke. The main aim of this trial is to assess whether there is a presence of penumbra and presence of collateral. If there is a presence of collateral and presence of penumbra, we should go ahead for mechanical thrombectomy in such patients. So both this trial have proved that endovascular therapy in such situation is beneficial and one should go for mechanical thrombectomy. This patient also, we went for, patient was taken to cath lab. There was left IC total occlusion and patient underwent mechanical thrombectomy with stent retrieval. After 4 passes, there was complete recanalization at right MCA, although that the flow in the right ACA was TK2B. And patient had deficit after the thrombectomy, left hemiparesis was there, which improved over a period of 3 to 4 months and became independent for most of his activities of daily living after 3 to 4 months. This is the last case. 53-year-old female presented known case of hypertension and diabetes on regular treatment, presented with acute onset of slurring of speech and left-sided weakness at around 10:30 p.m. at night. She, immediately, out of 10-15 minutes, her weakness improved completely, but there was persistent slurring of speech. She was a mother of a doctor practicing at Bede. Patient was admitted at local hospital, and early in the morning at 5:30 a.m., I will take 2 minutes only. So patient developed left-sided weakness. By 12:30, patient shifted to our center, but patient was intubated because of altered sensorium. And MRI showed pontine midbrain infarct, cerebellar infarct, and there was total occlusion. So there was basilar total occlusion. The evidence what we have in basilar total occlusion, this BASICS trial and BEST trial did not show any significant benefit after mechanical thrombectomy in patients with basilar occlusion. But there were certain limitations. I will not go into the detail into these two trials, but the more recently published trial, thrombectomy 6 to 24 hours stroke due to basilar occlusion, has shown the endovascular therapy, if we select the patients properly, is beneficial in such patients also. So in this patient also, where patient was shifted to cath lab, there was right vertebral artery, very tight stenosis. Because of that, patient had thrombus, which had embolized into the basilar artery. There was total occlusion, basilar occlusion, and the patient underwent mechanical thrombectomy. Next day morning, patient was drowsy but arousable, mild left-sided weakness. She was obeying commands, and after 7 to 10 days, patient was independent most of her activities except for ataxia. She was quite good. So coming to summary, so mechanical thrombectomy guidelines, what we have, a patient who is eligible for IV thrombolysis should receive if the patient is window period, and mechanical thrombectomy should not be delayed, and we should not keep on observing the patient. Patient should be shifted for mechanical thrombectomy. And what are the criteria for selection is pre-stroke MRI score should be 0 or 1, causative occlusion of ICA or M1, age 18 or older years, NIH score 6 or more, aspect score 6 or more, and treatment can be initiated 6 hours prior after the onset of the symptom. And MT is also recommended from 6 to 16 hours as per the, if the patient fulfills the criteria for Down's trial and diffuse trial. And patients with up to 24 hours can also be taken for mechanical thrombectomy. In patients with M2 occlusion, M3 occlusion, vertebral occlusion, basilar occlusion, we do not have that much data at present. Will require more studies. And patients who have low NHS score but anterior circulation stroke, it's a class 2B evidence we have. Thank you.
Thank you, Dr. Vatambar. We'll not have questions because of running short of time. Thank you.
Thank you. So please stay here. Yeah.
Thank you, Dr. Pandurang, for a wonderful talk. I would now like to request Dr. Tushar Chodiwal and Dr. Satish Solanke to felicitate Dr. Pandurang. I would now like to request Dr. Amit Choradia to come and felicitate Dr. Tushar Chodiwal and Dr. Satish Solanke, please. Thank you, Chairpersons.
So coming to the next topic after thrombectomy is secondary stroke prevention. So to call upon the next chairpersons, Dr. Shailaja Rao and Dr. Ramchandra Giri, sorry, Dr. Ramchandra Giri. I will call upon the next speaker, Dr. Amit Kulkarni from Bangalore. I'll ask the speakers to introduce Dr. Amit Kulkarni.
Dr. Kulkarni is eminent neurologist. He's clinical fellow in stroke and neurology from Singapore and certified in neuroscinology by American Society of Neuroimaging. And he has more than 15 publications, and he has given live TDC demonstrations at neurological workshops at Asia Pacific Stroke Conference, and his national faculty at neuroscinology and stroke conferences. And because of need of time, I skips the affiliation, but I request.
Thank you, Madam. Thank you, Chairpersons, for the kind introduction. May I have the slides, please? So today we had a deliberation throughout the day on when to choose a patient, for say IV thrombolysis, when to choose a patient for mechanical thrombectomy, and who are those people whom we would like to bridge, means we give IV thrombolysis and then do mechanical thrombectomy. So my job here is for patients whom we all see. I mean, as physicians, you see probably more than us. Here, these are the patients who have multiple risk factors. They have multiple problems. They are hypertensive sometimes, they are diabetic sometimes, they are having CKD, sometimes they are on maintenance hemodialysis, some people are on conservative line of treatment. And because of these multiple comorbidities, lot of times, we are in for a lot of confusion as to whether to thrombolize, not to thrombolize, what to do with these patients. And we always face this dilemma that people who already have strokes, how do we prevent a new stroke from happening? So my talk would be to address all of these factors one after the other. So I would like to just take 3 case scenarios so that you would understand what I'm likely to talk about. And at the end of it, I want you to answer this question. The first one is a 55-year-old lady who presents with sudden onset of right-sided weakness and aphasia since 3 hours. So you know that the problem is on the left side of the brain. The NHSS on admission is 8, which means it's a moderate size stroke. The BP at presentation is 240 by 110. Patient is a diabetic, hypertensive, on medications, compliance has been good. Patient is not on any antiplatelets, not on any anticoagulation. The CT has been done, CT is normal. CTA was done, there was no LVO. LVO means there was no large vessel occlusion. So this is how it stands at the moment. This patient comes to the emergency and we have given this patient repeated doses of labetalol. Why did we give labetalol? Because that's an approved indication in reducing blood pressure in the acute period. That's a window period. So we gave several times doses of labetalol, to name about 4 to 5 times labetalol. And although the BP would come down, it would again pick up to more than 200. So the BP was not able to sustain no matter what. So we did even try giving infusion of labetalol, but that also did not work. So in this situation, I would just like you to imagine and visualize this. I will not answer this question now. What do we do next? I think the answer for this is fairly simple, but this is something that will answer at the end. The second case scenario is a 65-year-old long-standing diabetic. Patient was found to be drowsy with paucity of movements. That means patient was not moving the hands and legs well. So the paucity was more on the right side as compared to the left side. Patient was brought to the ER within 15 minutes. The GCS at presentation was E2 M5. M5 means patient was localizing to pain, but there was a paucity. There was slight difference between right and the left. Here the GRBS on admission was 38, CT brain was normal, and the BP was normal. And as soon as dextrose infusion was started, there was a rapidly improving deficits. Right? So this is another case scenario. What do we do here? Again, I think this is a very simple question to answer, but we'll discuss this at the end again. And finally, a third case scenario. This is a 70-year-old diabetic, hypertensive, and CKD. CKD on conservative line of management, not on dialysis. Patient has non-valvular atrial fibrillation as well. So patient has 4 risk factors. For NVAF, the patient is on 2.5 mg BD of apixaban. So last dose of apixaban as documented by the family was 12 hours before. Now presentation was with sudden onset of left-sided weakness with dysarthria. And with patient was within the window period, NHSS was 7 on presentation. Here, as Madam Padma already spoke about, here what do we do when somebody is on apixaban is not the PTINR but APTT, because that's the way you measure the effect of the NOACs. So what was the APTT? She has already shown you a slide. If somebody has got an APTT of less than 37, we can still plan thrombolysis. But here the APTT was 41, the INR was 1.3, CT brain was normal, and CTA showed a distal right M1 occlusion, which means if you leave this patient, the patient is likely to deteriorate and worsen. So what next? So these are the scenarios. I think these are all diverse case scenarios. These are routine case scenarios which we encounter in day-to-day life. And what do we do in these situations is what I need to answer. So my presentation would be directed towards exactly that. So hypertension is a #1 killer, and it is 54% of cerebrovascular incidents are attributable to high blood pressure. And the risk of stroke is significantly increased with sustained hypertension of more than 140 by 90. This is proven beyond doubt. And the association of blood pressure and risk stroke is continuous without any threshold. till 115 by 75. So what does hypertension do? We all know this. Hypertension can cause a stroke, both ischemic as well as hemorrhagic. Hypertension can cause silent brain, white matter spots or white matter, what we call as silent brain infarctions. And it can also, hypertension can also cause atrial fibrillation, heart failure. And as a result of it, it can cause not only stroke, but it can also cause minor impairments of motor and sensory and vascular dementia, cognitive impairment, which could be vascular. And how does it cause it? Oxidative stress, baroreceptor dysfunction, eventually mediated by inflammation, risk. You can also have a lot of free radical induced damage. And as a result of that, we tend to have strokes. So again, 51% of stroke deaths are attributable to high systolic blood pressure. So if we want to change anything in the society, so as society at large, as a physician, you can definitely make a difference. The way we can make a difference is hypertension is a leading killer in most conditions. So you will have to identify and emphasize on people to check their BP checked regularly. This is the single most important thing that we should do, not only for people who are stroke naive or who never had a stroke, but more importantly for those people who always had a stroke, because they tend to assume that the doctor has prescribed medications and they come to you for a follow-up after a year and their blood pressure is not very much controlled. So it's again very important that the hypertension is identified at the community level and corrective antihypertensive medications are started. Not only started, it has to be monitored. And this is a very simple thing. I'm sure all of you are doing it day in and day out, but this is something that will make a difference at the community level. So what about the recanalization therapies? So for patients eligible for IV thrombolysis, antihypertensive treatment is recommended to achieve BP of less than 185 by 110. So the patient which I showed you, the BP was never below this, right? So if the patient we cannot recanalize, if we cannot bring this BP down to this level, what we have to do, if there is no large vessel occlusion, conservatively treat the patient. This is the line. So for non-thrombolysis patients, what do we do? What is our BP targets? Generally for non-thrombolysis patients, we must understand that target is different. Our target here is not 185 by 110. Please remember this. For somebody who has presented with beyond the window period and where we are trying to manage conservatively, do not bring the BP down drastically, because it is seen that if you bring down the BP drastically, you will worsen the neuro deficits. I hope I'm very clear on this point. People who are beyond the window period, people who have a blood pressure of say 200 by 100, you should only intervene if the blood pressure is more than 220 by 120 and target not more than 10% reduction. Mark my words, not more than 10% reduction in 24 hours. If you do anything more than that, overzealous correction of blood pressure in the first 24 hours leads to poor outcomes. Leads to poor outcomes. I hope I'm clear on this. So if you see a BP of 180 by 185 by 110, you are not thrombolizing this patient. Please, for heaven's sake, do not bring it down to 140 by 90. Right? So what you need to do is just give antihypertensive medications only and only if the BP is more than 220 by 120 and target not more than 10% reduction in 24 hours. After that, the patient's uh, response itself, the autoregulatory response itself takes over, and usually what you start seeing is a drop in pressures by itself. You don't have to intervene too much, you just have to support the BP whenever it's required. So this I've already emphasized about. And what drugs can we use? We can use labetalol, hydralazine, esmolol, in our situation, nicardipine as well, enalapril. So, but in our situations, most commonly what we use is labetalol. It's very easily available as well. In Europe, they have tried urapidil. And however, the only difference here is because you're also managing, ischemic cardiac events. Please remember that sodium nitroprusside and nitroglycerin, which are the favorites for cardiologists, can be a little bad for the neurologist. Okay, so please try to avoid these two drugs when it comes to neurological patients. So when do we increase the blood pressure? So I talked about decreasing the blood pressure. When do we increase the blood pressure? So in some situations where the patient, patient has got a carotid occlusion, the BP is a little on the lower side, we would like to bring the BP up. Do we want to start something to increase the blood pressure or not? So the guidelines here are not very clear, to be very frank with this. So some people, some initial trials did recommend to start some vasopressors to improve the blood pressure, to improve the perfusion in those carotid occlusions. But there was no significant benefit noted with this. However, so now what the expert consensus says is just stop the antihypertensive patient was taking. If the BP is a little low, just do one thing: stop the patient, the medicine the patient is taking, start IV fluids, and start some other kind of medicines to improve the volume, cerebral volume, so that plasma volume, so that the cerebral perfusion pressure is maintained. So all that it talks about is that if it is unresponsive to this, you can consider giving vasopressors. So I hope this point is also very clear. So what are the interventions to prevent subsequent strokes? You know, if the BP is, bring down the BP to less than 140 by 90. The magic number is 140 by 90. So bring it down to less than that. Target should be less than 130 by 80 for people who had already had strokes. So these are two numbers which you have to remember. And BP lowering should be very cautiously done in the acute period, which I've already spoken about. So I think I move on to this. The second part, which I think hypertension, I have already spoken about and what is to be done. Diabetes, okay, again, diabetes is one of the most common things that you people encounter. Prevalence of diabetes in patients with all types of stroke is about 28%. And the rate is greater in those with ischemic strokes as compared to hemorrhagic. So again, you have a condition where diabetes also leads to more ischemic strokes than hemorrhagic strokes. And patients with diabetes have 1.5 to 2 times higher risk of stroke as compared to people without diabetes. And people with diabetes have poorer post-stroke outcomes and higher risk of stroke recurrence than those without diabetes. This also we have to remember. So how does diabetes cause it? There are various ways. One is inflammation. One, it accelerates atherosclerosis. It can cause even small vessel disease. And it's also known to be generating a nidus for cardioembolism. So all of these factors, one after the other, can give rise to ischemic strokes. So increase in patients with ischemic strokes and hyperglycemia is very well known. And hyperglycemia delays the reperfusion of the ischemic penumbra and decreases TPA-induced recanalization rates. That's one more point. So the diabetic people are slightly more resistant to TPA than the other people. So odds for symptomatic ICH increase by 75% with every 100. So if the higher the blood glucose, the risk of symptomatic ICH increases. But that does not mean that it's a contraindication. Please remember that higher blood sugar is really not a contraindication for thrombolysis. This is one thing you have to carry home. So then what are these therapies which can help reduce the risk of stroke? Well, I don't have personal experience. I don't treat diabetes that much, but GLP-1 receptor agonists as well as thiazolidine diones. So these are the two agents which have a positive impact on risk reduction of strokes. All the other agents are known to, are not known to improve or increase any benefit in terms of management of diabetes with stroke. So what are the targets? How do we manage sugars? So here again, what is recommended is maintaining the serum glucose concentrations in the range of 140 to 180. So that is what is important in the first 24 hours. So it does not talk about this particular level, but it says that try to maintain in particular level. If you try to do a overzealous correction of blood glucose, again it is seen that there is a very high or a very poor outcome because of induced hypoglycemia. So that is something we should need to avoid because most of these patients are on hypoglycemic agents as well. So in such situations, we must use short-acting insulin to ensure that the blood glucose is kept within this range of 140 to 180. And we should try to normalize the blood sugar within next means 48 to 72 hours. So that's our target. So bring it down to this level in the first 24 hours and then gradually try to bring it down to the normal range. So again, I think so what do we do to prevent strokes? We know this: weight control, dietary changes, improve the physical activity in patients with diabetes. And as I already spoke about, a GLP-1 receptor agonist or SGLT2I may have some cardiovascular benefit, although we don't recommend changing over to those medications. It's not that just anybody who's taking that change over to this, not like that. So these drugs have shown some cardiovascular as well as some neuro benefit, so they can be added or they can be substituted if one requires. So the next one is chronic kidney disease and stroke. So the prevalence of CKD is almost, it affects as much as 9.1% of the population. The overall incidence of stroke is more than twice than in individuals with normal kidney function. And risk increases by 7% per 10 ml drop of GFR. Remember this. And also the risk of proteinuria. So there are two risk factors with people of CKD. One is that the low GFR itself is a risk factor. Number two is the presence of proteinuria is another risk factor. If we don't have these two things, I mean the significant low GFR and this one proteinuria, then still these patients are not a bad risk factor. So how does this cause? Multifactorial again, decreased erythropoietin can be there, anemia can be there as a risk factor. During hemodialysis, there are a lot of things that can happen. Abnormal platelet function in patients with uremia and accelerated atherosclerosis in patients with uremia. So these are all the risk factors which can accelerate atherosclerosis and cause increased stroke risk in CKD patients. So again, the traditional risk factors also do add up with these patients. So even if CKD patients could benefit from specific treatments like thrombolysis or thrombectomy, their prognosis seems to be poor. Important to understand this. It is although these patients are treated with thrombolysis, it is not that because of bleeding of thrombolysis or because thrombolysis has not worked in these patients. I'll take another 2 to 3 minutes, but it is not because of the failure of thrombolysis, or it's not because of the SICH. But what happens in these patients is because of the other poorer risk factors which cause this poor outcome. So in these patients, the risk is not that. So renal failure is a potent risk factor. The risk of stroke is 5 to 30 times higher in CKD patients, especially those on dialysis. And case fatality rates are much, much higher in those patients. So again, I'll quickly jump through this. What we see is younger patients are more affected there. Again, they tend to have more in terms of hemorrhagic strokes as compared to a control group, which is 68%, which is ischemic. In these patients, a sizable number of hemorrhagic strokes are seen, while in the ischemic strokes, it's about 68%. And uncontrolled hypertensives are more likely to have both ischemic as well as hemorrhagic. And hemorrhage, remember one more thing, that in our fraternity, in the South Asian populations, it is the hemorrhagic strokes which occur more frequently, and in the Caucasians, it's the ischemic strokes with people in the same risk factors. So again, one more problem is more incidence of atrial fibrillation. So again, these are all subgroup of patients who are at a very high risk of stroke. So again, 43% independent risk of stroke with low GFR of less than 60% and higher stroke risk seen in the Asian origin people. So again, different, as I told you, low GFR and proteinuria, these are the two things you have to look for. These are the people who are more likely to develop strokes, and they are likely to develop both acute strokes. They are likely to develop small vessel disease, cognitive impairments leading to dementia as well. So all of these factors can lead to it. So CKD and IVT, I have already touched upon this, that IVT itself is not a problem here, but it's because of the other poor control. Patients have lactic acidosis, patients have other problems because of which they'll end up with poorer morbidity and mortality. It's not because of thrombolysis per se. So there was this fact that because they have a bleeding risk, higher bleeding risk with thrombolysis, should we give a higher dose, normal dose, or a lower dose? So in Enchanted trial, there was this study which was done, which said that a lower dose, which was 0.6 mg per kg, did that benefit? But however, it was seen that there was no difference between a lower dose and a normal dose of Altiplase. So in other words, you can stick to the tried and tested guidelines, but do remember that there is a little bit of higher risk of thrombectomy, bleeding risk with these patients. So all of these guidelines, we just stick to the guidelines is what this table says. So I'll just skip this. So IVT for acute ischemic stroke may improve outcomes, should not be withheld just because somebody is on ESRD. So just follow the technique, the guidelines of when to thrombolyze, and you have to follow that guideline. So secondary prevention in terms of antiplatelet therapy, anticoagulant therapy, and statin therapy. The problem with CKD is we have the CHADS2 VASC score. If somebody has got a CHADS2 score of more than 2, then the problem is that do we put them on anticoagulation just like we do the other patients? The problem in such patients would be that they do tend to have a higher risk of bleeding. And we must remember that in those situations, we have to analyze the various other bleeding risks through Hasbled score and other score, and then come to a conclusion whether the patient needs anticoagulation or does not need anticoagulation. And probably you can dose modify anticoagulation in such patients. So secondary stroke prevention in terms of lifestyle, we all know that everybody should practice this. So improve physical activity, target weight loss, stop smoking, reduce alcohol. Hypertension targets I've spoken about. Lipid targets LDL of less than 100. Diabetes, anti-diabetic medications, antiplatelet therapy. Always remember dual antiplatelets are for 3 weeks. or 3 months, up to 3 months. After that, in selected situations, you continue dual antiplatelets. Otherwise, please do stop dual antiplatelets, continue single antiplatelets. Cardiac embolism, look at oral anticoagulation, VKA versus DOAC, NOACs. Choose the right patients. ESUS, the last word has not been said on it, but aspirin is a drug of choice. Patent foramen ovale, now there's more and more guidelines saying that we should try to close these close these PFOs if they are big and based on the scoring. Symptomatic carotid stenosis, carotid endarterectomy or stenting, and in stenosis like intracranial mild stenosis, vertebral stenosis, best medical treatment as of today. So this, so in to summarize, in patients with underlying hypertension, target goal of less than 140, maintain goal of less than 130 to 135. Sugar control, which I've already spoken about, and IVT for AIS should be considered. So what was done in the case scenarios? Case scenario 1, where BP was persistently high, thrombolysis could not be done, and we tell the family thrombolysis could not be done, and patient was managed medically with gradual blood pressure reduction as per guidelines. Case scenario 2, where there was a hypoglycemic event, what we did was the patient was treated with dextrose. However, we still did the MRI. MRI showed bilateral posterior limb of internal capsule diffusion restriction. So which means it's hypoglycemic event, and it resolved completely after 24 hours. It was bilateral, remember, it was not a stroke, it was bilateral. And case scenario 3, where the patient was on NOAC and the APTT was high, although the PT-INR was normal. Remember, this patient was on NOAC, the PT-INR was normal. We did the APTT to check that APTT was 41. Patient last NOAC dose was 12 hours back, so we knew that NOAC is still working. IVT is difficult, dangerous. So this patient was taken up for primary mechanical thrombectomy. Patient had minor deficits after thrombectomy, but did eventually well after 2 or 3 months. With this, I would like to thank one and all for a patient hearing. And thank you for the organizers for giving me this talk. Thank you.
Thank you. You have given a very expert talk, beneficial for all, and you have almost covered all risk factor which is related to the stroke. Thank you.
I'll ask the chairpersons to felicitate Dr. Amit. I invite Dr. Vilas Magarkar to felicitate the chairpersons, Dr. Shailaja Rao and Dr. Ramchandra Giri. So from moving to prevention, now we go ahead with the drugs, what we use routinely in practice for secondary or primary preventions. Those are antiplatelets and in some scenario anticoagulation. So we have two debates. For the first debate, for use of single versus dual antiplatelet, I invite my next speaker, Dr. Shrikant Deshmukh, on stage, and Dr. MV Padma Srivastava. Debate? Talks? Okay. So I introduce my fellow colleague and friend, Dr. Shrikant Deshmukh. He is a senior consultant neurologist at Medicover Hospital, Aurangabad, and he doesn't require any introduction. So I ask him to go ahead with his talk.
Uh,
Thank you, Shripal, for the introduction. Actually, I think the time allotted is 15 minutes for the debate. So I will take 6 to 7 minutes to put up my case. Actually, the last speaker, Dr. Amit Kulkarni, in last few of his slides, actually summed up the whole situation. But I'll just go through briefly about the use of antiplatelets. So as you know, these are the different types of antiplatelets we use. Aspirin, the clopidogrels, silestazole, dipyridamole we don't use often, and the other GP2B3A inhibitors, blockers. But our focus is on aspirin, clopidogrel combination in this talk. So I mean, there is no debate as such. I mean, we know that dual antiplatelet therapy is mainly used in only high risk TIA cases and in mild non-embolic cardioembolic strokes as per the guidelines. So this is where we are very clear that where should we use dual antiplatelets. Now, if we look at the TOAST classification of stroke, we can see there are different types of mechanisms of stroke. When there is a large artery stroke, small artery occlusion, cardiogenic embolism, cryptogenic stroke, and stroke of undetermined etiology. So in first two categories, like large artery and small occlusion, the role of dual is very clear. Cardioembolic is not very advocated. And these last two categories, again, it is not very recommended to use dual antiplatelets very often. As you can see in this diagram, the most left is a lacunar stroke, small artery. The second one is a intracranial atherosclerosis. The third one is extracranial atherosclerosis. On the bottom right is a cardiogenic. The middle one is a dissection. And the last one is cryptogenic, I mean, the undetermined etiology, where you don't know, despite of thorough investigating the case, we are still not able to find out what is the etiology of of the stroke. Now, as I told you, high risk TIA, that means we need to calculate ABCD2 score. Now, the parameters in ABCD2 score is age more than 60 years, blood pressure more than 140 systolic, clinical features of TIA, whether it is unilateral weakness or speech impairment, and duration of TIA, whether it is more than 60 minutes or it is below 60 minutes. So depending on these whole parameters, we can calculate the score from 0 to 7. More the score, high risk of TI. As you can see, if score of is more is 6 to 7, then within next 2 days, the risk of stroke is almost 8%, and in up to 90 days, it is like 18%. So in high risk TIA cases, we have to use the dual antiplatelets. Now, what is mild stroke? As we know, NIHS is a stroke severity grading system in which the points are from 0 to 24. If the stroke is the score is less than 4, we call it as a minor stroke. So again, the use of dual antiplatelets is only restricted in minor strokes, not all the strokes. Now, as you can see, there are the whole many trials has been done. The International Stroke Trial, CAST trial, ECPS trial. The bottom line is, in all the trials, the role of aspirin is clearly advocated. I mean, it has significantly reduced the risk of recurrent stroke by around 15 to 20%. So there is no doubt about role of aspirin. As we go further in the later years, there are three trials: match trial, charisma trial, and SPS3 trials. Now again, in all these trials, uh, because they are long duration trials, I mean those trials where the antiplatelets have been used for a longer period of time, and they have shown that over a long period of time, the role of dual antiplatelets is not very preferable to a single antiplatelet agent. Uh, I think these THELS trial is basically for use of ticagrelor. SAMPRIS trial is for intracranial atherosclerosis and use of antiplatelets. And the CHANCE 2 is a trial where the patients who are having the clopidogrel resistance due to certain mutations, they have used ticagrelor in place of clopidogrel. But in our debate, I mean, we'll just go through the next slides. We'll not dwell too much upon it. Now, as I told you, there are 5 short duration trials where the antiplatelets are used for maximum up to 3 months. and two long duration trials where they are used up to maybe 3 years or more than that. So what conclusion has derived out of them? So if you look at this graph, you can see the ICH and major bleed is more common with dual antiplatelets. So clearly the long duration trials has told us that in a longer run, these two major side effects of dual antiplatelets clearly negate their use. Now, when we go into short duration trials, this was for the short duration. Now this is for long duration trials, where now you can see uh, the the use of single antiplatelets is still comparable with dual antiplatelets in the longer term. So whenever you keep on using the antiplatelets for a longer term, again the role of single antiplatelet becomes vital. Now there is a very recent paper where they have studied the trend of using dual antiplatelets in those patients who were non-eligible for point and chance trial. Now, point and chance trials, as we discussed, they compared the dual antiplatelets versus single antiplatelet, but the inclusion criteria for those two trials were very precise. But what happened over few years is that after the chance publication, it is a Chinese trial in 2013, the use of antiplatelets has increased in all the subtypes of stroke, whether it is large artery atherosclerosis, small vessel occlusion, undetermined cause of stroke, all the subtypes of strokes, the use of antiplatelets has proportionately increased. Again, you can see the eligibility criteria. The NIHS score, as I told you, a minor stroke is less than 4. But even for the patients having NIHS more than 4, and those coming even more than 24 hours after the onset of stroke, the use of double antiplatelets has increased. So the use of antiplatelets is now slightly violating the inclusion criteria of point and chance trials. And again, whether there is a no stenosis, mild stenosis, significant stenosis, or occlusion, the proportion of dual antiplatelet is same. It has increased post 2013. And in 2018, there was a point trial which was predominantly for USA patients. Again, the use has increased significantly. So basically, this is the summary of the trial where you can see the recurrent stroke and the major bleed is relatively comparable in dual versus single antiplatelet. Now, when the dual antiplatelets were used up to 72 hours after onset of stroke. Now, as we told you, it should be used within 24 hours. But when it is used up to 72 hours after ischemic stroke, uh, as you can see in this study, yes, definitely the risk of stroke has reduced. But again, as you can see down, the risk of bleed has almost doubled with whenever we use the antiplatelets up to 72 hours. Now, this is the paper which clearly mentions that in strokes of undetermined cause, the use of dual antiplatelet therapy has caused early neurological deterioration. And the role of the dual antiplatelets in such kind of stroke is not very convincing. And we have to abstain from using double antiplatelets in this class of patients where the etiology is not very clear. I think I'll skip this because this is not pertaining to our talk. So basically, to conclude, I'll say dual antiplatelets is for high risk TIA, ABCD2 score more than 6 to 7, and in minor, where NIHS score is less than 4, non cardioembolic strokes. Dual antiplatelets are only for short duration, maybe 21 days, in some cases, maybe up to 3 months, and early initiation is better. Longer duration, higher dose which was used in point trial, clopidogrel was used as 600 milligram loading dose, was associated with high risk of bleed. Lacunar strokes, obviously single antiplatelets are much better, and there is no doubt about it. Post chance and point trials, the use of dual antiplatelets has significantly increased. Even in non-eligible cases, we have to be very careful in using dual antiplatelets very rampantly. Long duration trials match an SPS 3 has slightly shifted the favor towards single antiplatelets. Extracranial atherosclerosis, dolichoectasias, dissections, dual antiplatelets for 3 months. And large artery atherosclerosis, I think Dr. Padma Madam is one of the author for the trial which is ongoing. And I think this trial is for use of double antiplatelets in large artery atherosclerosis. I think it is for 12 months. So we'll get to know what is the outcome of using dual antiplatelets for up to 12 months and then possibly derive more data about it. What is the optimum dose and duration? And what I personally feel, whenever there is a stroke or a new event happening with prior antiplatelet, there is a desire to do something. There is a urge to do something, try new drug, add something. But before adding or switching to something new, you need to ensure a proper drug compliance, whether patient was taking the drug properly in proper dose or not, whether the other lifestyle parameters were being taken care of, as Dr. Kulkarni in the previous talk has suggested. Statin, sugars, lipids, smoking, alcohol, all these parameters also need careful attention rather than jumping to a new antiplatelet. Drug interactions, clopidogrel and PPIs again have a very strong interaction, so you have to be careful using these two drugs together. Check the drug resistance, like as we know in Asian population, the clopidogrel resistance is significantly high. So we had, whenever possible, I mean, now there are few laboratories who are doing this resistance checking. We can advocate for such cases. Always had to remember a genuine risk of hemorrhage, and any genuine fatal hemorrhage can be very life threatening. Also, as these antiplatelets are used long term, we have to consider the side effect profiles like dyspnea, headaches, which is common with ticagrelor. So, so I conclude by saying single antiplatelets are preferred for a longer duration, dual antiplatelets for a shorter duration. Uh, Thank you very much. And actually, I'm honored to share this debate with Dr. M.E. Padma Madam. Actually, we grew up as a neurology residents, reading her articles, and today I'm standing here. So thank you very much. Thank you.
Actually, I wasn't there for the initial part of your thing, but I don't think there is a debate at all. There is no debate. I think we'll just quickly end it by saying that what are the indications for dual antiplatelets, okay? So thank you. You actually already set the ball rolling.
Madam, please, laptop is different. Laptop is different. You can do later.
So as I said, there is really no debate. Okay, so we'll just get on to what are the the indications and where do you place dual antiplatelets in your secondary stroke prevention. So essentially, when you're looking at a secondary stroke prevention, we need to definitely understand. I probably, maybe Dr. Gaikwad has already run through this. I wasn't there initially. Pardon me if it is a repetition. That we have what is called as a stroke prone state. The occurrence of another stroke is maximum in a certain duration of time, and that's where you actually, when the iron is hot, you really hit it hard, right? So in the first 48 hours, depending upon what stroke subtype you're looking at, you have the maximum chance of a recurrence. So obviously it makes sense that you need a harder strategy when the stroke prone state is maximum, but you will not need that when the stroke prone state diminishes. And we know this for sure, that when the plaque is ruptured, you get these clots up. The ruptured clot will not stay ruptured, it will heal. So after that healing process, you may not have the same kind of a recurrence. These are the statistics. So when these key questions still remain, And when we are looking at a very old scoring system, this is called essence score of a very two old very trials. So they actually looked at the risk factors of an individual. The person can be aged, can have hypertension, diabetes, previous MI, peripheral artery disease, smoking, what have you. Now, every stroke patient is not identical. So you can have a 75-year-old, a hypertensive having a stroke, and you can also have a 75 hypertensive diabetic, had a previous heart disease, has an ongoing peripheral artery disease, and will not quit smoking and had a stroke. Now, the risk factors are not the same for these two guys. So when they looked at the scoring system and seen a single antiplatelet versus double, and when this risk score is very minimal, single antiplatelet did great. But when you have a risk score which is high, 7, 8, you look at the single antiplatelet which is colored in this, maroonish, whatever color that is, versus blue, the recurrence was much higher when there was a single antiplatelet. So therefore, please again remember, guidelines are there, but your individual patient, as Dr. Gaikwad again said, that yes, compliance and a whole other issues when you have a stroke recurrence. With this background, we have a lot of combos which are there. You have aspirin clopidogrel, which is famous. Aspirin diphenhydramine, which is pretty infamous. Like, we don't have too many takers right now in that, although they are in the guidelines. You have aspirin silastazole is a combo which is fast coming up. Ticagrelol is thanks to our cardiology colleagues, and one funny study of Thales. I was also part of that. And then we have the triple antiplatelets, which are no takers. So, what are the current indications? And let's just bury the hatchet, Dr. Gaikwad, and just look at the indications of DUAT and not really listen to early versus late. So, you have TIA and minor strokes, you have ICAD and atrial fibrillation, period. So, in TIA and minor strokes, you have definitely a lot of literature, all these trials which have already been talked about, I guess, and we have a meta-analysis which said around 9,000 patients, all who have started the medication, preferably within 24 hours or mostly within the less than 72 hours, and you have a non-significant bleeding, which has again been the biggest, problem whenever you hit it hard. But there's been a definitive decrease in the recurrence of ischemic event and the composite vascular events. And so that's a meta-analysis. You look at the diamonds which favor the dual antiplatelets. So the first one is all the cardiovascular events, and then we have ischemic strokes, and then what we are concerned about is hemorrhages and death. So in these two, the diamond cuts the midline, so it is not really significant in a way, but the diamond is more towards single antiplatelet, so I would prefer that. So the conclusions in a kind of a minor events is that duat, lot of evidence with aspirin clopidogrel, less with aspirin ticagrelol, that within 24 hours, as he said previously, high risk TIAs, non-cardioembolic, mild to moderate strokes. Definitely you have risk of stroke and all the major cardiovascular events, and there's no real difference much in bleeding events. But then please individualize based on bleeding and thrombotic risk profile. That comes as a disclaimer. Second is ICAD. ICAD, you have big trials, Sampras, Claire, Caris. Claire, Caris, so small ones. Sampras is when really it is, an age which is a different era altogether. But this is the take home thing that I put up for my students, that when you have an atrial fibrillation, I'm looking at a non valvular atrial fibrillation, antiplatelet versus nothing. It's again no brainer. Single antiplatelet, you're reducing the risk of a stroke with a, that is your, vitamin K antagonist. You're decreasing great. You're almost getting almost 60-70% risk reduction. So really comparing and contrasting, you definitely have an oral anticoagulant. But then when you're getting a newer anticoagulant, you have a slightly better edge with VKA in terms of bleeding because you have less intracranial bleeding. So you do have a duet place in atrial fibrillation where you cannot anticoagulate and you don't have this left atrial appendage closures and what have you and all this. And I hope we don't have cardiologists here. So the recommendations out here, even in 2019, with not a great class, it's not a level 1 evidence, it is indicated for 90 days patients with severe ICAD, that is where he's brought out the ongoing ICMR trial called the stenosis trial. We're giving the dual antiplatelets for a year versus 3 months, which is what the Western guidelines have come in. But I do believe that we have more ICAD. In fact, we have ICAD and ECAD. We're somewhere in the middle between, Far East and the Westerners. So that's where we stand. But yes, you can take an individual, you have an M1 occlusion, which is an ICAD sitting there. You can't really stent it, but you don't want to stent it or whatever it is. And they keep having recurrences. You probably should continue to add for 12 months. And that's we'll get out of the stenosis trial results and indicated in lifelong in patients with AF who are unable to take the oral anticoagulants. That's where again DUAD has come in. And for the minor events is just 21 days. And of course, the whole list out here is unexplored, unanswered. This is out for all the youngsters out here that we don't have a level of an evidence, so there's actually no debate here. Large infarct volumes, high NHSs, low risk TIAs. And as he said, if we're taking this and we are, ad lib giving to everybody on board that you continue your, the Brilanta with aspirin and aspirin clopidogrel, you will land into trouble. So that's where all these are gray zones and you're not getting into it. So even after, angioplasty, how long to continue DUAT? And there are different takes on different interventionalists. So again, should I always take ticagrelol? I have preferred ticagrelol when I've suspected clopidogrel resistance, which is not really non-significant. It's really almost bigger than 30%. And then we have this resistance, and then we have this combos of oral anticoagulants with APT. I'll just touch upon it. So these are the teaching points, which are the take home for what we have. And the compass is the last one where we are actually combining. This is another combo of a single antiplatelet with a small dose NOAC. Rivaroxaban, apixaban is also coming on board. Not so much dabigatran, but we have the compass results where again they have a big reduction when you have a combo. And there are situations where these combos have come on board. Again, so these are the guidelines at this point of time where we use Dior antiplatelets and we have the exact duration spelled out. So the take home is, as far as a duet is concerned, again, I don't think there is a debate. We certainly are not going to start off DAPT at any point after they come a week after stroke and you're going to put them on DAPT and continue for a year long. That's not what you're going to do. So when we are sticking to the guidelines at this point of time, I see no debate. Thank you.
Thank you, ma'am. And thanks, Dr. Shrikant. I call upon Dr. Manjiri Naik, HOD, MGM Medical College. Ma'am, please come to felicitate Dr. Shrikant Deshmukh. His name got changed, ma'am. Shrikant, please. So next routine after antiplatelets, what drugs we use is in cardioembolic or other strokes is oral anticoagulations. So there is a second debate between newer versus conventional anticoagulants, and I call upon Dr. Anand Soni and Dr. Pramod Dhonde for the debate. I call upon Dr. Sanjay Ambekar.
Good
Sir,
afternoon.
please, can you introduce Dr. Anand Soni and Dr.
Yes,
Pramod Dhonde?
yes. Dr. Anand Soni is a consultant in Aurangabad. Is life member of Indian Academy of Neurology life member of Maharashtra Association of Neurology, member of Brain Dead Declaration Committee, and life member of IMA Aurangabad. He has worked as a sub-investigator in a various national and multinational trials of Parkinson's disease, epilepsy, dementia, and multiple sclerosis. He is a clinical rater in UP, DRS, and EDSS for Parkinson's disease and multiple sclerosis, respectively.
I thanks Stroke Academy for having this wonderful session. Uh, I thank you, sir, for the kind introduction. So basically, here is a debate about conventional anticoagulants in ischemic stroke versus new oral anticoagulants. So we need to understand that anticoagulation per se doesn't have a very significant role in the earlier thing we have discussed, like ischemic strokes. What we are here discussing is about the cardioembolic strokes. So where anticoagulation use and where to use such anticoagulation. And the debate is not between the subcutaneous. We are discussing about the oral anticoagulants. So what are we know that what are the conventional anticoagulants in ischemic stroke? One is warfarin. So we know what is the mechanism of action of warfarin. Warfarin inhibits vitamin K, and which is a vital component of blood clotting process. We have direct oral anticoagulants and we have heparin. So here we are debating about where should we use warfarin and where we should use newer oral anticoagulants. What is the place? So as we know what is the mechanism of action, we know that the coagulation cascade, there is a extrinsic and an intrinsic pathway where we use there is extrinsic and intrinsic pathway, and we need to have warfarin, which is a vitamin K antagonist. So 2, 7, 9, 10, factor 2, 7, 9, 10 are vitamin K dependent. So when we use warfarin, the anticoagulation effect takes 3 or 4 days to at minimum 3 or 4 days. The initial prolongation of PT, prothrombin time, is just because the factor 7, which has short half-life, maybe 5, 7 hours, is inhibited. So when we start warfarin, the anticoagulation starts during third day and it's actually normalizes at 7 days. And there is something known as TTR, like time for therapeutic this thing. So when we are using warfarin, we need to know that a single INR is not sufficient. One INR ratio or one reading is won't help you titrate that this is optimum anticoagulation. But this is something known as TTR. If patient is 65 to 70% time in TTR, then probably we can tell that patient is in has an optimum anticoagulation. So these are the landmark in development of anticoagulation. So what we can see is now it's almost like 60 years we are using warfarin. 60 years, it's a time tested drug, and we know and there is something known as therapeutic efficacy we can look for. Like we have a monitoring system for patient for anticoagulation is INR, which is a standardized ratio. And for the newer oral anticoagulant, we don't have any monitoring system. So for efficacy, it is only a new clinical event which can help you. But here warfarin, for efficacy, you have INR which you can always titrate. So there are certain advantages. It's high bioavailability. We can monitor. They have an antidote. So sometimes if you have a overdosage or INR is in a supratherapeutic range, you have an antidote to treat this thing. In this condition, you have a vitamin K which you can give. It can be used in all age groups. Uh, Long clinical experience, as I told you, it's 60 years and it's least expensive. So it is as compared to the newer oral anticoagulant, which are very expensive. This is a least expensive drug. The disadvantages, maybe Dr. Pramod will go into detail, is it being a debate, but only the problem most of the time is it requires a monitoring system. You give, and if patient doesn't monitor, then there is a problem. Second, there is a drug interactions. It is because if somebody is on a anticonvulsant or somebody on a other drug, like earlier we discussed like PPI or many other drugs, there can be like or multivitamins also, which have low level of vitamin K, you won't get the therapeutic INR. So this is a problem. And second problem is you can't have a immediate anticoagulation effect. You have to have a bridge therapy with low molecular weight heparin or a conventional heparin. So and the least common is that skin necrosis, which is very uncommon days. So two trials. One is RELY trial, patient with atrial fibrillation. What we are talking here is non-valvular atrial fibrillation, either paroxysmal or persistent. Even for a paroxysmal atrial fibrillation with a stroke, you have to have an anticoagulation, and there is no structural heart disease, only atrial fibrillation. Here, we know that warfarin is time tested for that. But then with the newer molecules like dabigatran, rivaroxaban, apixaban coming into picture, with head-to-head trials, this RELY had shown that these NOACs are slightly superior as compared to warfarin. Earlier it was like a non-inferior trial, but it has shown that they are slightly superior, but the risk of hemorrhage is slightly lower in dabigatran group as compared to the warfarin group. So this is that in RELY trial, both doses 150 and 110 of dabigatran were better than warfarin. So recommendations from Indian guideline for use of anticoagulants in secondary stroke prevention. Anticoagulation is recommended for all patients with atrial fibrillation, valvular heart disease or non-valvular, provided they can comply with the monitoring. Both warfarin and newer are equally effective for non-valvular AF. So for non-valvular AF, they are equally effective, but for valvular heart disease, as of date, recommendation is conventional anticoagulation is advised. So when you have a structural heart disease or a valvular heart disease, it's preferable or by guidelines or by large RCT, still warfarin is recommended, or oral anticoagulants, directly acting oral anticoagulants are still non-inferior to warfarin. Additional antiplatelet therapy may be considered for patient with stroke, TIA or rheumatic valvular heart disease on warfarin. Somebody who has a rheumatic heart disease and a stroke is already on anticoagulation. Maybe he may require additional antiplatelet therapy. VK therapy with specific target is recommended for patient with mechanical heart wall. We need to have uh, vitamin K antagonist. Always there should be a brain imaging. Even if patient is on warfarin, we need to have a brain imaging to precede anticoagulation initiation for stroke to rule out hemorrhage. Target INR effective varies with higher range for mechanical heart wall on a warfarin therapy. So consider brain imaging for anticoagulant therapy, oral anticoagulation for non-valvular AF for stroke prevention, warfarin for stroke prevention in valvular atrial fibrillation, or warfarin anticoagulation in LV thrombus or a LV clot. At that time also, maybe the directly acting oral anticoagulant versus warfarin, still efficacy of warfarin, because we can titrate again with INR. So recommendation, patient with stroke, TI and valvular AF, moderate to severe MS, mechanical heart warfarin is recommended to reduce the risk of recurrent stroke. It's a class 1 level A evidence. All these trials, I think they same thing. The take home message is when you have a heart disease, structural heart disease or a mechanical heart wall, it's preferable to use warfarin over newer oral anticoagulants. And anticoagulants target various cascade stages. They inhibit clotting factor synthesis. Evidence suggests long clinical experience. So my debate point here is we have a long clinical experience with warfarin for over 60 years, and for mechanical heart wall still they are class 1 level A indication. To take home message, warfarin time tested, efficacious, cheap, easily available, monitoring available for efficacy even at a local place, rural place it is available. And INR test, I think, can be done at Taluka place also. Time for onset of action is late and needs a overlap in acute condition. This we need to understand. You can't directly start on warfarin to some patients. There are drug interactions and definitely monitoring is required. Thank you.
I call upon Pramod to counteract. Sir, you can introduce Dr.
Gives me pleasure to introduce Dr. Pramod Donde. He is a consultant neurologist in Nanded, the director of Donde Hospital. He has multiple publications to his credit. He is working in rehabilitation field, set up an advanced rehabilitation center in Nanded. Facilities for inpatient hydrotherapy and various modalities with a teamwork. Working as a environmentalist since last 6 years with tree plantation and guaranteed maintenance is a very incredible. And rainwater harvesting across Nanded city. These things are much needed in our areas. Yeah. it is a request from organizers to stick to time. We have got very little time now.
Actually, I will finish off within 5 minutes, most probably. Actually, there is no debate as such in this. There are already Anand has told that the clear-cut indications of warfarin versus newer anticoagulants. So, just story about this warfarin. Do anyone recognizes what is this actually? What is this related to warfarin? There is very interesting story of warfarin. This is a plant actually that is called sweet clover silage, and that has been in the 1920s or 30s. In US, some of the counties, the cattle were eating these plants and they were bleeding like anything and they were dying. So nobody knows what is the reason for this, and that's why the study came. And after that, it was found that that was the molecule that is nicumulin or this warfarin is the molecule which is causing these bleedings. And this name came after this patented patent by this Wisconsin Alumni Research Foundation, that is WARF. So this is the story of warfarin began. And initially, warfarin was not used as an anticoagulant. It was initially as an rodenticide. And with the people were wary about that, why to use this warfarin. So one of the army inductee has poisoned himself with the large dose of warfarin, and he didn't get bled. And after that, it has started the using of warfarin. So that was the story of warfarin. Very interesting to find that it is started with this cattle thing, and after that, it has gone to this naming, and after that, the army inductee has gone poisoned, and they didn't find anything related to this. So already Shrikant has, Anand has told about the intrinsic and extrinsic pathway. We are going to deal with this factor 10A inhibitors and what is the direct thrombin inhibitor, that is dabigatran, and all the others are the factor 10 inhibitors in this common pathways. So evolution of anticoagulation, as seen that initially 1995 VK superior to aspirin for acute prevention AF, and after that all these trials came, and till 2020 the field is still evolving. So NOAC's indications, it is VTE prophylaxis after elective hip or knee surgery. All the indications are apart from endoxaban. VTE treatment, all the NOACs are recommended. While the anticoagulation for non-valvular atrial fibrillation, all the indication, all the molecules are recommended. For anticoagulation for significant mitral stenosis or prosthetic heart valves, as Anand has told, it is not recommended. You should stick to the routine VKS. Dose selection criteria as shown that dabigatran is 150 milligram BID, lower dose 110 milligram BID, rivaroxaban, all the doses are there. And dose reduction criteria, if it is age more than 80 years, concomitant use of verapamil or increased bleeding risk, then you should reduce the dose. Rivaroxaban, creatinine clearance, if it is 15 to 49, then you should reduce the dose. While apixaban, age more than 80 years, a body weight less than 60 kg, serum creatinine more than 1.5, and you should reduce the dose. While the endoxaban is not available, so we are not going to discuss about it much. And these are the mechanisms that apixaban is mainly this metabolized through liver, dabigatran mainly metabolized through kidneys, while this endoxaban 50% liver and kidneys, rivaroxaban it is predominantly through this liver metabolism. So accordingly, we should reduce the doses. Choice of NOACs in high-risk population, GI bleeding, preferred choice is apixaban because apixaban is the only NOAC with smaller number of GI bleeds in the original studies. Elderly is rivaroxaban, apixaban, endoxaban, 110 milligram dabigatran, and the 150 milligram dabigatran showed trend toward higher bleeding in the elderly, so you should avoid dabigatran. Impaired renal functions, then apixaban, rivaroxaban, endoxaban are the choices of NOCs. Then coronary artery disease, rivaroxaban is the only NOAC with proven benefit after acute coronary syndrome. So choice of NOACs in high-risk population, that diabetes mellitus, choice of NOACs, all these are recommended because there is no interaction between the diabetes mellitus and the efficiency and safety of NOACs. While the cardioversion, endoxaban, rivaroxaban, both have been prospectively found to be very viable alternatives to warfarin for cardioversion. Mechanical heart valves, none because it is to be VKS. Bioprosthetics, more data needed. And non-mechanical and non-rheumatic mitral valvular disease, apixaban, endoxaban, dabigatran are recommended. Rivaroxaban was associated with higher rates of bleeding in those with native valvular disease. Advantages already has been shown that NOACs have rapid onset and offset of action, few drug interaction as seen with this, as seen in the diabetes or what we are discussing lately.
Predictable pharmacokinetics, eliminating the requirement for regular coagulation monitoring, lower incidence of major bleeding, and wide therapeutic window. Disadvantages, obviously, there is no antidote for this molecule. If their bleeding happens, do not exist standardized test for monitoring of NOACs when it is necessary for monitoring of these drugs in hepatic or renal disease. Sometimes rapid offset and short half-life may be considered as disadvantages. For example, missed dose affects efficacy. Currently, lack of antidote, high cost is going down, so that there will not be issue over the period of time. Not enough experience, and NOACs therapy can be initiated without low molecular weight heparins. So these are the, already ma'am has told about these trials, that is Rayleigh, Rocketf, and Aristotle and Avros trials. Actually, you see the number, sample size is very huge, 18,000, 14,000, 18,000, and 5,000. So all these trials have shown that it has got comparable efficacy with the warfarin. Even the event rate is little bit more lesser, as better with this all these Novax. So primary outcomes in subgroup of patients with previous stroke. If you see the forest plot, it is shown that favors experimental drug, that all the trials are favoring towards this rivaroxaban, then apixaban, endoxaban. All these drugs are favoring towards this primary outcome, favoring towards primary outcome. Stroke or systemic embolism in NVF trials of Novax versus warfarin. You show that it is shown in the graph that Rayleigh trial and Rocket and Aristotle, all the trials have shown that the bleeding risk is little bit lesser as compared to the warfarin, as shown in the graphs. Intracerebral bleeds in trials of warfarin versus NOACs, the bleeds are little bit lesser. So advantages of NOACs is that it is a rapid onset offset of action, few drug interactions, predictable pharmacokinetics, eliminating the requirement for regular coagulation monitoring. All this I have shown in the last slide. And so the efficacy of NOACs is for prevention of ischemic stroke. The new oral coagulants, direct oral anticoagulants, have similar efficacy to warfarin, while the ischemic stroke reduced by 2/3 compared with the placebo with the NOACs. So NOACs have favorable safety profile compared to the warfarin, safer compared to warfarin, with associated with an increase in GI bleed. So apixaban is the one of the drug that has to consider when it is considered like that. Significant reduction in all-cause mortality compared with the warfarin. So 2020 ESC guidelines clear-cut say that in AF patients with an ischemic stroke or TIA, long-term secondary prevention of stroke using OAC is recommended if there is no strict contraindication to OAC use, with a preference for NOACs or VKs in non-NOAC eligible patients. In AF, that is class 1A, in AF patients presenting with acute ischemic stroke, very early anticoagulation using unfractionated heparin, low molecular heparin, or VK is not recommended. Then this AHA guidelines that same things in patients with stroke or TIA and AF who do not have moderate to severe mitral stenosis or a mechanical heart wall. Apixaban, dabigatran, endoxaban, or rivaroxaban is recommended in preference to warfarin to reduce the risk of recurrent stroke. That is class 1 BR recommendation is there. This is one of the another entity that is called atrial cardiopathy. Nowadays, it is showed that ESUS, or whenever there is undetermined causes, that when you should suspect this atrial cardiopathy, there are some biomarkers that if it is 3 biomarkers are there: LA enlargement, increased P wave terminal force in lead V1, and increased anti-proBNP. If these 3 biomarkers are then there is chance of atrial cardiopathy, and there are chances of having cardioembolic strokes. So these patients to be considered probably for in future. There were 3 trials already has been done: Navigate ESUS, Atticus, and Arcadia, which has been recently published. Arcadia, but they are not in favor of NOACs till date, but future studies might have some light, throw some light on this. Anybody seen, this is the last, for one of the last slide. Anybody sees what is the cardiomegaly, what is the sign actually? If you see the arrow, what is the sign? Actually, this is called a GRE susceptibility vessel sign, suggests a red clot, and it is more in favor of cardioembolic stroke. And they are more than those with stroke with subtypes seen within 24 hours of stroke. It has little bit fairly more sensitivity, or little bit specificity. You can say that if it is a red clot is there, then they are more amenable to treatment for this IVT, and in future you can see the source for cardioembolic strokes whenever you see this sign. To summarize, already anticoagulants target various cascade cells inhibiting clotting factor synthesis, clotting function. Evidence suggests that therapeutic window
These drugs, NOACs, have shown lower risk for bleeding and are safer than VKA, and VKA therapy is recommended for as in patients with mitral stenosis, non-valvular AF with related to mitral stenosis. Then take-home message is that ample evidence to support the use of DOACs in non-valvular AF, even in patients with renal dysfunction. In patients with history of GI bleeding, apexaban is preferred. Regarding prevention from LVT, which I have not told anything about that initial slide, but because of the limitations of time, data is limited, but the suggestion of favoring to DOACs over the VKAs. Recommendations in hypercoagulant states are more varied with data addressing the acute and secondary treatment of venous thromboembolism rather than ischemic stroke. Use of DOACs in antiphospholipid syndrome is not currently recommended, and regardless of the indication, anticoagulant decisions need to be shared decision after thoughtful discussion of the risks and benefits of the chosen. Thank you once again. Today, happy Guru Purnima is there, and to all my teachers, I salute to all of them because I am from GMC Aurangabad. I have done MD medicine from here, and there is Jirvankar sir is there, Rao madam is there, and probably Joshi sir is also there. All of them I have high regard for them because we have taught under them medicine, and they have thoroughly taught us very well. And after that, I have done neurology from JJ, and where my Khadilkar sir is my mentor, and he is like a mentor, godfather to us. Thank you once again. Thank you once again.
Thank you, Pramod, and thank you, Anand. I think we are near to the lunch time, so everyone please stick to the time. Debates are not. It has to be faster, Chris. I want sir to felicitate Dr. Anand and Dr. Pramod. Excellent talks on oral anticoagulations, newer and the conventional ones.
Actually, as Padma madam is there and Nirmal Surya sir is there, there is in the main theme of this meeting is a mission brain attack. The actual problem we are working in the tier 2, tier 3 cities, the overpowering of the people's mindset towards stroke care is very difficult. Because yesterday, two things I will tell you. One of the vet came day before yesterday. He reached within the hospital. Vet doctor, I'm telling you. Vet doctor came into the hospital, reached somewhere, and he has gone to the quack within 2 hours. So that mindset is very difficult to change, and that is the biggest challenge. Whether you have available CT scans, anything you have, but the people's mindset is very difficult to change for this stroke care. Yes, absolutely, absolutely. In JJ, there is in near Mazgaon, you see that there is one person who was doing stellate ganglion block. People used to go for stroke care for initially for the within 2 hours, initially 15 years ago. Now what he does, I don't know.
I call upon Dr. Ganesh Agrawal to felicitate Dr. Sanjay Ambekar. Sir.
New anticoagulant is very comfortable for doctors and even patients. Doing INR every month and waiting for doctors to see the report will take a lot of time.
We have spoken about antiplatelets and anticoagulation. But what are the side effects? And if they bleed after anticoagulation or after IV thrombolysis, what has to be done? So I call upon the next speaker, dynamic stroke neurologist from Mumbai, Dr. Pavan Ojha. And I call upon chairperson for this session, Dr. Sandeep Sanap and Dr. Madhusudan Tapadia. Sir, please come on the stage.
So I think you can go with the introduction, then we can start quickly. I think everyone is waiting for the lunch, I suppose.
Hello. Right. Sir, Pawan sir needs no introduction.
So I'll start. Yeah.
Uh,
I was just
sir is
waiting
a,
for that sentence. That is fine.
sir is a director of neurology at Fortis Hospital, Mumbai.
No worries, no worries.
Uh,
I
sir,
we'll save the
yes,
time. Yeah. Thank you.
I welcome you. Sir.
So I thank the this great initiative of Academy, Indian Stroke Association, the local organizing committee members, and chairpersons for giving me this opportunity to share some views. We will keep it a little faster, informal lecture because I think everyone is waiting for lunch, and this is like time is brain, and so the lecture will be divided into two parts. First, we'll deal with complication of thrombolysis, and second, we will see when we have these NOACs, DOACs, whatever you say, if we need to reverse, then how should we reverse it? So this is like a very practical implication. It's like that Abhimanyu entering into the Chakravyuh but not coming out of it. So you can easily prescribe a thrombolytic agent or DOAC, and then when the hemorrhage or the situation hits, then you don't know what to do. So you can't keep on looking at the guidelines at that time because things are moving very rapidly, patients are deteriorating very rapidly, and your adrenaline is shooting very rapidly. So your brain is confused now. So better have a look here. So first we will go ahead with this TPA associated intracranial hemorrhage, right? This is a scary situation to be in. And what TPA does here is, we should see here, is basically when you have a stroke, this is your fibrin clot, right? And then to the fibrin clot, there is something which is endogenously attached to it. This is called as a plasminogen. So the key also is there, but we need something to activate that key. So when you give the TPA, then this clot we are breaking down by activating the plasminogen to plasmin, right? And when this happens too much, then there will be too much depletion of fibrinogen and too much thinning of blood and hemorrhage. So FDP products will increase and fibrinogen in the blood will drop. Now this is what we need to, and there will be other clotting factors also which will drop. So we need to reverse this situation when there is a hemorrhage, right? But every time you see blood on the CT scan and the patient is not deteriorating, there may not be a real worry. So the real worry happens when there is a major hemorrhage in the brain as seen on the CT scan and seen by a clinical deterioration in the patient, right? If you have a very tiny some blood speck here and there, no need to worry. But if the patient, even till this point, PH1 also, this is called a parenchymal hemorrhage type 1, in which there is a minor hemorrhage in the infarcted area. But if there is a major hemorrhage more than 30% of the area, or there is a remote hemorrhage, then there is a cause of concern, and this usually leads to drop in the patient sensorium or a deficit, and this is called as a SITCH, so symptomatic intracranial hemorrhage. Now this is the real concern, and how we handle this we will see. So what happens to these patients? So if you have a patient who deteriorates, will he worsen over time? So there are 30 to 40% chance that over next few hours these patients will worsen. When does this hemorrhage happen? So after the giving a TPA, this hemorrhage can happen up to 36 hours, but most of the hemorrhages they happen within 24 hours, and that too around half of them will happen roughly about 6 to 8 hours from the time that you give the IV TPA. So most of the times we give TPA and then go home, and there will be one person who is not observing the patient. So that person has to be made to carefully observe and document the blood pressure and the NIH. So we call that person a stroke nurse. So whenever you have a thrombolysis case, you please for the next 8 to 12 hours you assign one person that your job is to immediately let me know if there is a drop in the sensorium, or you can say NIH, and this is what exactly happens, that the effect of the TPA lasts much longer than the actual half-life of the TPA. So the TPA, most of the literature is related to the actylize or TPA, but we will extend this whole discussion to tenecteplase also. So although the half-life of the TPA is only 5 minutes and tenecteplase is only 20 minutes, but as you see here in this picture, that the fibrinogen level drops and it remains low for little longer time. So those people whose fibrinogen level really drops to less than 150, they have a serious problem and more chances of hemorrhage. So we need to treat this coagulopathy rather than only think that no, TPA must have disappeared, so no need to treat it now. Right. So what are the options for treatment? So we will take it very, very simple. So if you have in a very like a large corporate hospital, then the protocol may be slightly different. If you are in a little less well-equipped place, then the protocol is slightly different. So first we need to think about that what has gone wrong with this patient. So if you look at the end, then this fibrinogen has depleted. So we need to replace the fibrinogen. Now replacement of fibrinogen is not by giving FFP and platelet. Platelet will only replace platelet. FFP will replace other clotting factors and little bit of a fibrinogen. So if you have an option of giving cryoprecipitate or fibrinogen concentrate which is available, then please do it, right? Then there will be other agents which will stop the fibrinolysis. Whatever fibrinogen is there, that also something is breaking, that we need to stop. So that we use this agent tranexamic acid now. Everyone knows about this agent, so you can use that. And then to supplement this, you give FFPs and whatever other things that we will go to discuss further. So the typical plan is that you can use cryoprecipitate. Now one cryoprecipitate bag contains roughly 10 units of cryo. So that is sufficient to increase the fibrinogen to above 150, right? Then you can give 6 to 8 units of platelet or like a single donor platelet. Then keep on, then again after you give this injection, then you send fibrinogen level. So one strategy will be to, as soon as the patient deteriorates, you draw a sample, check CBC, PT, PTT, fibrinogen level in that. That is will be considered a baseline. And the other strategy may be just to give the this fibrinogen or cryoprecipitate and then repeat the level at the end of this injection, and also check for platelet. If the fibrinogen level is less than 150, you give more fibrinogen or cryoprecipitate, right? If the platelet is less than 1 lakh, then you give platelet transfusion. So this is the protocol in which we work. The factor 7, the effect is not very clear and it's not also easily available. So this is a guideline for reversal that if anyone is having a problem, you can Google and search for burn stroke guidelines. BER, University of Bern, that I refer to them very easily. It is available. The other app which you can use, download it, is called the Neuro ED, Neuro Emergency Department. All the guidelines are there. You please use it. It's very easy to use, right? So fibrinogen, this injection is there. It is available. Whenever you drive a car, before you press the accelerator, please check the brake. So whenever you give TPA, you check whether you have the things to block the, treat the hemorrhage. If you don't have it, I think better to modify your practice, right? So you may need to give additional fibrinogen concentrate or cryo to increase the level of the fibrinogen in the blood. The fibrinogen is the most important point here. So this cryo we have already discussed. This bag of 200 ml will contain roughly about 10 units. That will be sufficient to for next 4 hours. Then this tranexamic acid injection, that is an antifibrinolytic agent. So whatever fibrinogen you are giving, that also will get disintegrated. So you, to stop that, you give tranexamic acid. Simple protocol will be that you can give 2 grams, so 1 gram bolus followed by another 1 gram bolus, or you can give 1 gram bolus followed by a prolonged infusion over 6 to 8 hours of another 1 gram. So that is very easily available injection now. Now some people will also have other factor problems. So all those 2, 7, 9 and 10. So you can replace prothrombin, but this is not the agent which is of first choice in these patients, because these are not the factors which are deficient. So this will be used for patients who are having a warfarin related hemorrhage. But sometimes some centers they choose to additionally give this. Sometimes nothing is available, fresh frozen plasma, but it is a high volume transfusion and can give rise to major side effects sometimes. And then the platelets can be given if the platelet is under 1 lakh. And then some centers, although this is not clear, the recombinant factor 7A. Now we go to the second part of the lecture, and that is the all these newer agents, the direct oral anticoagulants or the NOACs as you say. What happens when you need to reverse it? Suppose you are using it and the patient has to go undergo an emergency surgery, then you may need to reverse it. Or if there is a patient who has a life-threatening or a serious hemorrhage, then you need to reverse it. So what are those hemorrhages usually? So these hemorrhages will be usually intracranial. Half of them roughly will be intraparenchymal hemorrhage. Some of them will also have subarachnoid or subdural hematomas for which you may need to emergently reverse it. Now this is a protocol that has been mentioned, and in this the important thing is that we have now reversal agents available, and we will learn to see how we can use them more effectively. So first is to understand that when this patient has taken this DOAC, and if the patient has taken this DOAC in last 24 hours, then you know it's a situation where this DOAC may be still acting in the body and the blood may be on the thinner side. So how we need to do this? What test should we rely on? If their history is not very clear cut, there will be easily available tests which is PT, PTT. Trust me, they are not very reliable. But if at all you have to rely on them, then dabigatran you should do APTT, and rivaroxaban or the other apixaban that you should do PT-INR. But I don't think they are reliable. The specific test which is available for dabigatran is thrombin time, which is available in many centers. This anti-factor 10A also is available, but the results don't come so fast. So the agents that we need to discuss here for the direct thrombin inhibitor, that is dabigatran, we have a darosizumab. Now this is injection is available in 2.5 grams vial. You can give one vial after the other with a gap of 5 to 10 minutes in between. And this should be usually sufficient to reverse the patient for next 24 to 48 hours. Sometimes there is a rebound and they need to give again this thing. Now this dabigatran, if you have taken within first like last 2 hours, then there can be a role for giving an activated charcoal 5 grams orally to absorb this dabigatran. In many patients, it may be a good idea to do a dialysis and remove this dabigatran because it is a renally excreted agent. There will be a few patients who will be having this 10A factor inhibitors in their blood, and this andexanet alpha is now being made available in it. I have not used it, though I think that there is a protocol in place to use this now. And there are two protocols. One is a simple dose protocol, and this is called as a double dose protocol. Simple dose protocol means 400 milligram bolus followed by a for next 2 hours there should be a per milligram per minute 4 milligrams. So all these are written protocols, but it is not so simple. There are some thrombotic complications with this andexanet alpha. We'll quickly go through this so that we understand what are the issues. So this idarosuzumab, basically it's a very interesting concept, is that out of these antibodies only the FAB portion is taken and there is no FC portion in this. So there is no risk of any immunogenicity and all those things. And you can use this very safely to reverse the dabigatran. Now it has been extensively tested in the reverse ADA trial, and what they found basically is that you can use this effectively and there are not many complications here. So the median time by which the extracranial bleeding will stop will be about 2.5 hours, and before the surgery 1.6 hours before you can give this. Now for the andexanet alpha, now this has been approved for only bleeds and this has not been tried for stopping before surgery. And there are some side effects which we must remember is that there can be a higher complication rate of MI, ischemic stroke, thrombolysis. So mostly when you reverse it, there will be thrombosis. And although this factor 10A activity has been reduced in within 2 to 5 minutes by 94 to 92%, but this is not like as the effect is not as great as the idarosuzumab. So have a look here. There are problems here that with the andexanet alpha to be used. So how do we compare idarosuzumab and andexanet alpha? So there is a need for infusion, and there is no emergency, no approval in emergency surgery for andexanet alpha. There are some prothrombotic effects, and there is a cost which is higher. So, and obviously the cost is so high that, it will not be in everybody's reach. Then there will be another concern is when to restart the NOACs. Once you had this, stoppage of this agent, and then you did the surgery, and again, when do you restart it? So if there is a clean surgery, we say that clean surgery, then 6 to 8 hours after surgery. So simple lumbar puncture, no complications, good hemostasis was achieved. If there is a problem with the procedure, there is a immobilization, then sometimes there may be a requirement of starting low molecular heparin little early and delaying the NOACs by 2 to 3 days. So whenever you want to do that, think about it. So we'll finish quickly by last two cases, just two exemplary cases which have been published in Indian literature. One is of a 79 years old lady who presented with a fall and then subsequent ICH. And this patient was given idarucizumab, and the bleeding stopped, and she did not require any surgery later on. And within 2 months, then again this thing was started, the dabigatran was restarted. And there is another 49-year-old lady who presented with stroke, and within 30 minutes of symptom onset. So this patient was reversed with the adarucizumab and followed by a thrombolysis for the acute stroke, and this patient recovered very well and went home. So I thank you for your attention, and I appreciate everyone's patience. Thank you so much.
Thank you, sir, for excellent talk.
I ask the chairpersons to felicitate Dr. Pavan Ojas, please. And I ask Dr. Rahul Javle to felicitate the chairpersons.
We are running short of time. I would like to invite Dr. Kanjalkar sir for the next talk. A referral to higher center. When, where, and how. I would like to invite Dr. Jirvankar sir to chair the session and Dr. Umesh Raithe to chair the session.
Stroke referral. Start, sir? Yes. Thank you for giving me this opportunity. Believe me, I shall take less than time allotted to me. So I have just changed the title. Referral of a stroke patient rather than higher center. When, where, and how. So first thing is, when should refer any patient, not only stroke patient? When he should be referred? First is for something which is not available with you, it should be referred. When you are not sure what is wrong with the patient, you are not understanding in spite of observation, daily observations, investigations, discussion, he should be referred. And last and commonest thing for which the patients are referred is when patient or in neurological case, patients are not happy with you. So patients seem from taluka to district, from district to regional places, from here to Pune, Pune to maybe Mumbai. From Mumbai, I don't know about US. And then there are people from US who are coming back to Mumbai and even Aurangabad for treatment. So this happens and this gets shifted. So where should be shifted? Where the first case, where the concerned treatment is available, like if you are doing thrombectomy, where it is done, where such diagnosis can be made, where the senior persons discussion departments are available, and in last case, where the patient and his family will be comfortable. So these are the general rules. Now, as far as stroke patients are concerned, when you are seeing a patient in society, community, in OPD, where this should be shifted, when it should be shifted as early as possible, that is insisted since morning by madam, because IV thrombolysis is the only proven therapy. Because thrombectomy, etc., needs selection, but IV thrombolysis should be offered, and if it is not offered, it is considered as an error of omission as per the medical acts for the court. So it should be given as early as possible. So whenever you suspect stroke, he should be referred as early as possible. So when should you suspect the stroke? I mean, there is weakness on one side, numbness on one side, imbalance, etc. And this is again, which was covered in the morning. Be fast, balance, eyes, face, arms, speech, and time. And this Government of India guidelines, I mean, I just researched it, and this is very nice. And देखता कैसा है, दिखता कैसा है, हाथ कैसा है, पैर कैसा है, बोल चाल कैसी है. So all this, I mean, this can be very easily told to any practitioner. देखना, दिखना, हाथ, पैर, बोल चाल. So if there is something wrong acutely, these patients should be referred. So where they should be referred? They should be referred to nearest hospital. Now here I must say, when last week I was taking lecture on the final MBBS students, and I asked them, if you are sitting in Aurangabad and if you see a patient who has got stroke, where they should be referred? One of the students stood up and said, I shall take him to Orion Hospital. So that is an awareness, Dr. Vattam. Believe me, I am no way concerned with Orion. I have no financial but that is an awareness which is stroke, Vattam var. Fine, okay. So that should be taken to nearest hospital. We should have a CT scan facility. Neurologist is an optional. Where the CT is there, he should be referred. And of course, now we have got so many neurologists in the town and everywhere in district place. So it is not an difficult to find out and then see. I mean, 20 years back, things were different. And now with all teleconferencing videos, etc., on seeing CT on WhatsApp, we can definitely thrombolyze. So patients should reach as early as possible, and this was told to me last about few years back when Dr. Isha Puria, past president of ISA, had come here. He always insisted, don't call ambulance. I mean, ambulance will take time, use any mode of transport. Traffic is not a problem only of metros. This is our photograph in Aurangabad town. So believe me, how the ambulance will come, pick up the patient and shift. And he insisted that this slide said it should be shifted as early. This is Three Idiots photographs. So patient is taken on the bike. Of course, this is exaggeration, but you mode any transport, use rickshaw, etc., your own vehicle, but take to the hospital. Now, next type is from a hospital, maybe a smaller ICU, smaller hospital to a stroke unit where cath lab, dedicated neurosurgeon, neurological are available. Which patient should be shifted? So patients who have got severe symptoms, patients who have got radiological deterioration, and who need specialized care like thrombectomy or neurosurgical intervention should be shifted. So they should be individualized looking at the guidelines patient flow. But this is okay, but practical scenes are different. I mean, like Pramod was saying, patients say, why should we go? We shall go to such places like Puntamba, etc. And this should be answered, whether these are higher centers or not. For public, they may think these are higher centers, but they are giving you magic cure. They are at least giving a hope. So how should to deal with these patients? So about 20 years back when we started thrombolysis here in the town, we had tough resistance, which patient should be offered, etc. So here, these are the guidelines from Ayurvedic textbook. This is a Vagbhat. And it says this is the ideal patient which should be treated. And what does it mean? This is Adya Rogis who has resources. Vishak Vasho is who listens to the doctor. Jnapaka is who understands. And Satvik is who is really grateful to you. He's not doubting you. So for this patient, maybe you explain, yeah, he is going to do something better. Money is at this time, but later you will repent. You try to explain. So for that, maybe you spend time, but otherwise, if you want to go, okay, go. Because even if you are not saying anything, they are going to go. So you explain with few words. You can go to all these centers maybe later also. This is not the time to go. But there will be some patients who will say, nahi, nahi, humko jana hi hai, and who are not listening to doctors, etc. So these are the bad patients. Like, I mean, madam was saying, which patient should not be offered thrombectomy, gata yusham, who are about to die, who are afraid, who are not. So then you cannot insist them. So these are the patients, okay, fine. And if you are having some chandam, I mean, who are notorious, maybe refer to Vattamvar, we will deal them. Or we refer them to Dinanath Hospital or Sahyadri Pune, dear Dr. Rahul Ichapuria. So these are the patients which can be referred. Then, of course, which patients comprehensive stroke care should have interventional facilities, and then you should know geo-talking, etc. Our town is not that much big. We know each other very well. And these should have all these, including rehabilitation services. And how they should be referred? They should be referred stabilized patient. They should be communicated, appropriate transport and documentation. Transport, again, basic critical care, airway, breathing. They should have enough. They should have adequate monitoring vital signs and controlling bleeding. So basic critical care. You should contact wherever you are referring. That person should be aware such and such patient is coming.
because in IV thrombolysis also, if you are aware that the patient is reaching to hospital, the time will be shortened. Otherwise, patients will be waiting in casualty, in OPDs, and particular neurologist OPD, they may live in 1-2 hours, etc. And then you should coordinate. Transport, arrange appropriate transport using ambulance, and in certain cases even air ambulances etc. are described, but here appropriate critical ambulance where we can shift this patient to the other center. Always document. I mean, documentation is not only for legal safety, to tell the opposite person also that this patient, I have done such and such imaging, this is the CT picture which can be transported via WhatsApp, emails etc. And it should include and provide the copies to the patient and to the opposite parties where we are sitting. So in summary, proper referral of patient to higher centers requires careful coordination, communication to ensure the best possible outcome, and following standardized protocol and guidelines can help to streamline the referral process and improve the quality of care. So whatever may be guidelines in our country, it is individualistic. Even the patient's treatment is individualized. Every stroke patient is not the same, like with every doctor is not the same. But as I said, that first line, that shlok, which is the ideal patient. So that Grantha says there are 4 pillars of the treatment. One is doctor, Vaidya, Aushad is whatever treatment you are seeing, Paricharak is nurse or your assistants, and Rogi is the patient. So these are the 4 pillars. And I want to insist this last line. Yad Vaidya Vigune Pada Gunumantopi Anarthakam. And what it says is Ya Chatushpadam Peki Vaidya Yogyana Selif. Doctor is not the proper. Even if the rest 3 pillars are okay, just like 1 minute, just 3 pillars are okay, they are useless. But even if rest 3 pillars are bad, if doctor is good, he will use appropriate resources at appropriate time and do something good for patient. So be a good doctor, refer proper patients to a proper doctor at proper time. Thank you very much.
Thank you, Dr. Kandarkar. As usual, you have a spiritual touch to your lecture, and it is humorous. So everybody is waiting for the lunch.
Thank you.
I think I should thank sir from bottom of my heart. No, not for promoting me, but for finishing it on time. So I request Jirvankar sir to felicitate Kandarkar sir. I request Shirshika sir to come on the dais and felicitate our chairpersons, Dr. Umesh Raithe and Dr. Jirvankar sir. So coming to next topic, once the patient is referred to higher center and if there is a mass effect midline shift, what to be done? I request Dr. Yogesh Vargantwa sir to come on the dais for the next lecture, decompression in ICH. For chairing this session, I request Dr. Abhinandan and Dr. Ashish Kulkarni to come on the dais to chair the session.
I think with a lot of drugs which are anticoagulants and antiplatelets and a combination of these, I'm coming to a topic which is a bit different from whatever we have just heard from. Dr. Kanjalkar has already introduced our hospital. I thank him to do that. I'm a neurosurgeon and I will be talking briefly upon the surgeries to be done for IC bleeds. When to operate and whom to operate is $1 million question. I'll try to simplify it for you. There's a trial, which is a stitch trial done across 27 countries and more than 78 institutes, which shows this is a stitch trial 1, which was published in 2005. And this showed that no overall benefit is done by surgery. But this is only when you compare with the initial conservative line of treatment. The second stitch, that is stitch 2, was introduced or published in 2013. And this did not show much of a difference in the two treatments, that is the medical line of treatment and the surgical line of treatment. But in spontaneous superficial intracerebral hemorrhage, it did show a clinical outcome, a better outcome in the patients. So with these two trials, which are not showing any gross benefit in the early stage, the question arises that when should we operate and on whom? So patients who are not uh, coming up or getting treated with the medical line of treatment is one, to prevent secondary brain hemorrhage, which starts occurring after the primary bleed. Two, and the Cushing's triad, which shows a bradycardia, a change of breathing pattern, and a reactionary high hypertension. Or patients where the posterior fossa bleeds are more than 3 centimeters in size, and patients which are developing mass effect and deteriorating. When do we avoid operating on patients? Patients with brainstem bleed, a GCS score of less than 5, and definitive contraindications for surgery where the expected outcome is going to be poor, like absent brainstem reflexes, fixed dilated pupils, I would surely say that, and flaccid quadriplegias. Why to operate these patients? That is only to prevent secondary injuries, which basically occur because of the edema, inflammation, red cell lysis because of toxic effects of the iron, and cytotoxic edema because of damage in the blood-brain barrier. What would be the aims of surgery? The aims of surgery would be to prevent further herniation if it is already started off, which is very clearly seen in the posterior fossa bleeds, to reduce the intracranial pressure, to decrease the excitotoxicity and the neurotoxicity of the because of the bleed, to prevent secondary brain injuries. There are different surgical procedures to choose from. Which to choose and when to choose basically depends upon the surgeon and what he is used to. But small trephine craniotomies with evacuation, I think, are sufficient for patients with large bleeds and having less edema. Decompression craniotomies, especially in posterior fossa bleeds, where the cavity is small and the hematomas, along with the swelling, gives rise to compression effects onto the brainstem, as well as can cause hydrocephalus. EVDs, we all know, are usually done for only intraventricular bleeds, and endoscopic evacuation is as good as a trephine craniotomy, but endoscopy has its own problems, but they have started doing it because it needs a media to work upon. Surgical interventions for supratentorial hematomas. Lesions with mass effect causing midline shift, causing pressure on the posterior circulation, causing edema. Then patients where the volume of the bleed is between 30 to 90 cc are usually taken up for surgeries because less than 30 cc may not require surgery and more than 90 cc do not give good results. Persistent features of raised ICP in spite of the medical line of treatment, rapid deterioration of patients, and favorable locations, lobar bleeds or non-dominant hemispheres. These patients with supratentorial hematomas may give better results than others. These are a few cases. I didn't want to put these pictures because this is more of a surgical side, and neither I wish to put a video, may not be very interesting to you, but these are the post-op results in a few of our patients where we did these surgeries. This is one patient which shows a bleed after the surgery in the below the skin. And I think your dual platelets were working on these patients where we did not, we had this complication to come in. Right, surgical interventions for infratentorial hematomas. In cerebellar bleeds, the time given by the patient may be less because of the compression effects. So whenever we see a neurological deterioration of patients, or brainstem compression showing brainstem signs, or obstructive hydrocephalus setting in, or bleeds which are more than 3 centimeters, we usually should take up the patient for decompression craniotomy as well as evacuation of the hematoma. Decompression here will surely help us because the space is less and it gives a chance for decompression onto the brainstem. It relieves the brainstem and may allow the fourth ventricle to open up, preventing the obstructive hydrocephalus. So this is one of the patient where which shows on your right, it shows the decompression done, and there is an EVD which can be seen in the central picture, which is in the right frontal region. So bad outcomes are seen with, yes, definitely intraventricular extension of the hematoma. Hematoma volume more than 90 cc. GCS, I would say GCS between above, in fact, below 3, and ICH score of more than 3. What is ICH score? It can be seen in this table. Lesser the score or lesser the score less than 3 is has a better outcome. I don't wish to go into this ICH score. Finally, the line of treatment from which we need to select is best medical line of treatment. Evacuation of hematoma, which is done in patients with large hematomas and less edema, where smaller craniotomies can be helpful. Evacuation of hematoma with decompression craniotomy, this is something where there is a moderate hematoma with edema that also is moderately seen. Only decompression, which are deeply based hematomas, which are small in size and also has large amount of edema. So only decompression craniotomy would be preferred, and only EVD where only intraventricular extension is, or only intraventricular bleeds are seen. Ultimately, talking about the QOL, whatever said and done, a surgical or maybe a medical management for large bleeds, the results are quite poor, with basal ganglionic bleeds causing hemiplegia, and if it's on the left side, many more problems with it. It will be more worse if it is on the left side. Finally, to take home for the take home message, I would say mass effect, Cushing's triad, deteriorating signs, herniating signs, developing hydrocephalus, posterior fossa hemorrhages should go in for surgery. Thank you very much.
Thank you, sir, Dr. Vargamana, sir, for enlightening us upon decompression. I would like to request Dr. Abhinandan to felicitate Dr. Vargandwar, sir, and Dr. Dhananjay Mane, sir, to felicitate our chairpersons. I would like to request Dr. Sachin Bangar to come on the dais to felicitate chairpersons. Coming to the next and the last topic before the lunch, which is very important, and often we are not aware, or in our busy practice, that part is little bit neglected by the busy practitioners, is the rehabilitation after the stroke. I request Dr. Nirmal Surya, sir, to enlighten us upon the rehabilitation. And for chairing this session, I request Dr. Anant Kulkarni, sir, and Dr. Sudhir Deshpande, sir, to come on the dais.
As usual, rehabilitation is the last. Pandurang said a little bit neglected. I would say that it is the most neglected. Little bit is only people know. So it's contrary. Uh, Even in our practice, even go to the neurologist or even go to the stroke specialist, when it comes to rehabilitation, it is the last. While this is the most important part to bring back the patient back into the normal activity of daily living. And I'll show you quickly why. I'm not going to talk about this because you already know about this, that is stroke recurrence rate, which is 5.7 to 51%. So that's something you have to understand, that even a patient who has recovered from the stroke is at a very high risk. And when a stroke happens, what does it mean? For patient, it is end of the road. For the family, it is the beginning of burden. For physician, it is he thinks what interventions I can do. Organization think investment, and for the nation, it is loss of daily. And no two stroke patients are alike and react similarly into that situation, and we have to plan out treatment accordingly. These are some of the impairment. And what is important is you look at that. Initial hemiparesis in 73% patient, but at 1 year is 37% patients still continue to have aphasia from 36% to 20%, dysarthria from 48 to 16%. Dysphagia is the only one which improves significantly, and incontinence to 9%. So even at 1 year, the disability is quite severe. Even if you look at the discharge and 6 month about the person with functional level and activity limitation, you can see that there is significant disability at 6 months. And these are Indian data from Tali et al. So these are the fact. The 1/3 ambulate with sufficient endurance to be function after the stroke. And we need to work on supervised training and task oriented practice. This is the way the patient, once you start the rehabilitation, how the motor function slowly improve due to the plasticity which improves. And neural plasticity is something which we have shown that there is a areas which are dorsal prefrontal cortex, which is something which activate, and there are cerebral reorganization, and there is a synaptic reorganization, which is what is important. This is the comprehensive stroke care program, and I don't think many of us are really following that. There should be basic of stroke organization or stroke unit, hyperactive, hyperacute, acute surgical management, system care, rehabilitation, and then finally customize of a stroke training, local setting, SOP, etc. This is the graph which I have given you, that how each part of management is important, and it is just not the one therapy or other. Everything has to be important, including the rehabilitation, which of course is third, then going into the fifth. Stroke team has to be a multidisciplinary team, so there are multiple people who work together. The question comes when to start the therapy. Timing of therapy is always questionable, but earlier is the better. And there are animal studies which clearly show that delays are determined to recovery in the stroke. So earlier is better. How early? We start the therapy in 0 to 48 hours. So positioning in the bed on the first day, and these are some of the important position which has to be done. Therapies could be, traditional therapy, which start in the ICU, and therapy should start in the ICU. So start from the passive movements, from positioning, edge of bed, out of the bed. And table is something which is very important. All stroke unit in the ICU should have tilt table. And why? Because a patient who may not be even able to stand, but on the tilt table, here is a large intracerebral hemorrhage on day 7th has been made to stand. So from day 3 onward, once is stable, we slowly start from 30° to bring it back to the complete 180°. I give you an example that how you all would have given that this 82-year-old lady who has come with the hemiplegia, who was on clopidogrel and then she stopped in 2003. And I mind you, I'm giving you a story of 11-year-old. When I started this therapy, 11-year-old, when 90% of you did not even think about the rehabilitation at this age, 82 year, you would have said, take her home. Look at that. She came with the left-sided grade 2 power. She has acute right MCA infarct, right carotid occlusion. She has an old left MCA infarct. She has a left parietal meningioma. You can see that. And this patient was on 5th day as of the bed. She was in tilt table in ICU by 7 day. And you look at 20 days, one person support, patient walking home. 82-year-old stroke, carotid occlusion, meningioma, can still be living a leading life. And that, mind you, those days we do not have robotic and other therapy in our hospital. So criteria for mobilization of stroke patient, when to mobilize and when not to mobilize, are very clearly written. These are not to mobilize. These are the criteria. Sit out only, to mobilize, stand and walk. And these should be followed by and large for the 90% of patient. Otherwise, for 10%, you have to modify as per the patient requirement. What are the rehab methods? You have now gazettes of treatment therapy available. I do not know, many of you might not even heard the name of these techniques. And I'll name few of them, which are very simple and classical. Body supported treadmill training. This is something which improves the gait of the patient. And here is the patient with the stroke. He has a left hemiplegia. We treated him with Botox. And this treadmill picture is 2003. So this was Nair Hospital when we started a neuro rehab department OPD there. I donated the treadmill. We could not afford a body supported frame which was costing that time 10 lakh rupees. So we made this wooden frame with the help of lumbar thoracic belt which costed us 25,000 rupees. And on that, our Rachna is our physiotherapist, with the help of patient relative, we started the therapy. So mind you, 2003, in a government municipal hospital, we built up this indigenous mode to treat the patient with the for the gait training. Now we got very expensive 20 lakh, 25 lakh gait therapy for body supported. You got a lot of robots which are available now, and in India it is getting fancy. There are advantages with the robot. There are individual robots. Various kind of robots can be used. They can be for the individual joint also. And for the hand also, there are different kind of robots are available, which can be shoulder, elbow, wrist, fingers, and you can use all together. And Locomote is something which is for the gait training for both stroke as well as spinal cord injury. And there is a clear Cochrane criteria of improvement with the Locomote on the gait in the patient with both spinal traumatic brain injury and stroke. Constraint induced movement therapy. How many people you know about CIMT? One and two, and maybe three, four. So CIMT is the only therapy beside botulinum toxin which has got level 1 evidence of motor rehabilitation and improvement in motor power among all the other therapy which is available. So what you do is you are tying the normal hand of the patient with the mitt, and you use the patient's paralyzed hand 8 hours a day for every day, and that has shown a significant improvement in the EXCITE trial, which is one of the landmark trial. Earlier, they used to do it for 24 hours. Then they came out to the 6 to 8 hours, and there's a significant improvement in the motor power. Mirror therapy is something very simple, but yet we are not doing. This is very, very important for the hemi neglect. And there's a clear evidence that if this therapy is performed about 30 minutes every day for several weeks, motor function has improved and disability reduction in both subacute and chronic phase. But this has to be done along with your normal conventional therapy. Mental practice, such a simple thing. So these are like repeatedly rehearsing the patient the physical task which has to be done. We tell the patient, think about it and do it, and you will find that many times patient has some movement in the hand. I have always been doing this. Here the patient is thinking about moving the hand, and see obviously move. So this again to be done each session for 10 to 60 minutes for 3 to 10 weeks, and shown some improvement. And these are the evidence which have been shown with the mental practice for treating upper extremity deficit in upper individual with hemiplegic due to the stroke. So there are quite a few evidences. Bilateral arm training. So that's another new thing where you bilateral isokinetic training, use of mechanical or robotic devices. So what I heard yesterday, the neuron who unite, fire together, are wired together. So you make the neuron for fire together, and that's how the improvement in the other limb. Virtual reality is something which is very fancy and coming up. Padma has worked in the virtual reality. We have been doing on various parts, and there are clear Cochrane review which shows that virtual reality is good. It may be submersive or passive, depending on whether you are using the gloves or you are using without the gloves. There are different kind of virtual realities are available, and time after stroke and severity of though statistically, yet the data are not positive for the virtual reality. Repetitive transcranial magnetic stimulation, and our champion is Pawan Oja sitting here. He has the highest number of experience. He has been using it for past 3-4 years, and he can tell you more. But at least for the acute, this is something which can be used for both acute stroke and chronic stroke, and this has got significant improvement in the speech disturbance, particularly for the aphasia. You can also have transcranial direct current stimulation, where the stimulation is done directly into the brain by the current, and these are some of the new therapies which are coming up. FES is something which many of our physiotherapists has been using, where there is a electric current, and this is particularly useful for the hand function and the walking, because you can current at the time when a patient wants to do it, so you can get the extension of the wrist done. Same way you can use the current at a time when while walking patient can lift the foot and walk, those who do not have the those who have the weakness of dorsiflexion. Botulinum toxin is another one which for use for the focal spasticity post-stroke, and it has got level 1 evidence to reduce the spasticity and improve the function. So we talked about physical therapy, but what is occupation therapy? I don't. How many of you know what is OT? Who is OT? Do you know anybody knows OT? What is occupation therapist? What she does? One person. So occupation therapists are the most useful therapists because they work on your activity of daily living and hand function. So hand function is part of the occupation therapy. They are the one who are going to do the modification, like using a spoon which has to have a high handle, using a pan. So they modify the instrument which are used in day-to-day activity, and they can certainly help your patient. So OT is very, very important. Speech and language therapists, there are two kind of thing, two potential. One is assess and optimize the safe swallowing. Another is those who have a speech disturbance in the form of aphasia or dysarthria, which need to be evaluated. Very important that swallowing is being assessed in all the patients, because there is a high risk of aspiration pneumonia, and if you have a pneumonia on a patient with a stroke, there are a lot of other complications and the recovery is being delayed. So you need to prevent all those complications. And how do we do the feeding, chin down, which food to be given, solid, semi-solid, liquid, which side to be given, the oromandibular exercises, they need to be understand, and the speech therapy has to be part of your team right on the day one. And why I say about day one, because it is very important that patient is established. What we do is we just put the Ryle's tube, and at day of the discharge, we see if he can swallow. We give the water. Many times they cough, and then we say he cannot swallow. Send the patient with Ryle's tube at home without putting him on any therapeutic plan. Aphasia is something which is very important. With these are the patient where language has to be improved. There is a, like I showed you CIMT, there is a CIAT, constraint induced aphasia therapy, where you ask patient to reply to you all the time, not to nod. So every time patient has to reply, put an effort to say in the word. So that is CIAT. There are certain drugs which are useful. Memantidine is something which is useful. And as I said, Pawan might be using the RTMS in the patient with aphasia. He can tell you about the experience. Uh, and that is where TDCS and RTMS are very, very important in improving the speech disturbance with aphasia. Dysphagia rehabilitation, as I mentioned to you, serious complication, pulmonary aspiration, dehydration, and malnutrition. So this has to be evaluated. And why I said evaluated? Because we did a study, my resident during his DM did a study of all consecuting patients with a stroke and evaluated them with the swallowing assessment, our BYL NIRE assessment scale, which we have formed for the swallowing. And Out of 72 patients, he has 21 patient has a dysphagia on admission, which was ischemic in 17 patients and hemorrhagic on 4. Anterior circulation was 11 and posterior was 6. So they are the one which has persistent aphasia at the discharge. So posterior fossa is something where dysphagia persists at the time of the discharge. So 29% patient with acute stroke has dysphagia. We did not even think about this. And these are the transient, as I mentioned, is improve particularly after few days. And there's a positive correlation with severity and anatomical localization. So posterior fossa and severity of the lesion and patient with dysphagia. Those with mild to moderate dysphagia improve significantly by the time of the discharge. So these are important observations and we really need to work on that. Neuropsychologists are the one who evaluate the cognitive function, and many of the stroke patients with the advent of thrombolysis and mechanical thrombectomy, what you find that they don't have deficit, but they have the neuropsychological issue when you evaluate them. And that is where now we will see more and more of neuropsychological issue and cognitive therapy would be required. So how do they give cognitive therapy should be target non-motor impairment and new dementia, which can be seen in 10% of the cases. And therefore, they also look after for the depression, anxiety, and associated cognitive training is important, which can be started as soon as patient is ready to be discharged. So if you look at the outcome, what are the positive factor and what are the negative factor? Positive predictor are those patients who have a family support, those whose bladder comes back in 1 to 2 weeks, those whose proximal muscle recovery in 2 to 4 weeks, isolated pattern of muscle in 4 to 6 weeks, and perception is intact, motivated. So motivated patients do better, and therefore nowadays we are working on how do we do the motivational therapy in these patients of stroke. The negative are those one which I think that should have missed out. Negative are those which are depression, those whose persistent bladder involvement, persistent associated cognitive involvement. So they are the not one, and aphasia after 3 weeks and the discharge. Then question comes, what is the length of rehabilitation? This is something which is very debatable, how long to be given. The stroke should begin as soon as possible, as I mentioned to you, after the patient is established. The rehabilitation should continue till patient recover completely or come back to the stage where he was there before the stroke. That means many patients may require lifelong. Also, as the patient recovery occurs, his plan of the treatment changes. So if the upper limb has improved, the one focus on lower limb. If proximal has improved, we focus on the distal. So these plan keep on changing as per the patient need. So it is a duty of MDT to stress upon these patients. They need to come and tell that from my physiotherapy point of view, these are the difficulty, my speech therapy point of view, these are the problem, and my occupational therapy point of view, ADL, these are the issue. You need to prioritize which needs first. You have all the issues, but what should be addressed first, what should be addressed second, and what should be addressed third? This is how you need to plan. That is the reason a neurologist has to take a lead in the stroke care, not leave on the physiotherapist, because she will not think about the speech and language and swallowing therapy. She will not think about the occupation therapy because they don't work together. And therefore, it is the duty of neurologists to decide who should be the leader, who should be the first and second and third. And that's how you can get the best out of your patient disability. So stroke related disability can impact greatly on a patient quality of life and ability to live independently. Effective neuro rehab plays a central role in recovery of these patients. The nice guidelines are very much there. You can go through them. And MDT is pivotal aspect in implementing effective patient-centered therapy. There's a constant need to explore novel path and path-breaking therapies to complement or enhance the current practice. Several trials of novel therapies are underway. I've shown you a few of them, which offer great promise for the future rehab practice. However, question will remain regarding the long-term safety, clinical effect, cost to benefit ratio of many of these interventions on functional recovery. With further research, their potential usefulness in the real world will emerge. These new techniques offer great hope for the future, and thus we look forward to a new era filled with exciting time for stroke rehab, and we cannot leave our patient on just the mercy of some of the physiotherapists who are not even neuro trained. These are some of the chapters you can go through if you want to read more about the stroke rehab. And this is some book which is by the WFNR, Clinical Pathway in Stroke Rehab, which is an evidence based. There are 18 chapters. One of the chapter has been written by me along with my colleagues. So you can go through that. It gives you a comprehensive rehab approach in the patient for both motor, sensory, dysphagia, cognitive, and bladder and everything. So rehab can change the overall outcome in stroke. MDT is need of hour. You cannot treat alone. Alone physiotherapy alone or OT alone cannot be the answer. We are still at early stage in evaluating all these novel techniques for the recovery in the stroke. While many of these techniques are not practical at the present, it's likely that rigorous trial will demonstrate some are superior to current approach. Rehabilitation of stroke may be quite different in the next decade, and we should be part of it. So exciting time for the new rehabilitation treatment. And there's a textbook of neuro rehabilitation available. Those who want interested in neuro rehab can look for this book. Thank you very much.
Thank you, sir, for
I
this
think I hope that I
path-breaking.
give you 5 minutes extra for the lunch break.
Yeah, yeah, this shows your zeal and passion to help these stroke patients. Thank you for this all path-breaking Zugadu techniques, whatever you have shown, but that ultimately helps to the patient's rehabilitation. That's a
Yeah.
great work, sir. Thank you.
Thank you. I think we should break for lunch.
Thank you so much, sir. I request Dr. Anand, sir, to felicitate Dr. Nirmal Soja, sir, and Dr. Mahesh Shinde to felicitate our chairpersons. So we will take a break for lunch now, and now the time is exactly 2:38. So we will gather here at 3:10. Is that okay? So we have three interesting cases after the lunch. So please be come on time. And I request Dr. Vinayak Jatale, Dr. Vishal Gaikwad, and Dr. Ramdas Solanke to be ready with their cases.
फूल लगा दो ये वाला लगा दो बस
cases. I invite Dr. Vishal Gaikwad for the first case to be presented. I request Dr. Pawan Oja sir to come on the dais and chair the session. I request Dr. Pramod Dhonde and to come on the dais to chair the session. I request Dr. Dhananjay Khataukar sir to come on the dais to chair the session.
Good afternoon, everyone. So basically, I'll be presenting three short cases. So my mentor used to say, stroke patient saved is a family saved. So let's go into the cases directly. So basically, these are the three arrows we have. So my case one would be a case of thrombolysis where I just use a tenecteplase. Case two would be a case of lysis with followed by mechanical thrombectomy. And case three was a rescue stenting in case of acute stroke. So first case, this gentleman was a 60-year-old male. He presented with acute onset right upper limb and lower limb weakness, and he was unable to speak since last 2 hours. So is a known case of diabetes mellitus, which was a precipitating factor along with age. His NIHSS was 7. Comprehension was affected. Broca's was there. He had global aphasia, and power in right upper limb and lower limb was 3/5. So if you see, though the NHS was low, but the area involved is a eloquent area. So that's why we did flare and everything. Flare was absolutely negative because it just 2 hours. And in SWI, you can see the thrombus. So this is how the thrombus looks in SWI. In angio, you can definitely see that there is definite paucity in this particular area. Even here also, there is a paucity of vessels. So we decided to take a decision of clot lysis because basically this is a case of MEVO. This is a case of medium vessel involvement. So thrombolysis was done with a dose of 0.25 mg per kg. As usual, we monitored his BP, neurological status was monitored. And after 6 hours, we repeated the MRI and this was the picture. So the positive vessel has completely gone. One, the inferior branch is completely opened. And this was the DWI. To our surprise, even the DWI reversal was there and thrombus of this vessel particularly is gone. So that is how a thrombolysis very well works in a case of MEVO. So these are the things that happened. One, DWI reversal, clot was completely lysed in Swan image and vessel was recanalized and he went home with NHS 1 walking. So that was a case of MEVO where lysis works very beautifully. Then there will be another case, case 2. This gentleman was a 55-year-old male with no known comorbidities, presented with acute onset left upper limb and lower limb weakness along with altered sensorium. He presented to me at 1 p.m. As a time of onset. He had 3 to 4 episodes of vomiting also. He had a stroke. Time of onset was 1 and he presented to me at 3:30. On presentation, he was drowsy. He was following verbal command occasionally. There was no left upper limb and lower limb movement. NHS was 18. So obviously, urgent MRI brain stroke protocol was advised. At 4 p.m., we finished his MRI. So there was a large right MCA territory infarct and right intracranial IC was not utilized. As patient is definitely irritable, so it was not possible to complete the study. But this is what we could do. So in DWI, the large core is basically there. But the difference is this is not a settled infarct. So if you see, this is typically a salt pepper appearance of the DWI image and which these patients usually have a good outcome. This was the angio. So this is the lacerum segment. So above lacerum segment, there was no ICA. So as usual, as per the guidelines, we started the drip with 10 replays, 0.25 mg per kg, which was given at 4 p.m. Patient needed immediate intubation as he was drowsy. One second, he needed airway protection because he had already 3 episodes of vomiting, and again post lysis also he had 2 episodes of vomiting. So I had a fear probably that he must have developed hemorrhage. But as I repeated MRI after intubation under proper sedation, so there were even significant MRI changes just after 45 minutes of the lysis. One vessel was still occluded, but it was occluded now beyond distal M1. So I explained mechanical thrombectomy to the patient. This was the DWI. Just so the first DWI and this WI, there is a definite difference. One, Second, this is the clot that we can see in the GRE image, and this is a rotated image. So you can see that ICA is still occluded beyond supraclinoid to the proximal M1 region. So obviously we did tenetiplase, we have given tenetiplase, it is definitely costly injection. So for mechanical thrombectomy, relatives had a pending decision till 6 p.m. But they finally decided that we should go for mechanical thrombectomy. And at 6:30 p.m. he was in the cath lab. So in the first shoot, patient had a mild atherosclerotic disease in the cervical ICA, and there was complete thrombotic occlusion of the right M1 of MCA. The good part is it is in the distal part. So the best part about this patient was the thrombus has lies. It has now stuck up into the M1, but it was distal to the temporal branch, one, and second, it is distal to the lenticulostriate arteries. So whatever supply he was getting, he was basically surviving on the pile collaterals, and probably that's why till 6 p.m. also he was comparatively doing good. So for this patient, I needed 2 passes to achieve the TK3 level of recanalization. And these are the red thrombus that were retrieved while the recanalization. This was my final result. So vessel was completely opened. So even post opening, now there are multiple things. Overnight BP monitoring and pulses monitoring was done because I have given thrombolysis to the patient, tenetiplase was given. So BP was strictly monitored to be 120 to 130 with a low dose of Lobet, and even sedation was given because he was irritable. Even muscle relaxant were also needed SOS in the night. But second day, the MRI was literally wow. So this was the MRI. So the infected area and the penumbra part. So you can understand that penumbra was much part was saved, and the vessel is now completely open. That is the best part about this patient. So clinically, as with tapered midas, patient became conscious after 4 hours. He was extubated the next day 6 p.m. He had eyelid opening apraxia, and it lasted for around 24 hours, and he had left upper limb and lower limb weakness of 3/5. After 34 hours, after 36 hours, patient became conscious following verbal commands. Verbalization was very good because it was the right side. Apraxia also improved. Left upper limb, lower limb was 4 minus by 5. On discharge on day 5, NIHSS was just 2. He was walking without support, and this was the CT scan. So CT scan is just showing subtle infarct in the insular region and certain cortical infarcts. So this is the best result which we could achieve after the first DWI that we saw. And this was the patient on the day of discharge. Happy patient. So, so this case basically suggests that in cases of MEVO, what we require sometimes is lysis is more than enough. But in cases of LVO, sometimes tenetiplase followed by mechanical thrombectomy or mechanical thrombectomy directly would be essential in certain patients. The next case is very peculiar and unique cases. I recently presented this case in SNVACon also. So this patient was came into OPD of Anand sir. He was Mr. ABC, presented with transient episodes of right upper limb and lower limb weakness with slurring of space since last 2 weeks. And his episodes actually were increased in frequency since last 2 days. That's why he presented to the OPD. There was no past history of hypertension, diabetes, or any heart ailments. On examination, when he came to OPD, he came literally walking. He had just naming difficulty. Right upper limb frontal drift was present. Gait tandem were absolutely normal. Plantar was right extensor. So the first MRI which did, it showed left MCA territory patchy infarcts, mainly in the caudate and lacunar infarcts in the periventricular region, and left ICA was not visualized. So considering complete thrombotic occlusion, we thought that let us go with DAPT symptomatic management and let us increase his BP to a further level. So this was the first MRI. As you can see, there is a caudate infarct, there is a periventricular and CR infarct, coronary artery infarct. But after admission, now he started deteriorating. That he had recurrent episodes of right upper limb and lower limb weakness, and those were very frequent now. And he literally developed 4 minus by 5 weakness with anomia. The peculiarity was his symptoms were mainly in the sitting position, and they used to get better in supine position. That actually suggests that there was a definite postural variation to it, and postural variation suggests basically hypoperfusion. In second MRI, that's why we repeated a second MRI. The infarcts were increased mainly in the basal ganglia and periventricular region, and there was evolution of the caudate infarct, and this was the MRI. So as you can see, the infarct, definitely the size has increased. There is a multiplicity of infarct, multiple infarcts now there in the periventricular region and coronary data region. So considering a rapid worsening of his symptoms despite DAPT plus Clexane plus BP within a range of 140 to 150 and MAP of 100, so we planned that we should go for DSA, that just check is there any complete thrombotic occlusion or not. So DSA we did, there was a complete thrombotic occlusion of supraclinoid segment of the left ICA. Left MCA was feeling sluggishly through right ICA via ACOM, but there was very much critical narrowing of M1 segment of left MCA at its junction with ICA. So this was the angio. As you can see, the ICA was feeling sluggishly till the supraclinoid region. Patient was irritable, was deteriorating. Complete thrombotic occlusion. And this was the right ICA shoot basically. So as you can see, there's a severe narrowing. So this was the picture. Complete thrombotic occlusion here, not significant supply from posterior circulation. And here there is a very severe and critical narrowing as seen from the right ICA. So plan was to take puncture from both the femoral arteries. From right femoral puncture, basically we took neuron max along with CAT5, and CAT5 was put in cavernous segment of the left ICA. From left femoral artery, we took 125 for the roadmap, and the 3 mm segment from the atherosclerotic narrowing to the T junction was a blind pass with a traxus wire, and the stent to use was Onyx 2.5 with 18 mm. It was a drug eluting stent. That is how it was done. You can see that this is the CAT5. The wire is going blindly, and this was the shoot from the opposite side of right ICA, and we're trying to negotiate wire into the MCA. This is the CAT5, offset is over it, and ultimately we pass the wire into the opposite segment into the M1, and then the stent was placed, and this was the picture. So MCA was completely open. AP view, MCA was completely open. So our catheter was in right ICA. So we took shoot for the left ACA. Left ACA was feeling beautifully from the opposite side, and MCA with stent was feeling beautifully from this side. So day 2, he was extubated. He was conscious, following verbal command, but power was still 0/5. Broca's aphasia was present. In third imaging, it was miraculous. Left ICA flow was established with patent stent. There were no fresh infarcts. So this was the CT scan, and this is a stent artifact actually. This is a stent artifact, and vessel was completely opened. On day 5, he was conscious. Broca's was improved. Power was 4-5 in right upper limb and lower limb, and he was able to walk with support. And this is the video which relative sent to me after 1 week of discharge, when he first started his job after 15 days of illness. A happy moment for family. So conclusion from all these cases is stroke is very dynamic disease. Strategy has to be tailor-made depending upon the time of presentation of patient and the vessel that is involved. Rescue stenting can be done during acute cases in certain patient, and delayed rescue stenting can be done if the symptoms of hypoperfusion are persistent despite optimum medical management. So on the eve of Guru Purnima, I thank Dr. Sagarok sir and Dr. Anandalukar sir for teaching me, and I happy Guru Purnima to everyone. Thank you. Raj.
We have more cases, no? Yeah. So nicely presented cases obviously shows the entire spectrum of the thing, that medium vessel occlusion. So that is an important burning topic that is coming up, whether to do an intervention in them also, or just thrombolysis will be good enough. And rescue stenting again, this is also an interesting and important topic. Good outcomes. Congratulations. Yeah.
This vessel wall imaging after thrombolysis, when do you recommend to do, at what point of time?
What we used to follow basically, we used to repeat not after thrombolysis or after mechanical thrombectomy, we used to repeat just a CT scan basically. That's it. In this particular patient, last patient basically, so he was developing repeated symptoms, and hypoperfusion symptoms were there. So that's why we repeated another MRI angio after 6 hours. That's it. Otherwise, we don't do MR angio after 6 hours. We just repeat a CT, a plain CT, and after 24 hours, another CT. That's it.
Because of the clinical deterioration, you have done that scan.
Just because of clinical deterioration basically, because earlier the first angio was, there was like cone like narrowing in the cervical region. So there was a doubt, there was a small doubt that probably this vessel is open, but MR angio was showing that it is completely closed, as because it's a top image. So that is how we usually see. Even on DSA also, there was complete occlusion beyond supraclinoid. But this case was discussed with multiple interventionists, Anand sir, Sagar sir, Dr. Lati sir, multiple Anand, Soni sir, multiple people were involved because this was a like a VIP case one, and the second, opening a CTO is again not in the guidelines, at least in neurology. So similar case was presented recently conducted SNV Icon. Similar case was presented by resident of Dr. Vikram Buded sir. So they also performed similar case. So probably like what I personally believe is we are 5 to 10 years behind the cardiologists, but ultimately probably we are going to land up into same territory as the cardiologists are going.
Congratulations. Thank you.
Thank you, sir.
Good afternoon, everyone. Thank you, ISA and API, for giving me an opportunity to present a case. So, this presentation is for our fellow physicians, fellow and senior physician who can benefit from our knowledge and apply at their center, empowering the stroke care in our region. So that is the main purpose of my presentation also. So, starting with my point, these are my mentors who used to say, be bold in stroke, many brains will be saved. So, in any stroke case, you have to be bold. There are two prejudices for stroke. कि thrombolysis की या bleeding का risk है. So, as discussed by Nirmal sir, only if there is a PH2, then you have to be afraid of it. And second is financial. Now, there are some government scheme which finances stroke thrombolysis, which I will tell you a few points. So, okay. So this is a saying which says many people go to their graves with the music still in them. That we have a dream, but we are able to achieve it. So anybody anonymous said many individual brain get discharged from hospital without getting thrombolized. So that is the thing when we go to a peripheral center, we give a opinion for stroke, but we see that the advantage of thrombolysis was not available. So coming to my case, 31-year-old male, Dharmaraj Pathade, he's a carpenter, he's a chronic alcoholic. As per father, he was a nuisance to the family. Daily alcohol intake and smoking. He has index event. He presented with multiple episodes of seizure on 10th May at 2 a.m. He had his friend's marriage. 2 days there was binge alcohol intake, and he had this uh, traveling and all for 2 days. In summer there was loud sound, and he had seizure at 2 a.m. Within 86 minutes he reached our hospital, but he had significant past history. Past history was that at the age of 17, he had his first left hemiparesis. And as usual, he was managed at Puntamba. He was given some medication and he told he had seizures. And he was on Tegretol for 1 year. Then he became alcoholic. He had recurrent focal seizures, post-stroke seizures that were also focal at the age of 20. At the age of 22, he stopped his medication. He was symptomatic for 10 years. There was significant headache with alcoholism, which started at the age 29. Again, he had a seizure or a stroke, which he again got treated at Puntamba in March 23, 2 months before he came to us. And he was told to take glucosprin, but he never took it. And then he presented to us with status epilepticus. So at presentation to casualty, he was completely comatose. He was E1, V1, M2. Pupils were equal. Dolce was responding. There was minimal extensor to pain, responding to all four limbs. His BP was 150/90, pulse was 110, and there were significant ectopics. So imaging was done NCCT at the emergency. Door to CT was 35 minutes, and that was normal actually. We can see there was a slight amount of gliosis near the caudate nucleus of the right side, which explained previous ischemic events. So there was no improvement in the morning. Then he was referred to a neurologist. So MRI was done at morning 11 a.m. Door to MRI was 8 hours. So then we went ahead with MRIs. We showed some bad news and a good news. Bad news was that there was bilateral MCA territory involvement. As we can see, there was diffusion restriction in uh, MCA territory, and there was some amount of penumbra was left. As well as there was on left MC also, there is some infarct. So this was a bad case for us. Uh, this one, sir, yes, AC also. It was a bilateral territory. Good thing was that the T2 didn't show that there was infarcted that has occurred. It only ischemic event that is presented. Again, angio showed that there was a complete loss of flow in the M1 segment. So M1 was completely blocked in this case. Until then, 9 hours has passed, and lab report showed he had dyslipidemia, as well as the ECG showed that there was LV. In favor, ischemic changes had happened initially also. There was QS complex in 2-3 AVF, and there was LV dysfunction. So he also gave a history of headache, which I told, and that was migrainous in nature. I hope that is audible. I will go ahead. He had this hemicranial throbbing headache. There was no aura, exacerbated by fasting and stress, and this headache used to get relieved with eating or with analgesics. So this significant evidence of migraine before stroke again come to a question whether migraine is related to stroke. So what challenges we faced that 9 hours has passed stroke. So patient was out of window for thrombolysis. There was a bilateral pathology as well as the financial issue as he was a carpenter. So we made him explain the patient and the family member that there is financial constraint around 3 lakhs that we told him that will be required at our setup. But considering his other comorbidities, that there will be a decompression that will be required if it doesn't go thrombectomy. There will be prolonged ICU stay, and as the pathology is bilateral, he will have quadriplegia for most of his time. So finally, family member agreed to undergo intervention. So these are the thrombectomy. Now, as we also have Dr. Pranav Manjari, he's a radiologist doing thrombectomy. There was thrombectomy was successful in right MCA territory. This clot were removed, and post-op CT is this. So in post-op CT, we were able to save some amount of penumbra other than core. And this was day 7 post procedure. Cardiac arrhythmia, sir, because there was pinch alcohol intake and ectopics were present at the presentation to the hospital. So, no, sir, at that time, echo didn't show any clot. So, post procedure, he still was quadriplegic, power was 2/5 in the limbs. He was severely weak, but he was under close follow-up. He is a young onset stroke with post-stroke seizure, bilateral MCT infarct, which is cardioembolic, with cardiac arrhythmia, secondary possibly to binge alcohol intake, which we further worked up. Holter was normal later on, and he had migraine and post-thrombectomy right MCA. 1 year later, to find out any cause for his bilateral pathology, we did CT angiogram, but that was also normal. So there was nothing like moya or any other structural defect causing patient bilateral MCA infarct. And now 1 year follow-up, there was no further event. He is on regular anticoagulation. Now he is able to work in his own farm. He has impaired fine activities of his right left arm. Otherwise, no other issues, no headache, and on regular medication. So challenges we had was financial constraint, and that we overcome with the help of counseling and explaining the risk benefit analysis. We tried to find out some other cause for his bilateral pathology, but workup didn't show any pathology. I have one more case, sir. 5 minutes.
It's an interesting case, bilateral infarcts. So
Yes, sir.
two things come to my mind. I'm sure you would have thought about it also. One is a patent foramen oval. So you can do a bubble study with echo or a TE
Okay, sir.
bubble study.
Okay.
because young individual Pascal score is like, high here.
Yes, sir.
And second, also in these kind of patients when you have headache, so basically even PFO, a lot of them have migraines.
Okay, sir.
And the headache that you can connect with the strokes is APLA syndrome. So antiphospholipid antibody profile,
Yes.
not just the APLA that we do, if we send APLA, there is, long some 12 antibody test, it's called as a APLA profile.
Yes, sir.
So that can come positive. Third, I agree with you saying that it's like a holiday heart syndrome. But generally in the holiday heart syndrome, your echo will show hypocontractility.
Okay, sir.
So it's very, very unlikely that, all the entire clot from the left atrium would have gone. So the way you connect alcohol with this is probably holiday heart syndrome, but that you didn't show any evidence. So my two, because the post care also has been very good. So he doesn't have any disease that will come so frequently, like, any vasculitis or anything like this. So APLA and PFO. So that these are the two thoughts.
Yes. Just 1 minute, sir. Yes, sir. We had post CT angio, means he somehow managed money for his CT angio that we did, but we had planned autoimmune profile, sir. So apply is the one we will do sir later on. So I will go ahead with second case. It's a short case. He's a 83-year-old male, non-hypertensive. He was on regular medications, but on inquiry we found out that even on regular medication, his BP was within 150 to 170 heart rate. So most of the patients says they have a on regular medication, but it's very necessary that they get regularly checked, and it's target to around 130 to 140. He presented with left-sided weakness of duration 25 minutes. Presented to the casualty. He was conscious. Power of right upper limb, lower limb was 0 by 5. NHS was 14 and this was his MRI. So in MRI, diffusion showed a slight left cortical cortical restrictions. Otherwise, T2 and flare were normal. Sorry. So BP was 160, 110 and presentation within less than 30 minutes. So MRI didn't show any major diffusion changes also. And T2 was also normal. So we went ahead with thrombolysis of this patient. So we had an advantage in this case that we have best use of time and we were able to follow all protocol. So as thrombolysis with 10 active place, a total 15 mg dose. In our hospital, we have strict protocol that we use a wide bore needle in a brachial vein and as bolus and strict hourly charting of NIHS, GCS, BP and pupils. So this was our, this is the chart that we prepared in this stroke management. His onset was 13:20 and he reached in 27 minutes to us. And door to visit, door to examination completed was 34 minutes, was 77 minutes. Door to imaging was 14 minutes and door to needle we achieved was total 18 minutes. So we in our protocol we also write contraindication in hand. We write contraindication by hand so that we don't miss any much important points, and that is signed by intensivist and consultant, and counseling is done by a treating consultant and signed in their present. So this is the protocol we followed, and we achieved a door to needle time of 18 minutes in this case. So post procedure NCCT didn't show any bleed. NHS at presentation was 14, which decreased to 3 on day 2, and by day 3 it was 1. And MRS stroke MRS scale was 0.83. So, point of emphasis in our stroke center is that we need to follow this chart. We need to do 15-minute charting for first hour, half hour charting for 2 hours, and hourly charting for 24 hours. This Our prejudices of brain bleed, which can occur maximum in first 9 hours, can be decreased with help of discharge. And and we have been successful in thrombolizing 15 patients in last 1 year at our center. So this was the patient, and his son-in-law is our RMO. So we were, because of their concern, and we have a stroke team which is always on their toes if any stroke patient comes. So take home message is all eligible patient can benefit from thrombolysis. Proper counseling and availability of intervention always helps. In government scheme, most of the physician ask on all peripheral visit, is there any help? Because in Maharashtra there is a full Yojana, but most of the physician doesn't know that stroke thrombolysis is covered at the cost of 1 lakh. And any BPL patient can benefit from full Yojana because thrombolytic agent cost around 35,000. So they can always benefit, and time is brain as always. Thank you.
So, great case again, and all credit to your entire team. It is no one man's job, obviously, and to achieve that kind of a door to needle time, uh, congratulations to you and your team. 18 minutes is good. Yeah, thank you. So, just one comment I want to make, like regarding this door to needle time. So, we had one patient who we achieved a door to needle time of 9 minutes because the patient was sitting in cardiologist chamber and he got stroke over there. Cardiologist himself got the patient down in CT scan. We all moved in CT scan. Code white was announced in hospital. So we, because it is there, I think that because the patient was already inside the door, not outside the door. So technically it was not a door to needle. So sometimes, God is kind, and we cut whenever we have less than 30 minutes of door to needle time, we cut a cake just to celebrate everyone. So team is motivated. Yeah. A small cake, you can get from Manjini's brand. I am not promoting any brand. I am just saying that is the cheapest cake around. Good.
Good afternoon. I have one case of elective CABG in the patients of stroke and bilateral symptomatic ICA disease. So the patient was 58-year-old male diabetic patient. He was businessman. He had sudden onset weakness of right upper limb and right lower limb 1 day prior to admission at our center. On admission, he was conscious, oriented. Only deficit was mild dysarthria, mild right facial weakness, and right upper limb and right mild weakness, distal, mainly distal weakness. So his MRI DWI images showed right MCA territory infarct and right right ACA territory infarct also. This was his MR angiogram. There was intracranial angiogram showed complete absence of flow in intracranial left ICA, and cervical portion showed on left side there was complete cutoff from the just after the bifurcation left ICA, and on right side just after the bifurcation there was a tight stenosis in the right ICA. Eventually, we treated him with dual antiplatelet and LMWH for 5 days, and we did DSA. So this was his DSA images. Left ICA, there was complete cutoff, absence of flow just after bifurcation, uh, and intracranial part also was not visualized. The right ICA was there was a tight stenosis just after the origin. Intracranial part was also good, and right MC was feeling better. But left right right AC was also feeling well, but there was not cross flow. Left MCA was not feeling. Posterior circulation was normal. Left vertebral, right vertebral, and basilar formation was normal. And during routine workup, we did ECG, which was almost normal, but echo showed depressed LV function. Ejection fraction was 35, and there was inferolateral hypokinesia. At the time of DSA only, he underwent CAG, which showed triple vessel disease, and consultant cardiologist advised elective CABG for him patient. So we had a patient who admitted for the stroke, acute ischemic stroke with severe bilateral ICA disease and severe coronary artery disease, triple vessel disease, and who recommendation was the elective CABG for him. So we made a plan, medical management, and followed by right ICA angioplasty, interval angioplasty after 2 weeks, and CABG after interval of 3 to 6 months. We decided to go for right angioplasty because the left ICA was completely occluded, and whatever in anterior circulation we had was only right ICA. So during immediate follow-up, after just 2 days after the discharge, his actual stay was 8 days. He had a slight worsening. He had transient weakness in right upper limb and right lower limb, which recovered, but he developed aphasia. Mainly it was motor aphasia. He comprehension was totally intact, and he used to speak in the words, not able to complete the sentences. And 2 weeks after the follow-up, when we called him for the angioplasty, we did MRI screening. It was showing hemorrhagic transformation. So this was CT also was showing hemorrhagic transformation. So we postponed plan for a while because of risk of hemorrhagic transformation if we go for angioplasty immediately. So the stroke onset was in the May end, 20 May, and eventually he underwent the right ICA angioplasty in the end of the July after almost 2 months. So this was the previous image, and this was the post-plasty result. Intracranial MCA feeling also improved. And during this procedure, we took the shoots on left ICA. During this 2 months, the left ICA was opened slightly. There was some flow. Just after the origin, we can see here, which was absent previously. And intracranial part also was showing some flow. So what we decided next was, as there is a flow established in the left ICA during these 2 months, so we offered relative left ICA angioplasty attempt. Considering that it may not succeed and there is a risk of reperfusion injury. There was a only thin channel, so we may not be able to pass the wire and do the balloon and put the stent. So we counseled him that we may not succeed. And second risk was the risk of reperfusion injury, as MRI was GRE sequence was still showing the blooming. So relative took some time and they then agreed for the left IC angioplasty. So we did it in the month of September. So this was the lesion on the left side. This is the post-plasty result, ICA cervical segment, intracranial part, and left MCS filling was established completely, left ACA. So this was the final result after left ICA angioplasty. Eventually, the patient underwent CABG in the month of December, and procedure was uneventful without any perioperative or postoperative stroke. So we did review of literature for this case. The risk of stroke after CABG or perioperative stroke within 1 month of the CABG is varies from studies to study from 0 to 5.2, and this result varies because of the study design, patient profile risk, operative techniques, and the length of the study during which observations of the stroke are made. Uh, Over the periods, these operative techniques have improved, but the perioperative stroke after CABG remains still high, mostly because the elderly and elderly patient are undergoing CABG. These are the pathophysiological mechanisms of the stroke, mainly cerebral embolism, hypoperfusion, panvascular inflammation, and chronic atrial fibrillation. And there were many attempts to calculate the risk of perioperative stroke in patient undergoing CABG. These are some scores, mainly include age, diabetes mellitus, depressed cellular function, female gender, then urgency or priority of the surgery, renal dysfunction, and presence of peripheral vascular diseases. If you see carefully, these are only systemic risk factor. As the imaging modality is improved, the local risk factor like the percentage of the carotid artery disease, these are becoming significant. And as the percentage of the carotid stenosis increases, the risk of perioperative stroke increases. As the disease become from unilateral to bilateral, severity also increases. So our case was the severe symptomatic bilateral ICS stenosis, and in which we did carotid angioplasty and followed by interval CABG. So this is the literature supporting our case. If if there is a history of patient undergoing elective CABG, if he is having history of stroke, consider delaying the elective surgery at least for 6 months and preferably 9 months from the time of onset of stroke, and consider the revascularization first. And if the disease is bilateral, even ipsilateral hemodynamic symptoms in the setting of the ipsilateral ICA total occlusion, which was our case, and contralateral ICA stenosis may benefit from revascularization to ameliorate the hemodynamic insufficiency. So this was the exactly our case, which had stroke on left side with left ICA total occlusion and severe stenosis on right side, in which we revascularization did on right side, contralateral side. Some more literature supporting the carotid revascularization prior to the CABG and electively deferring the CABG for 3 months to 6 months and preferably till the 9 months. So take home message is patient undergoing CABG should be assessed for the risk of perioperative stroke, and symptomatic carotid artery disease should be addressed first. And if possible, CABG should be deferred electively till 6 months or 9 months. Thank you.
Thank you, sir, for the beautiful two presentations. Thank you for also elaborating the beautiful brain and heart interdialogue, and how to risk stratify patients who are supposed to undergo CABG and keeping in mind their stroke profile risk. Thank you very much.
Two very important points you brought out. There are two different situations. One is when your patient is for bypass and he has some carotid stenosis. Now that's a different scenario completely altogether. And all of us will get references for this. That this fellow is having a 50%, 60%, 80%, 90% stenosis. Is he fit for that bypass? So yeah, absolutely. So and the second situation, obviously, that you have stroke on one side and an asymptomatic artery on the other side. So very well done. Congratulations.
Thank you.
I request Dr. Vishal Vinayak and I request Dr. Madhusudan Tapadia to felicitate chairperson.
We would like to felicitate Mr. Prashant on MCure, who has been partner for all this program, and this has been wonderfully done. I hope Arvind comes by now.
Hello. So we have been into, active into stroke space, but the kind of vibrancy we are seeing, in Indian Stroke Association and giving us opportunity to partner for Mission Brain Attack is really wonderful. And the kind of initiative which Indian Stroke Association has given and chosen us as partner for this, we are assuring, sir, that no, we are going to really take it forward. And all three initiatives which you have undertaken, the partnership with QI to really expand the stroke care infrastructure with really accredited centers network to be expanded. The each one teach one initiative by which the layman will get educated about stroke signs, symptoms, and they will be reaching out to stroke ready hospital faster will surely help us. And the third is about partnering with consulting physician and their knowledge, and in their respective hospitals, if they need to establish the stroke infrastructure, we'll be more than happy to partner with all such hospitals. So we take this opportunity, sir, at MCure to thank Indian Stroke Association for giving us this opportunity to be a partner with them for this. Thank you very much, sir.
Thank you, Prashant and MCure. And I would like to thank on behalf of Indian Stroke Association to all the delegates, faculty, and the API of uh, Aurangabad. Thank you very much for being part, and all the neurologists who are here, who participated in the program, EC members, Dr. Pawan, Dr. Amit Kulkarni, Dr. Shripal, and all the other members and neurologists who participated in this. And I think we are going good across India. The way we are moving for last 4 zones, it's really very good. And it is a wonderful interactive program. And at last, we'll thank MCure for partnering this in the stroke accreditation. Those who want to apply their center for advanced stroke center, they can directly apply to the QI for their centers. Vishal has already spoken that, right? Pandurang can do that, and it will be great. And thank you everyone to be here. And on behalf of Indian Stroke Association, as a secretary, I thank you all. Thank you.
So thank you very much all dignitaries who are physically present here and 850 doctors, those who have joined us virtually from across India. We formally conclude the session and we invite all of you to please join us for high tea organized here. Thank you very much, sir.